Ladies and gentlemen, a very good morning to all of you. I warmly welcome you to the International Conference on Medical Sciences 2023. In a world that is constantly evolving, the medical field has faced a multitude of challenges throughout the past couple of years, highlighting the need within all of us to develop resilience, explore the power of remediation, and the art of reinvention in healthcare.
The International Conference on Medical Sciences is an annual conference organized by the Faculty of Medical Sciences, University of Sri Jayawardenepura, which is currently in its 16th iteration. We are also pleased to have the newly formed Faculty of Dental Sciences of the University of Sri Jayawardenepura collaborating with us on a symposium. We look forward to the participation of academics, researchers, medical, dental and allied health professionals, postgraduate trainees, and undergraduate students at today's conference.
Ladies and gentlemen, before we begin, I'd like to remind you that the book of proceedings containing the abstracts is available via QR code at the registration desk.
Ladies and gentlemen, let us now commence the oral communication sessions. I invite Professor Renu Wickramasinghe and Professor Savithri Wimalasekara to chair the session.
Good morning, everybody, and welcome to the first session on oral presentations. It's my pleasure to introduce the first oral presentation for the day, Association of Tumor Binding and Clinicopathological Characteristics in Colorectal Cancer from 4 tertiary care centers in Sri Lanka. The authors are Koskallana, Vijaythunga S, Malaviyarachchi SL, Kumarasinghe I, Ratnayaka P, Ranatunga KC, Kandegedara SL, Gamage BD, Prathapan S, and Prematilaka IV. I think you have 8 minutes for presentation. The timer is on the right-hand side of the screen. And at 8 minutes, please do stop. And we have 2 minutes of questions. The light will come on at the end of 8 minutes. So please do stick to time. Good luck. Dr. Koskallana EW will present.
Good morning, everyone. I'm Varuni Koskallana from the Department of Anatomy, Faculty of Medicine, University of Peradeniya. I'm currently reading for my MPhil on colorectal cancer. And today I'm going to present to you my findings on the association of tumor budding and clinicopathological characteristics in colorectal cancer. Tumor budding is defined as single tumor cells or clusters of up to 4 cells within the tumor or at the invasive front. It was first described in the cancer of the lip in 1920 and first described in colorectal cancer in 1989. Here you can see 2 pictures side by side. In the first one, you can see the dark purple stained ones are the tumor cells. Let me point it out. Tumor cells, these are the tumor cells, and you can see a clear margin. And in the second image, you can see the dark purple stained cells scattered here and there. They are the tumor buds. Here, at a higher magnification, at the tumor margin, you can see highlighted in red circles the tumor buds of about 2 to 3 cells. According to the International Tumor Budding Consensus Conference of 2016, they said that tumor budding is an independent predictor of lymph node metastasis in stage 1, that is the stage 1 colorectal cancer, and an independent predictor of survival in stage 2 colorectal cancer. However, this should be considered along with other clinicopathological features in a multidisciplinary setting. In our study, we looked at the association of tumor budding with the following characteristics: the T, N and M stages, the invasive front, the lymphovascular invasion, percentage of tumor infiltrating lymphocytes, and the intensity of peritumoral inflammatory reaction. Considering a previous study in Sri Lanka, which was a single center study done on 58 samples, they have found out tumor budding to have an association with poor differentiation, lymph nodal involvement, and tumor recurrence. We looked at the histology of 77 colon dissection specimens from these 4 centers and assessed them for tumor budding according to the ITBCC 2016 recommendations. Accordingly, we select the H&E slide, that is the tumor slide with the greatest degree of tumor budding, scan at medium power and identify a hotspot, that is an area with the highest number of tumor buds as shown in the dotted red circles in the first image. Then we use a 20 objective lens and count the tumor buds in that hotspot. In the second image, circled in red are the tumor buds. Finally, we correct it to an area of 0.785 square millimeters for consistency. As the eyepiece field diameter varies from microscope to microscope, we use a normalization factor to correct it, and using the following equation, we can make it consistent for an area of 0.785 square millimeters. We had a slightly higher percentage of women, that is 56%, and our ages range from 35 to 83 years, and most of them were between the ages of 60 and 70 years. Tumor budding was present in 53 of the 77 specimens, that is 68.9, and of these, peritumoral budding, that is at the tumor front, were seen in 68%, and intertumoral budding, that is within the tumor only, were seen in 2%. And both were seen in 30% of these 53 specimens. Here we compare the presence of tumor budding in neoadjuvant treated cases versus those without prior treatment. As can be expected, there was a higher number of tumor buds in untreated cases. However, this difference was not statistically significant, but as our sample size gets larger, we might expect it to reach a higher significance level. In this table, we look at the factors we look to be associated with tumor budding. The 3 factors we found to have an association were T-stage, infiltrative tumor front, and the presence of lymphovascular invasion. Although the other factors did not show a significant association, we found a weak inverse relationship with the tumor infiltrating lymphocyte percentage, that is the TIL percentage. And a previous study by Gonzalez et al. 2021, they found a significant inverse relationship between these 2 factors. Ours also might change as our sample size increases. So, in conclusion, tumor budding was significantly associated with the T stage, the infiltrative tumor front as can be expected, and the lymphovascular invasion. This brings us to the question whether tumor budding marks the beginning of lymphovascular invasion. In previous studies, it has been associated with epithelial mesenchymal transition. That is a feature of cells, tumor cells undergoing metastasis, that is breaking off from the tumor. When considering previous studies done on the T, N and M stages associated with tumor budding, the previous study in Sri Lanka found tumor budding to have an association with lymph nodal involvement. Then a study in Germany showed it to have an association with N stage also in addition to T stage and as in ours. A study in Turkey looked only for N stage compared to our study, but they did not find a significant association. So, just to tell about the clinical implications, tumor budding has been mentioned as an independent adverse prognostic factor in colorectal cancer, and it is also included in the RC-PATH dataset. And various studies, there are multiple studies telling that the tumor budding is associated with increased risk of recurrence and mortality in colorectal cancer. In our study, we look at tumor budding and its associated various clinical pathological features in our populations in Sri Lanka. And in the future, it may become an essential component of the histopathological assessment of colorectal cancer with therapeutic and prognostic importance. I would like to acknowledge my supervisors, collaborators from all 4 centers, all patients and healthcare workers contributing to this information. Ethical approval was obtained from the Ethical Clearance Committee, Faculty of Medical Sciences. Administrative clearance from all four centers and Ministry of Health was received. Financial support was by the University Research Grant, University of Sri Jayawardhanapura. These are my references, the main references. Thank you very much for listening, and I'm open to any questions. Yes.
Tumor budding has been considered as an independent prognostic factor by the Tumor Budding Consensus Conference.
Yes, madam.
Has it been included in the TNM staging of colorectal cancer?
It is considered to be included in the latest one, madam.
What is the edition?
Eighth
Well, I
one.
haven't, not in a,
The ninth, sorry, madam, ninth one.
it is included.
Yes, it is. It was included.
Right. You also mentioned about peritumoral and intratumoral budding.
Yes,
Did
madam.
you see any significant association, a change in the p-value between these two, or you lump together and study both together, peritumoral and intratumoral budding?
For the presence, I checked them differently, but with the other factors in this study for this abstract, they were lumped together, intertumoral and peritumoral and both.
Yes.
Those three categories, peritumoral, intertumoral and both are lumped together when checking for the association with the other factors. But I have to mention this is an interim study. We are still in ongoing study. So we can look at other associations and compare different things in the future also, madam. For
One
this,
last question.
Yes, madam.
The T stage is different. You know, it goes in colorectal cancer from T1 to T4.
Yes, madam.
Again, did you study separately the tumor budding in T1, T2, T3? Because I didn't see a breakdown.
Yes, madam. In the table, I used the rank biserial coefficient because I looked at the T stage as a ordinal variable T1, T2, T3, T4. I looked at that variation and its association with tumor presence and tumor absence.
Yeah, that chart is not here, no?
No, yeah, wasn't-
Thank you very much. It was an interesting paper. Over to you, Ray.
The second presentation for today is impact of microlearning on academic performance of students in higher education in theoretical examination, a systemic review and meta-analysis. The presenters the authors are V.V. Senadira, D.S. Edirivira and T.P. Rupasinghe. Over to you, Ms. Senadira.
Good morning to all. I'm India Senadira. The topic of my presentation is Impact of Microlearning on Academic Performance of Higher Education Students in Theoretical Examinations, a Systematic Review and Meta-Analysis. The students in current higher education are digital natives. They use technology in every aspect of their life, including their education. Therefore, to cater this technology-enhanced learning in the current learners, the university teachers are redesigning traditional teaching and learning using innovative pedagogies. These innovative pedagogies are aimed to be suitable for current learners, and they are explored in current research. Microlearning is one such innovative pedagogy, which is the process of learning through small-sized, well-planned learning units and short-term learning activities. Each microlearning unit is aimed to designed to achieve a single learning objective, and the format of the microlearning can be diverse and depends upon the intended learning objective. The literature reports the benefits of microlearning as enhanced motivation to learn, increased confidence in learning, increased task-based performance, and also it has been identified as a suitable instructional strategy for the current learners due to their reduced attention span. Though there are previous qualitative assessments reviews regarding these benefits of microlearning, to date there is no quantitative synthesis of evidence of impact of microlearning on academic performance. Therefore, this review aimed to answer the question, does microlearning significantly improve academic performance of higher education students in theoretical examinations compared to traditional learning? We used the Prisma guideline and 10 databases were searched and study selection was conducted using the Covidence platform and research conducted on microlearning in higher education in which the academic performance in theoretical examinations in microlearning method was evaluated quantitatively and compared with traditional learning and which were reported in English language were used in this review. We used RevMan 5.4 software for the meta-analysis and studies that have presented complete outcome data on academic performance of students in theoretical examinations were included in the meta-analysis, and we used the Cochrane's risk of bias tool to assess the risk of bias of these studies. This is the study flow chart. At the end of the screening, we used 12 studies for the systematic review and 5 for the meta-analysis. These 12 studies were published from 2014 to 2022, and research came from 8 countries, and total of 1,177 students were included in these studies. This is the risk of bias assessment. And the meta-analysis showed a higher academic performance in students learned using microlearning compared to students learned using traditional learning. The overall mean difference in academic performance in relation to post-test scores in theoretical examinations between microlearning and traditional learning group was 12.6. This is the forest plot comparison. The higher academic performance through microlearning has been achieved by the positive effects of microlearning, such as ability to learn through short and concise learning content, providing flexible learning environment, engaging in self-directed learning, and receiving timely feedback. The cognitive load theory explains that the capacity of the human brain to process information is limited. The human brain tends to retain more information when the content is structured in small pieces. Therefore, presenting the content as separate elements can decrease the cognitive load and thereby increase the retention. Moreover, according to Ebbinghaus' forgetting curve, the memory or the retention of learning weaken over time. By repetitively reviewing what we learn, we can reduce the rate at which we forget. The small and concise microlearning content in the microlearning courses have facilitated the students to go through the content, watch and replay the micro videos any number of times they needed and review. Microlearning affords anytime, anywhere learning. Students can go over only the part that is unclear to them without having to go over the long lessons all over again. The students could go through the exact micro content they want to revisit in order to achieve the intended learning outcome. This flexibility might have motivated the students to learn. The students in current higher education are adult learners. The analogical model of learning presented by Malcolm Knowles explains that adult learners have a self-concept of being responsible for their own decisions, for their own lives, and for their own learning. In microlearning courses, in the included studies, students were required to go through the learning content by themselves. This goes along with how they learn as adults. And at the end of each micro content, the students were required to answer a set of questions to make sure that they have achieved the intended learning objective. As soon as they answer the questions, they were given a feedback whether that answer is correct or wrong. Through timely feedback in microlearning courses, students have got the opportunity to make sure they have achieved the learning objective. But there are some factors that can mitigate the effectiveness of microlearning, such as lack of motivation of the learner for self-learning, content fragmentation, and technological barriers such as poor internet connection or unavailability of technological device. Therefore, to effectively achieve positive attributes of microlearning, Teachers should consider learning needs of their students as adult learners, design microlearning content that are of appropriate size for the cognitive processing, and microlearning object should be linked to the relevant learning objective and accessible through multiple devices and platforms. In conclusion, we can say that microlearning can contribute to a substantial increase in academic performance of students compared to traditional learning by reducing cognitive load, providing flexible learning, promoting self-directed learning, and providing timely feedback. Designing the microlearning lessons according to the adult learning principles can further enhance this positive impact. These are my references. Thank you.
Thank you. Thank you very much for the very interesting presentation, a timely one, I think. Are there any questions from the audience? Judges? Yes, Isha.
Just want to know, in the studies that you looked at, what were the courses alike, or were they like vastly different, like, medicine and arts and whatever?
Yeah, the studies included came from different disciplines, madam, not from one discipline, different disciplines. Yes, madam, 8 different countries.
Can I just find out about the duration of each of these micro-learning activities? Because, I mean, there can be vast differences in the time duration that is spent
Yeah.
on learning, and then it might have an impact on the results of the studies as well.
Yes, madam. They have actually tried to at least deliver one module, one course to compare the effects of this microlearning and traditional learning. One group has gone through traditional learning for the same module, while the other group has
No,
gone.
what I want to know is the duration of time that is allocated for each of these micro-learning activities. Does it vary between each of them, and
Yes, madam. Now,
range? If
mostly 1 credit courses, that means 15 hours, or 2 credit courses, not beyond that.
Okay.
That is the limit.
Thank
Yeah.
Yeah, that's
Well, madam,
yeah.
now here we tried to do a meta-analysis for these practical examinations as well, but only one study has presented the complete outcome data. The impact, the outcome means this with the standard deviations and all. But 4 studies have compared with the practical and impact of microlearning in practical examinations as well, and they have found out higher performance in microlearning in practicals as well, but we cannot do a meta-analysis for that because of incomplete outcome data.
Okay. Thank you. Thank you very much. We'll go on to the next presentation. Thanks
Thank
a
you.
lot.
The third session for this morning is on molecular-based detection of pathogenic and intermediary pathogenic leptospira from the kidneys of swines watered from human consumption in Kegol district, Sri Lanka. The authors are Ratnayaka Vijaykumaran, Senaratna Bandara, Karunadasa Muthusingha, Ruwan Patiranage, Koizumi, and Gamage. Over to you, Dr. Ratnayaka, for presentation.
Good morning, everyone. I'm Nipun Ratnayaka. On behalf of my team, I'm here to present molecular-based detection of pathogenic and intermediately pathogenic leptospira species from the kidneys of swine slaughtered for human consumption in Kegol district, Sri Lanka. First of all, I would like to give you a brief introduction. What is leptospirosis? Leptospirosis is a zoonotic disease caused by pathogenic spirochete bacterium belongs to genus Leptospira. These pathogens enter to the reservoir animal through the mucous membrane or the damaged skin and migrate to the kidney via bloodstream and colonize in the proximal renal tubules. chronically infected carriers excrete these pathogens in their urine for extended period of time, which plays a crucial role of leptospirosis epidemiology. First, in Sri Lanka, first human case was reported in 1953, and ever since, cases of leptospirosis has been reported all over the country. Leptospira species can be classified into three subclades: P1, P2, and S, which means pathogenic, intermediately pathogenic, and saprophytics. Several pathogenic and intermediately pathogenic species have been isolated in Sri Lanka. In this slide, you can see the geographical distribution of leptospirosis in Sri Lanka. In last 3 years, highest number of cases were reported from Sabaragamuwa province, Sri Lanka, which consists of 2 districts, Ratnapura and Kegol. Kegol is where we are focusing on this study as well. There are vast range of reservoir animals for leptospirosis. In previous studies, researchers have demonstrated small mammals like rodents, dogs, elephants, cattle, and buffaloes are acting as carriers for leptospirosis. In this study, we are focusing on swine. When you are moving to the methodology, these are the main steps we followed. In the sample collection, we collected swine kidney tissue samples from the local butcher shops and the slaughterhouses in Kegol district. Written consent was obtained from those places, and data such as collection date, location of the farm, and origin of the animal were collected. DNA was extracted from those tissue samples using DNA sol reagent according to the manufacturer's instructions, and extracted DNA was subjected to the conventional PCR targeting FLAB gene, which means flagellin protein subunit B, and the positives and negatives were identified by agarose gel electrophoresis. The positive PCR positive applicants were subjected to the sequencing for identification of the species, and phylogenetic analysis was done by using the sequences obtained. These are the main 2 sets of primers we used: PFLAB and IFLAB. IFLAB for the detection of PFLAB for the detection of pathogenic or P1 subclade species, and IFLAB for the detection of intermediately pathogenic or P2 subclade species. When you are moving to the results, 7 samples out of 76 samples were positive for PCR in total. Out of those 7 positives, 3 were positive for PFLAB PCR, and the infected species was identified as Leptospira interrogans by sequencing, and other 4 samples were positive for IFLAB PCR, and the infected species was identified as Leptospira liseraceae. In the figure 5, you can see the phylogenetic tree. When you are considering the history of these positives, majority of the positives, 5 out of 7 of positives, were originated from single farm in Kegol district, which is a commercial scale farm which consists of their own farm, slaughterhouse, and butcher shop, and they are distributing meat to some other butcher shops, hotels, and restaurants as well. Other 2 positives were originated from small scale domestic or backyard farms in Kegol district. Based on the results of the nested PCR, in total 9.21% of the samples were found to have leptospira colonization in their kidneys, which suggests that these swine could act as carriers for leptospirosis. When we are focusing on the infected species, Leptospira interrogans and liseraceae, both of these species have been identified in numerous similar investigation on swine all over the world, and in Sri Lanka, Leptospira interrogans have been detected in dogs, elephants, and livestock animals such as cattle and buffaloes. Leptospira liseraceae have been detected in dogs in Sri Lanka. In this slide, in figure 6, you can see the potential risk associated with the infected swine and the potential direct and indirect modes of transmission of Leptospira species among other animals and humans. In the sample collection, we observed wastewaterways of the farms are not properly built, and domestic and wild animals have access to them. And also, meat cleaning water and slaughtered swine parts are dumped into the waterways, which can contaminate the environment directly. And also, in the slaughterhouses and the butcher shops, poor sanitary practices and inadequate use of personal protective equipment were observed in raw meat handling personnel, which may be due to lack of knowledge and awareness about the disease. According to the findings of the study, we can conclude that farm swine in Kegol district are chronically infected with medically important leptospira species, posing a direct threat to associated workers, while other farm-associated animals and people living in the proximity to the farms are at a risk of acquiring infection. And also, this study points out the importance of the investigating possible carrier animals to have a comprehensive picture of leptospirosis epidemiology in Sri Lanka and to address the knowledge gaps in the public on leptospirosis. Awareness programs targeting the individuals connected to the piggery industry and related sectors are also important. These are the limitations we had. I would like to be thankful to all the owners and the workers of all the farms, slaughterhouses, and butcher shops contributed in the study, and the staff of Department of Microbiology, Faculty of Medicine, University of Peradeniya. These are the key references we used. Thank you so much.
Thank you. The paper is open for discussion. Can I just ask under what temperatures do leptospira finally die? Because food is not consumed raw. So, I mean, if you cook, I think you get rid of the organism.
Yeah, leptospira can survive in the body temperatures, but when we cook the meat, they will die.
Yeah.
But the risk is on the raw meat handling
the
personnel,
handlers,
the workers, or
that's
may, yeah.
Okay, thank you. Sahat.
Any other questions?
Are there recorded ones of the people who are handling meat getting infected more than the ones who come in from the community? That's the other. I've no awareness about contamination like that.
You're asking about consuming community?
Yeah.
I think no, ma'am.
Consuming as well as people handling the swine
We
in
have
the
to
farms,
do that,
exactly. Yeah.
You have to do that in the future. Yeah.
Go into that, yeah, in detail. Yeah. Any other?
Farms that you did this. Yeah. Did you sample like the kidneys in almost all the farms, or how did you select the farms in the Kegol district?
Yeah, we collected samples from the swine originated in Kegol district. We exclude other samples in this study. We have done in some other areas as well. We are going to publish that together.
No, Kegol district might have a lot of farms, I guess.
Yeah.
Okay, right.
So who identified the kidney tissue was identified in the slaughterhouse and taken to a lab?
In the sample collection, we went to the slaughterhouses and
picked the kidneys
yes.
and transported in the
Yes.
correct media. Okay.
Thank you very much.
Thank you so much.
Okay, the fourth presentation for this morning is, are we giving enough attention to young people with diabetes? A preliminary analysis of the multi-center database for patients with young onset diabetes in Sri Lanka. The group is STREP-D's research group, Sri Lanka College of Endocrinologists.
Good morning. I'm Dr. Umesha Vijayanayaka, and my oral presentation today is on, are we giving enough attention to young patients with diabetes, a preliminary analysis of the multi-center database for patients with young onset diabetes in Sri Lanka, conducted by the STEP-D research team of the Sri Lanka College of Endocrinologists. The prevalence of young onset diabetes is in the rise globally, and type 1 diabetes is the commonest cause worldwide for this disease entity. However, with the upsurge of obesity, there's a dramatic rise in type 2 diabetes among adolescents, especially in this part of the world. Unfortunately, epidemiological data of young onset diabetes in Sri Lanka is yet to be established, and the International Diabetes Federation has an estimation that the annual incidence of type 1 diabetes in Sri Lanka would be somewhere around 1 in 100,000 of children less than 15 years, based on the data published from India. So we identified this as a significant research gap with regard to young onset diabetes, and we planned our study to obtain data regarding the disease burden, characteristics, and state of current care with regard to the disease in order to streamline the resource allocation as well as develop care strategies within the college. So this was a retrospective multi-center study which was conducted in between April 2021 to February 2023. All diabetes clinics led by consultant endocrinologists and consultant pediatric endocrinologists were invited to enter pre-specified patients' data into the cloud-based database of young onset diabetes in Sri Lanka, which is DIOD-SL. The patients were diagnosed based on American Diabetes Associated standards of care, and the subtypes were classified according to a clinical criteria because of the unavailability of advanced investigations to subtype the diseases. Patients who were diagnosed before 25 years were included in the study, and gestational diabetes mellitus patients were excluded. The ethical approval was obtained for the database was obtained from the Ethics Review Committee of the Faculty of Medical Sciences, University of Sri Jayawardhanapura. So the study was conducted in 27 hospital-based centers, out of which 26 were adult diabetes clinics and 1 pediatric diabetic clinic from the Colombo district were included in the study. The preliminary analysis included 1,939 patients, of which the majority were females, similar to Indian data. However, in the global young onset diabetes population, majority were males. Looking into the socio-demographic characteristics, the median age of the study population was 20 years, while the age at diagnosis was 15 years, and the median BMI was 20.67. So we often use age at diagnosis, the age or the BMI, and the presence or absence of family history to differentiate between type 1 and type 2 diabetes. So when we looked into this data, yes, type 1 diabetes patients were younger. They had a comparatively lower BMI, which was statistically significant, and a higher proportion of patients with type 2 diabetes had a positive family history. But interestingly, 41.7% of the patients with type 1 diabetes also had a positive family history. So the commonest etiology for young onset diabetes was type 1 diabetes in our group of patients, and 33.9% had type 2 diabetes, and 3.7% and 2.1% had type 3C diabetes or pancreatic diabetes, and maturity onset diabetes of young or MODY based on clinical criteria in our study. So looking into the regional prevalence, Colombo district had the highest prevalence of young onset diabetes, followed by Badulla, Kurunagala, Kandy, and Ratnapura districts. So the distribution of patients according to the subtype, in younger age groups, type 1 diabetes was more prevalent, whereas in 20 to 21 age group, it was type 2 diabetes which was more prevalent. So to establish the diagnosis of type 1 diabetes, ideally, antibody testing should be done before 2 years of diagnosis. But in our group, we were only able to perform this antibody testing in 5.7% of the group. And interestingly, 26.5% of them had negative antibody results, which consolidates the fact that negative antibodies do not exclude type 1 diabetes. And previously, Professor Katulanda has demonstrated that there's a low prevalence of anti-JAD antibody in Sri Lankan population as well in 2008. So the glycemic control was not ideal. Median HbA1c was 9.6. In type 1 diabetes, it was higher. And we looked into the fact whether there's an association between the age and glycemic control years in patients who were less than 15 years, had a higher percentage of HbA1c more than 9 in comparison to patients who are more than 15 years. And also, only 14.1% of the study population was on the ideal treatment regime, which was the basal bolus insulin regime with self-titration. And looking into the disease-related complications, retinopathy was statistically significant and higher among type 1 diabetes patients, whereas nephropathy, neuropathy, and macrovascular complications did not demonstrate a statistical significance among two types. So we concluded that type 1 diabetes is the commonest subtype among Sri Lankans, young onset diabetes Sri Lankans in the hospital-based database. Age at the diagnosis was significantly lower in type 1 diabetes. Overall glycemic control was poor, and it was poorer among younger patients. And this is important in developing care strategies and pathways to lessen the long-term morbidity and mortality. This was a nationwide database providing a good coverage and insight to the young onset diabetes profile in Sri Lanka, which was instrumental in distributing the resource allocations through Sri Lanka College of Endocrinologists. But this was a predominantly state-sector hospital-based study conducted in specialized diabetic clinics, which tend to attract more patients with type 1 diabetes who needs intensive treatment regimes. We did not include private sector clinics, general medical clinics in hospitals, as well as primary care setup, which would more likely to attract more type 2 diabetes patients who need less intensive treatment regime. So, therefore, this might not be the ideal representation of type 2 diabetes in young onset diabetes population of Sri Lanka. And also, there was a lesser participation by the pediatric diabetes centers of the country, which do follow up a large cohort of adolescents with young onset diabetes in Sri Lanka. So that sums up my presentation, and thank you very much.
The paper is open for discussion. Any questions?
What a percentage goes to the pediatric and what a percentage is followed at your this thing?
Usually pediatric endocrine centers, we don't have data available, but there's a significant proportion of patients less than 16 years who are followed up at these clinics. In fact, the largest clinic, which was conducted in the Colombo Lady Ridgeway Hospital, was one of the clinics participated in the study, but the other clinic did not.
They participated?
One clinic participated. So there might be a discrepancy in that regard, yes.
Patients would be treated pediatric practice at Lady Ridgeway Hospital, so
yes.
I think you may have captured.
Once they are transitioned to the adult clinics only, we do follow up these patients. But we have now the database, currently there are more than 2,000 patients up to now we are following up.
Can I make a comment? Yes. Actually, what is the remedial measures for these children? Because, I mean, this is a disaster. Our children are getting badly affected.
Yes.
And, I mean, are the clinics seriously considering something for these? Because this is a lifetime problem of diabetes, which is going to affect their entire life.
Yes, Madam, even we were alarmed with the HbA1c.
Yeah, that's the thing. The glycemic control is so poor as well.
Yes, there are several treatment regimes. The ideal treatment regime, which is practiced in other part of the world, would be the insulin pumps, which is not available in our setup.
Yeah.
Then the next best thing would be basal prandial insulin with self-titration, which they have to titrate according to the meals they are consuming. For this, of course, we need resources. Right now, with this data, we are providing resources for the diabetes clinics. But once again, this needs much of contribution from the patient as well as the family also to follow up this.
That's right.
Yeah.
Right. Thanks.
Any other questions? Okay. Thank you.
Thank you very much.
The next paper is on platelet to lymphocyte ratio, a novel marker for severity prediction in chronic kidney disease. The authors are Azra MF, Astra MHF, Nifla S, Brahma RT, and Karunata S R from the Faculty of Allied Health Sciences, University of Jaffna. Dr. Azra will present.
Good morning, everyone. I am Fatima Azra, medical laboratory science student from University of Jaffna. My topic on today's presentation is platelet to lymphocyte ratio, a novel marker for severity prediction in chronic kidney disease. Chronic kidney disease is highly prevalent all over the world. In Sri Lanka, it is highly prevalent in northern, eastern, and central part of the country, particularly the northern part, mainly because of the drinking water contamination by heavy metals and agrochemicals. There are several other factors that etiological factors that also can cause chronic kidney disease. However, regardless of the underlying cause, chronic kidney disease is a progressive disease. It will lead to end stage. It will lead to end stage, end up in the renal failure, which increase the clinical and economic burden to the patients. So, the early detection, screening, and disease monitoring is important to prevent the disease progression towards the end stage. So the proteinuria, which is the hallmark of the chronic kidney disease, itself it is associated with disease progression and inflammation. So measuring the protein concentration in the urine can directly reflect the disease conditions. So assessing the proteinuria in CKD patients is helpful for the diagnosis and monitoring of the disease. There are some methods used in the clinical laboratories to assess the proteinuria, like 24-hour urine protein creatinine concentration, 24-hour urine protein concentration, urine protein creatinine ratio, urine albumin creatinine ratio, and dipstick method. But generally in clinical laboratories, they are using the urine protein creatinine ratio. Even though it has advantages, it also has some drawbacks. Like it may cause inconvenience to the patient during the sample collection and instability of the results, and also there are several methods to detect the protein concentration and creatinine concentration. So reports from the different laboratories cannot be compared for monitoring purposes. Therefore, physician need to rely on the report which is obtained from the single laboratory under same analytical conditions. So it is difficult to use the proteinuria as an independent marker to assess the kidney disease progressions. Therefore, finding a new diagnostic marker is important. It is helpful for the patient as well as for the clinicians. According to literature, CKD is also an inflammatory disease where the inflammatory markers are highly elevated even at the earlier stages. So, recent studies proved that measuring the inflammatory markers can provide the better information about the kidney disease. There are a wide variety of inflammatory markers. The traditional markers are like interleukin 6, tumor necrotic factor alpha, interleukin 12, CRP and all. But the platelet lymphocyte ratio, which is a novel inflammatory marker that can be obtainable from the routine full blood count. So it is inexpensive, readily available, widely available, and we can easily perform. Even without an automated analyzer, we can perform by manual method. So we aim to find the correlation between proteinuria and platelet lymphocyte ratio in different stages of chronic kidney disease patients. So our objectives were to determine the EGFR and classify the CKD patients, and to determine the PLR and proteinuria in CKD patients, and finally to determine the correlation between PLR and proteinuria. to achieve our objective, we recruited 85 CKD patients from who were attending the nephrology clinic teaching hospital Jaffna by random sampling technique after the careful evaluation of inclusion and exclusion criteria. And then after obtaining their informed consent, we extracted some data like demographic data, clinical data, drug prescription and all. Then using their serum creatinine value, we calculated their EGFR value using the CKD-AP formula and classified this participant into CKD stages. And then from each patient, we collected both random urine sample and EDTA blood. From the urine sample, we performed the urine protein estimation and urine creatinine estimation. From the obtained values, we calculated the urine protein creatinine ratio. And similarly, from the blood, we performed the differential count, WBC count, and platelet count. From the obtained values, we calculated the platelet lymphocyte ratio. And after tabulating all the data in SPSS software, we perform the statistical analysis. As you all can see, we have observed male predominance with mean age of 58, and most of the patients were presented with multiple comorbidity condition, and also some of the patients were consuming ACE inhibitors and ARB medications. And after stage classification also we performed the statistical analysis, and we have also analyzed the association among groups in terms of these parameters. To our surprise, we also found a significant association among groups in terms of serum creatinine, EGFR, UPCR, lymphocyte count, platelet count, and for PLR. Particularly, the inflammatory markers like UPCR and PLR were increased from stage 2 to stage 4. That demonstrate that the intensity of the inflammation increases as the disease progresses towards the end-stage renal disease. And in the correlation analysis for overall participant, we obtain a strong positive correlation between UPCR and PLR, but for the stage-wise correlation analysis, we observed a positive correlation only for stage 3A, 3B, and stage 4. But for stage 2, we observed a negative correlation, maybe due to smallest number of sample in stage 2, and also the majority of the patients in stage 2 were consuming ACE inhibitors and ARB medications, which has effect against the nephropathy. So the proteinuria will get less. Since the PLR showed positive correlation with proteinuria in different stages of CKD patients, we concluded that PLR can be used as a novel predictive marker to detect the severity of chronic kidney disease and monitor the disease progression. However, we didn't find the cutoff value in each stages, so we recommend future studies to perform larger cohort studies with multi-center sample and with a different population to evaluate the applicability of this PLR model. Thank you.
The paper is open for discussion. Thank you. Interesting.
Had your results with similar studies, and was it the same? The PLR correlation
yes, ma'am.
with, was it
Same.
same results?
Yes.
In other parts of the world?
Only one study has been conducted in Turkey. It was same results.
Only one study with regard to PLR and the...
With PLR, only one study.
With repeated measures on the same patient, do you get the same correlation? Now you might have in stage 1, stage 2, etc. you get a negative correlation, but with stage 3 and advancing disease, you kept on maintaining a positive correlation. So if you follow up the same patient as it progresses through renal disease, if you can establish a serial correlation, then I mean all the other negative factors of the same patient will be avoided. So I think a longitudinal study would be useful.
Yes.
And it's a nice paper. Thank you.
Okay, thank you. Let's get on to the final presentation for this morning. Little Eaters, Big Impact. Preliminary findings on food group patterns and minimum dietary diversity in early childhood in selected MOH areas in Colombo district. The authors are Ma Patunage TK, Senivi Vikrama KLM, Hettiarachiri UPK, Anusha K, and Lienage G. The paper will be presented by Ma Patunage TK.
Good morning. I'm Thiranima Partner. I stand before you today to present the preliminary findings of food groups patterns and minimum dietary diversity in early childhood in selected MOH areas in Colombo district. So, as you all know, proper nutrition is crucial for healthy growth and development of young children. The consumption of dietary food will help for infants to prevent from chronic diseases, to prevent from micronutrient deficiencies, and to prevent from stunting and underweight. And also, it is important for the linear growth of children. However, we face significant obstacles when we come to ensure this minimum dietary diversified food, especially in resource-limited city. So, what is this minimum dietary diversity? According to the World Health Organization, minimum dietary diversity is defined as consumption of at least 5 out of 8 defined food groups. In future slides, I will present you what are these 8 food groups. So, according to the previous literature, in Sri Lanka, it is mentioned as the dietary diversity of children under 5 years remains low. And there were notable lack of comprehensive research in Sri Lanka, and the results also yield inconsistent results. So that we explore the dietary diversity of children aged 6 to 12 months in Colombo district. To conduct our study, we use descriptive cross-sectional approach in Colombo district at Child Welfare Clinic. And we recruit 98 samples from 6 to 12 months age. As sampling technique, we use stratified random sampling. So in our sample, as inclusion criteria, we recruited age between 6 to 12 month infant who do not affect any complications such as suffering from chronic acute illness within 2 weeks before the enrollment, and who affect with severe bony abnormalities and chronic diseases, and also we exclude premature babies. So as the data collection tool, we use pre-piloted questionnaire, which is an interview-administered questionnaire. Actually, this is an ongoing study. From the interview-administered questionnaire, we use two sections, section 1 and section 2. For the as socio-demographic factors, we measured gender, economic factors, ethnicity, the birth order, and so on. And for as dietary habit, we take the data of 24-hour dietary recall. So, as according to the World Health Organization classification of infant and young child feeding guideline, these are the 8 food groups. They are breast milk, grains, roots, tubers, it's a one category, and pulses, dairy product, flesh foods, eggs, vitamin A rich fruits and other fruits and vegetables. The minimum dietary diversity means consumption of 5 out of these 8 defined food groups. So, as a statistical tool, we use social science statistical software version 22 to analyze our data, and we use descriptive analysis. So the results we obtain are both enlightening and concerning. The mean age of our study population is 8 months, and we see a relative normal distribution among male and female. But surprisingly, we found that only 48% of children in Colombo district only fulfill this minimal dietary diversity. That means half of the infants do not consume dietary food in this MOH area in Colombo district. So when we examine the specific food groups, we see that the mostly common food groups were breast milk, grains, and vitamin A rich fruits. But we found some alarming statistics as well, because legumes and nuts, which is more rich in essential nutrients and protein, only consume 57.1%, and flesh food, which is more rich in iron, which is a good source of iron, only consume 44.9%, and eggs, which is a reference protein, is only consume 14.3%. So I want, from this table, I want to show you some researchers available studies done in Sri Lanka. In there, you can see, in our current finding, the minimum diversity is 48. But compared to our studies, other percentage of minimum diversity high, but it can be due to the age variance. We only take 6 to 12 months. Others, the age, there's age variance in other studies. But when we consider about this food group 3, food group 5, and food group 6, which are legumes, fresh food, and eggs, the overall percentage of all those studies is low. So when we consider about other countries, in Bangladesh, the minimum dietary diversity is same as the in present study, and Nepal and Zambia, it's lower than, the percentage is lower than our study. So with all of these findings, I would like to conclude that the minimum dietary diversity remains less than 50% in early childhood in Colombo district, and the food consumption of foods such as legumes and nuts, fresh foods, eggs, the consumption is low in this population. So I would like to recommend that there must be more research on dietary diversity of infants and in other districts too, as a representative sample of Sri Lanka, and they must have improved public health strategies and enhance public health strategies such as community programs, and we have to enhance some understanding about health impact of mothers, and we have to tailor interventions and inform guidelines for policymakers. I think it's neat. So I would like to thank all the mothers and caregivers who participated for this research, and university research grant for funding for this research. So these are my references. Thank you.
Thank you. The paper is open for discussion. Can I ask you a question?
Yes, ma'am.
Why do you think the consumption is less? Why is it 48% in our population?
Madam, it can be due to the economic crisis in
When was this study done?
From this 23rd January to June.
This year?
Yes, madam.
Okay. So any other reason other than the economic problems?
Madam, actually, we didn't do any cross tabs.
You didn't interview the parents to see why the consumption was less?
No, madam.
That you have selected?
Yes,
is
madam.
it one MOH area or several?
Several, madam.
Okay. So what was the education that was given by the MOH or the midwives in these areas? Did you look into that regarding the dietary, the diversity?
Yes, madam. They have some nutrition programs also conducted by midwives. There are some sessions.
Did you check whether these mothers have participated in those programs? And
no, madam.
You didn't look into that?
No, madam.
Have there been any previous studies done in these areas where?
Yes, madam. There's a study done in Colombo district.
Okay.
But the age group is 6 to 23 months. But sometimes our presentation is low because we only consider about 6 to 12 months. After 1 year, after 12 months, the consumption of diversified is more.
Exactly, yeah. That's
in infants. Sometimes it may be a reason, madam.
Exactly, yeah.
In
That's what I'm
12 to
trying to
23 months, they consume more variety of foods.
In Sri Lanka, ages from 6 months to 12 years, children, aren't they given breast milk most of the time rather than
Yes,
any other
madam.
kind of food.
Yes, madam.
Yeah.
So-
Did you check on that as well?
Yeah.
Because some of the mothers are feeding, I mean, continuously feeding on breast
Yeah,
milk rather
exactly.
than
Yeah,
the
giving anything
Yes,
else.
madam.
food. So that
The mothers are more prominent to give breast milk with
Yeah.
the demand of child, because
Yeah.
most of the children don't like to have complementary food. The,
Yeah, and also I think the CHDR also gives an account of
yes,
the
madam.
food
They have nicely given the recommendations.
recommendations for
Yes.
each age, right?
Yes, madam.
So did you? I think it's better for you to check on those aspects
yes.
also, whether they have
Absolutely.
gone through this, and that's
Absolutely, madam.
Yeah.
Any other questions?
Yes, I think you should continue and try to include the causes for the lower percentage. It
Yes,
will
madam,
be a very
yes.
interesting paper in our context.
Yes, madam. Yes.
Thank you.
Thank you very much.
Thank you. That brings an end to the oral presentations this morning. Everybody kept to time, and I think we have finished about 15 minutes early. I would like to thank all the presenters and the audience for some interesting questions. Thank you.
Thank you.
Thank you, ladies and gentlemen. That was a wonderful presentation session. I would like to thank the speakers again, as well as our chairpersons for their wonderful commitment. Thank you, Professor Renu Vikramasinghe and Professor Savitri Vimavadana. And again, I would like to thank the speakers for keeping up with the theme of our sessions in truly presenting their research on resilience, remediation, and reinvention. That research was oriented and focused on the theme, and we would like to thank them for an amazing presentation. Before we move on, ladies and gentlemen, we have a few housekeeping announcements today.
Yes. First of all, I'd like to kindly remind all of the members of the audience to please keep their mobiles on silent as the proceedings move on. And once again, I'd like to remind you that the book of proceedings and the abstracts are available at the registration desk, which can be accessed via a QR code. And again, during the lunch, during the breaks we'll have I'd like to invite you all to peruse through the poster presentations which are displayed outside in the corridor on the LED screens as a rotation. The poster numbers will be displayed besides the screen, and each poster will be displayed for 3 minutes before rotating to the subsequent one.
Ladies and gentlemen, before we move on, we have a small video on the history of the research committee, and I would like to invite you to take a look at it.
Ladies and gentlemen, I hope you all enjoyed that trip through memory lane I hope you all felt nostalgic as we remember our proud traditions and the legends of our faculty, who you all must remember. And
Ladies and gentlemen, we will now move on to one of the most anticipated and prestigious events of the day, the keynote address delivered by Senior Professor K.M. Nalin De Silva, who is the Chair Professor of the Department of Chemistry, University of Colombo, on Technology is Changing the Future of Healthcare.
to commence this special event, I invite the chairpersons, Senior Professor Aloka Patirana, the Dean of the Faculty of Medical Sciences, University of Sri Javanarpura, and Senior Professor Shireen Fernando, the Chair Professor of the Department of Physiology, to chair this session.
Good morning, ladies and gentlemen. I'm extremely happy to introduce our keynote speaker of the ICM 2023, Professor Nalin De Silva. He is the Chair Senior Professor of Chemistry at the University of Colombo and obtained his BSc Chemistry First Class Honours from the University of Colombo, and his PhD was from the University of Cambridge, UK. He has gained postdoctoral experiences from the Universities of Cambridge and Louisiana in USA. He has published over 100 science citation index papers and has 4 US patents. His present H-index is 32. He won the Presidential Research Award for 10 consecutive years and National Research Award presented by the NRC and the NSF of Sri Lanka. He was also named the Young Scientist of the Year, way back in 2004, by the World Academy of Science and NSF. He received the Vice Chancellor's Award for Research Excellence in 2017 and 2020. He worked as a science team leader in Sri Lanka at the Institute of Nanotechnology, SLINTech, from 2012 to 2019. He was also a member of the National Nanotechnology Committee and the chairman of the National Nanotechnology Research Panel at the NSF, and also being a member of the NSF for drafting the National Nanotechnology Policy of Sri Lanka. He also served as a chairman of the National Basic Sciences Research Committee and National Committee for Technology at the NSF. His main research focus areas are advanced material for healthcare, water purification, textiles and apparel, natural resources, and nanobiotechnology. Recently he was awarded with the most prestigious professional qualification, the Fellow of the Royal Society of Chemistry of the United Kingdom. I am deeply honored, sir, to invite you, a renowned scientist and a researcher, to deliver our keynote address of the ICM 2023, giving us an overview of how nanotechnology, AI, and robotics would influence healthcare. Thank you.
Thank you very much. Good morning. Thank you, Professor Aloka Patirana, the Dean Faculty of Medical Sciences, for giving a comprehensive introduction. And also, before I start, Dr. Varuni Tennakon for pushing me and, following me up. I was not in the country. I was in Oman. And I agreed for this presentation. And thank you again for selecting me to give this keynote address today. And given the time allocation, half an hour, I will try to stick to the time. That is very important. And also, when I came here, people asked me about the presentation, but I prefer to just speak my mind, rather than giving you the slides and, be more methodical. So you have to excuse me if I have some points, but I don't think I will need it here. Let's see how it goes. So the title, the theme of the conference, resilience, remediation, and reinvention. That's a really timely theme. I mentioned in my abstract also the which I shared with Varuni for maybe in the magazine. We have been facing this crisis, and the crisis became a real crisis last year. And as scientists, we have been, predicting this, and we have been communicating this to the higher authorities. The importance of science, technology, and medical sciences, how we can drive the economy to a better place. No country has ever developed without science, technology, which includes medical sciences, all agricultural sciences, everything. What I mean by science and technology is not only the science, the faculties of science that we do. You have a Sri Jayawardhanapura University medical faculty has strong science-based, the research programs like the Dengue Research Center and so many other things. And that results in high impact publications, and that's what I mean science, not related to the science faculty, like the technology. Now, the technology faculties, I have no any hard feeling on those things, but I have reservations of the technology that they do, because Richard Feynman in 1960s, he predicted that without a strong science background, the technology is redundant, because there's no way that you can, that we don't call that is technology. That's like the mechanical, you can train people to make things. That's not technology. Technology is where you have a strong background with science, we have the Sri Lanka has a cream, I would say, the top notch, the students. I have been teaching in Oman last semester. I'll be going back in September for another semester. Our students are so much clever. The reason is that we have a very competitive primary education and the secondary and the tertiary education. How many people come to the university? Out of which, that's my worry is, if you look at the world scenario, if you take the US now, if you take the highest income professionals in US, expatriates in US, like the Asian Americans or the British Americans, whatever, Sri Lanka plays number 3 after India and I can't remember the second country. Sri Lanka is number 3 in US. Highly paid jobs. That shows that the Sri Lankans are really clever, and wherever they go, they flourish. But unfortunately, not in this country. So the problems are, we always blame politicians, right? That's there. Now we have to see that the words resilience, remediation, reinvention, and also the role of academics, the present era, that was given in the website. And this is where we have to see what we can do within the system, while changing a paradigm shift is difficult at this moment. Because the political atmosphere, whoever comes to power, it's not congenial for science and technology. There are two sides of the story, because there is an economic recession, there is no money, and the chicken or the egg problem. We want money to do research, and they say there is no money to do research. So how can we address? The world moves in a rapid pace, that we have to understand that. Exponential, we call the technologies are disruptive technologies. the things that come out disrupt heavily. You take the mobile phone. How many industries were disrupted from this mobile phone? The camera is gone, right? When we were students, we had cameras, right? Right? But no more cameras, no more audio recorders, no more video recorders. Everything is replaced. Radios, TVs, everything replaced by the technology. So how many industries were destroyed because of the one piece of technology? That's a danger. This will it will come to everyone's profession. I would say my prediction is only the clever people can survive in this planet in the future. Elon Musk also predicted this, right? Elon Musk is a tech giant. He is now creating Neuralink and, the AI platforms, and, it's a really different scenario. The 4 technologies that will shape up the planet are biotechnology. So when it comes to the biotechnology, people think that it's a science faculty thing. It's not the science faculty thing. Biotechnology should be flourishing in medical faculties. So that means our research scope and the research, I saw nice papers, but my point of view is now the biotechnology has to come into the picture. We have medical doctors are the cream in this country. You are the high Z score and you come to that level, and, we have to have how to harness this technology. For example, now we face the COVID, right? And the Pfizer and, Sinopharm, all people develop vaccines in no time. Whether those are good or bad, we can't argue on that now, but it helped the planet to come out of this pandemic, right? So their vaccination programs within 1 year, how did they do that? My proposal, I think I wrote to the government also regarding, we have the best medical doctors in this country. And we have the best biotechnologies also in this country. We have the best scientists in this area also. Where is the problem now? Why can't we develop a vaccine in this country? That's not rocket science. There is no rocket science. If you take the Pfizer vaccine, it involves nanotechnology. There's a micelle solution, and it's basically it's a nanoemulsion. Right? Why we can't do it in this country? There is no vision for this. You can't have short-term visions for this kind of program. You have to believe in our scientists. You have to believe in our talent, and you have to put money on this. Who is going to put money? Because they say we don't have money. That's what I say. So that's a biotechnology. Then it becomes nanotechnology. Then you talk about the robotics, and you take the artificial intelligence and IoTs. Your medical profession, if you look at it now, it's becoming the technologically advanced. When you do a surgery, right? And how much technology that you use in the future. The top surgeons, top-notch doctors will have a future. Because you have to go with the technology also. But I'm just predicting some of if you are not ready to acquire the technology with the time, the lot of professions will be redundant, including doctors. Not only this, we also. Right? Because the machines will replace the man in the future. So that's a danger. Are we ready to accept that challenge? That's a sad story. Because of that's what we can't blame the people leave this country, right? I will address that separately. Leaving this country is not going to solve your problems, right? So if you look at these technologies, that will shape up the planet in next 20 years. It's really a scary situation. If you look at the ChatGPT also now giving alarming signal to the academics. Because we can't now find out whether the assignment is done by the ChatGPT or the student in the future. When you get special in medical sciences, they write, they can get a huge report on this. And so, but some other universities, they have now adapted the technology, you can find out whether this is AI generated or a man generated. Okay, so that's a problem in the future. You know, we use plagiarism software to find out people plagiarize. You know, that is already there. So if you look at the medical sciences, the nanotechnology, that's an area that we do research. Just now, I just have a profile of a scientist who is at Northwestern University. I'm just telling you his affiliations. Just to these things, not we have proposed this kind of thing. You know, multiple professor post. Right now, you are professor of surgery. If you work with me, at some point you should be able to get a professor of material science. Like me, professor of, it's not possible in this country. So for example, if you look at the Chad Merkin, he's a top scientist in the world. He's at Northwestern University. And also if you look at Rob Langer, he's at MIT. And his HNDX, he's a biomedical engineer. He has a lot of startup companies, over 100 startup companies for this professor. He's a biomedical engineer. His H-index is 168. So that shows something. He has 100 companies. He founded 100 companies. Now this Professor Chad Merkin is professor of chemistry, professor of medicine, hematology and oncology, professor of material science and engineering, professor of biomedical engineering, professor of chemical and biological engineering, director of the International Institute of Nanotechnology, Northwestern University. I just gave you one example how the planet moves. Where are we? I'm professor of chemistry forever. I retire as a professor of chemistry. Even though I do cancer research and a lot of publications on cancer research, drug delivery and so on, I can't get a title on that. I can't get another, there are multiple appointments you can get, different departments, different faculties, you have 2 professor posts. So that is where we have to move the collaborations, the sitting in now. For example, we worked with Nilika and we had a couple of good publications on our work with Nilika. That's a Faculty of Medicine, Sri Jayawardhanapura, right? So if you look at the nanotechnology is I have no time to explain the technology here, but it's simply that we work with small things. Like nano means 1 billionth of a meter. So we work with materials at that scale, 1 to 100 nanometer scale. So those materials will show immense properties. Those properties we harness that can be applied to different fields. Medicine, the other areas, agriculture, and so on and so forth. So that is where we worked at Slintech. I worked as a science team leader at Slintech. We had a good vision during 2008. It was started. It was headed by Professor Gihan Amaratunga in Slintech, and I was a science team leader. Professor Nilola Kottegode from Sri Jayawardhanapura, another senior scientist. And we had a mission. We wanted to have a strong science base first. That's the foundation. But the role of academics today, due to the pressure from the funding bodies, and we have been pushed to do some projects, give quick results. We call those are low-hanging fruits. It's good to have low-hanging fruits, but without a strong science base, it's not sustainable. I'll take one example. Faculty of Science, Columbia University, developed a bathroom cleaner, right? It's okay, right? I'm critical on these, and these are bucket chemistry we call, right? In alchemist term, these are bucket chemistry, right? But it is good for survival. It's good, and we got an income. That once they sell a bottle of this detergent or whatever cleaner, the Faculty of Science get 1 rupee. That's fantastic, right? That's good, we need it. But it's not sustainable. Where is the science that you would? You don't need any science for to do this. 3 months project, we can do this one, this thing, right? 6 months, we can do it. Where is the long goal for science and technology? These are, we call blue sky research. Every academic must have a low-hanging fruit research project and a blue sky project. That was our vision, Professor Gyan Amartunga from Cambridge. That was the vision. But the pressure came in 2019, and we were asked to make products. I had another 7 months to go. I said I can't make products, because we had 4 US patents that you mentioned, and many publications. The equation, this equation people don't understand. The Korea, I'll take one example as the South Korea. The Korea in 1970s was a poor country. GDP per capita is less than Sri Lanka GDP per capita. And then you take Singapore. Singapore GDP per capita was lower than Sri Lanka. That's why the Lee Kuan Yew came to Sri Lanka and said, I'll make Singapore like Colombo. Right? Those are the visionary leaders. Right? And Singapore National University now ranked top 15 in the world. How can they become like that in 40 years? Korea GDP per capita was $100. Now I am asking audience, a lot of students are there, maybe young doctors are there. We have to, when I do this to our science students sometimes, and I ask what is GDP per capita, and I bet many people don't know what is GDP and what is GDP per capita, right? If you look at the GDP of Sri Lanka is $89 billion. And the country that I lived last 4 months, the Oman also $89 billion. Now people understand, how can they be rich? How can we become poor? Right? We have 21 million people, they have 4 million people. So their GDP per capita is $20,000. Our GDP per capita is about $3,500. To make us happy, we can make 4,000. Okay. So that shows us where we stand. I met a Korean professor maybe some time back, and now we are talking about the government is pushing us to make more productive, money-generating research. My point is, it is not sustainable for science point of view. We have been always behind with this attitude. The reason is, the Korea is the best example that I take. The equation is, for science and technology, if you want to make a product, a vaccine or something, right? So you have to embed the technology. So to embed a technology, the best inventions yet to come. People think that some people have said, now the things have to be discovered are now discovered, nothing to discover. It's not like that. The new things that we think, they are yet to come. Right? So it can be from Sri Lanka, but where is our vision for create that budding scientists to, do work, that we as younger generation, older generations, we are responsible for not creating that atmosphere. So the equation is, when you publish 10 papers, 10 high quality papers, you end up with 1 patent. That's how we measure. Normally, a scientist, 10 papers, you get 1 patent. Either local or international law or something. Or 15 papers, 1 patent. And 10 patents, you might get 1 patent commercializable. Right? What do we expect from our NRC or NSF? They expect do 1 project, commercialize that project, right? That's the pressure that we get. Now we have, myself and my wife, we have a NRC mega grant, 50 million grant. So we have now, during these 5 years, we have come to a product development. While giving the NRC that concept under Professor, who was the former chairman, I can't remember, Janaka. Professor Janaka brought this vision, the long-term projects, like 5 years, but you need to, that's a fairly reasonable time period for a scientist to deliver something. Not like 1 year project that you expect something to be delivered, right? So then in that project, what we did was we have 3 PhDs. We have 3 PhDs. At the same time, we have a product. That's what we want to do it. So when you do a product development, there is something called the innovation death valley. So whatever you do it in the laboratory, it has to come to the market. It is not easy. If you go to Google, you will get to know about the innovation death valley, where you go from laboratory to market. Death valley means it can fall at any place, no use. You are brilliant scientist, you have a wonderful product on the bench in the laboratory, but it fails in the market. Some products fail after releasing the product to the market. That we have to, in Korean model, the government absorbed that shock initially. So the government funded those projects, blue sky projects, to develop products. After that, they slowly hand it over to the private sector. Now, what is our scenario here? We tell the private sector to come and develop the product. And we give a huge cost for them. So when our private sector also mostly buying and selling, to be honest, except the apparel industry and few things, they buy and they sell, right? So they are not ready to invest huge amount of money for science where there is no future guaranteed by scientists. As a scientist, if a product the company comes to me and asks, can you do it? I say we will try, but we have no guarantee for a particular X product in 1 year. So that shock, the government has to take that shock. But otherwise, the private sector is the all is well type of thing. You know, they bring products, they add value, they keep a margin and they sell. All are happy, right? So that is not good. That is not a healthy atmosphere for a country. So there must be a good research program in the Faculty of Medical Sciences or Faculty of Science, and there should be more cross-disciplinary projects should come out. You know, that's the only way. You don't have to reinvent the wheel. Now, when we worked it, we had to buy a flow cytometer, and all kind of things were required for our product, our project. So what we did was I explored where these are. It was with Neelika, and Neelika, we invited her, and we did a collaboration. But we never signed a MOU. This is the beauty of if you have a collaboration. It's a sometimes, you know, people are, you know, these collaborations do not bond with MOUs. I will tell you seriously. These will not be bonded with non-disclosure agreements. Okay, it's not going to work. But it's good to have a lot of MOUs for a university. But if you look at the number of MOUs in a university and how much it has gone to a productive level, I don't know. Better do a small survey and see how many things are fruitful. For example, now Neelika and that group and our group, we never signed anything. It's a pure understanding by two scientists. And she was very convinced that she can work with two of us. And that's a bond that we created. That's what we need. Another example is University College London, School of Pharmacy, ranked 8th in the world. We have now got about 10 papers, but even our university doesn't know that we are working with University College London. University College London knows, but our university doesn't know, right? But that's fine, okay? We have published a lot of papers and, you know, patents together and produced about 3 PhDs together. But, you know, my point is, you need to find out somebody who can be who can be a good collaborator for your projects. So that's a way you can embed science and technology. But you know, those are you know, more policy level decisions. You know, I would prefer it comes through the curriculum also. You know, the interfaculty involvement and so on. Like, medical faculties, have some kind of science interactions, giving the value of science, how we think, how we see. Because the scientists and the medicals see things in a different way, right? So, and we have to merge into one, and you have to move it. Vaccine development, I'll take, we do a lot of, if you look at the medical profession, sensors, therapeutics, drug delivery, tissue engineering, now you can, the Gareth Williams that we work with him in University College London School of Pharmacy, they make now artificial blood vessels. Just a technology, that technology is available in my lab. We can do it. We have proposed that. We have started working with Mandika also about these things, right? But the problem is there is no bandwidth for us to source chemicals that young doctors complain. To get a chemical, you have to wait ages, then your enthusiasm goes off. These are doable projects. The electrospinning technology, you can make blood vessels. Now, tissue engineering has developed. They make artificial organs. And the first person to use the live cells to electrospin and make organs is Professor Suvan Jayasinghe, who is a Sri Lankan, who is an engineer working with biomedical engineering in University College London Department of Engineering. He's a biomedical engineer who is dealing with live cells, electrospinning to make tissues for wounds and other things. So you can see, this is the engineering faculty I'm talking about, University College London. Right? He's a materials engineer, biomedical engineer. Another person, Professor Mohan Edrisinghe, he's also a biomedical engineer in engineering. So those people, those countries, they are moving towards that direction, but we have to take that initiative. At least if it is not policy level, we as scientists should go out and look for the opportunities, and we try to develop these things, because our doctors are clever, that we have to understand. When I work with engineers and doctors, I can give you the credit. It's easy for me, that's absolutely easy. The two best students that I had was from the engineering faculty. One is running a YouTube channel called Science with Ruchira, and you can have it. He brings the science into a different perspective. So that's a time I have, only 2 minutes left. Now I will tell you that the technologies will shape up the planet, and we have to go with the technology, and you have to upgrade your level of thinking. Otherwise, all of us will be redundant in the future, because the man will be replaced by the machines. Those days are when we were the university time, our cell phones were like, like a brick, huge. Now it has become, now the computers, desktop computers and all these things gone. Now everything you can do it in small device. So that's the technology that we are in. This disruptive technologies that will come to the planet. When you have your kids, you have to be very careful when you educate them. Make sure that they may be with the present day technologies. I have no time to talk about that, the technology addictions and so on. But another point that I want last 2 minutes to address, that we are unhappy here, right? If you talk to many people, people complain, right? My point of view is, happiness is inside you, not from outside. So you try to detach from outside. The first thing is you stop watching television, which I have done last 5 years. I have not watched television. In Facebook, I get news items. But if it is a good news item, I'll watch. If it is a bad news item, I'll skip it. And I'll unsubscribe that also. Right? Because our life, it's up to us to make us happy. Right? When you do your consultancy, when you do something, you get happiness. Because of that happiness you do. Right? Happiness will not be dependent on where you live. I have lived in Cambridge, I have lived in USA. Last 4 months I lived in Oman. All in you. As Buddhist, I have majority is Buddhist here. Life is a set of problems. Alright? you solve a different set of problems in this country. When you go to US, you solve a different set of problems. In UK, you solve another different set. The problem set is different, but you're solving a set of problems always. That is guaranteed. Right? Here you have a lot of disturbance from outside. There you don't have. I remember when I came from US, I had a complaint to one of my professors, Professor Tilakaratna. I said, sir, it's very, very frustrating when you come after your foreign stay. You get really upset about the driving and the things are not methodical. You know what he said to me? It's a nice advice. He said, Nalin, here driving is very boring. When you get into the highway, you just drive there. See the entertainment that you have in your road. Have the positive side and enjoy. So I think it's true. When you see things that in a more positive way, you don't get frustrated. Now I don't get any angry with anyone outside when I drive. Yeah, I don't care about it. Oh, that 3-wheelers cut off from here. It doesn't matter. Yeah, that's his karma. This is my karma. It's okay. Yeah, right. So, I mean, I'm not discouraging you to go for your MDs and all things, but remember that this is our country. I have started the endowment fund. I think the all faculties can start. Chemistry department, I started an endowment fund. This is what we can do. Endowment funds are the funds that you can create from the well-wishers, especially from alumni. I mean, the doctors have the best alumni, the rich alumni, you can get it. So my concept was, I have created, if you look at the Harvard endowment is 2/3 of the Sri Lankan economy. $59 billion, Harvard endowment. The Cambridge and Oxford, when you travel from Cambridge to Oxford, the lands either side belong to Cambridge and Oxford. Why? When people die, they give it to the university. Only if they see the universities or the entities are doing well. Your money is properly used. Right? So that culture we have to create. I mean, I don't understand why the medical faculties, you may be having that kind of fund, but you can create. I created that, the Chemistry Endowment Fund, 2022 March, I launched that one with a 2 million donation from alumni, 1960 alumni. And now I have, within 1 year, I have reached 7 million from our students. They are sending money now. That is a set of objectives are given, that is only to promote postgraduate research, that money. No head in the future cannot use that money unless it is clearly mentioned here. So that kind of thing we can do it to retain the brains. First time I am advertising a PhD position, fully funded, 3 years and 6 months, fully funded, 4 million PhD project, but you need to have a first class to enroll in that project. So that is it. No, not every Tom, Dick and Harry will be in. There are people who can't go to US, they come and tell us, we want to do a PhD, and sir, karamudu PhD, but not that kind of people. You have to have a top of the batch. If you want to stay in this country, we'll give money. That's the way that we can retain some brains here. I have found one person, 4 out of 4 GPA, he's ready to stay and do a PhD with us. So that's a way that we can do it. So I wish you all the very best for your all future endeavors, and make sure that you have to, if you want to develop, achieve personally everything, there is a one factor we always tell. We tell about, I do a lot of career guidance talks and so on. One factor we tell the students and anyone, give back to the society. That's the main thing. Giving back to the society means either your alma mater, it can be your university, it can be your school or whatever. Give back. If you give back that attitude, you will get a lot of blessings, because that's how the nature works. No one looks at us, but we believe that no one is looking at us, but whatever the religion, I call the nature is looking at. We are all bound to the nature's forces. So therefore, I expect all of you to give something back to the Sri Jayawardhanapura University. If you are alumni of SJP or Colombo or Jaffna or anywhere, give back something to your alma mater and give back something to the society. And again, thank you very much, Professor Aloka Pathirana, the Dean Faculty of Medical Sciences, and the other chairperson, senior professor also, and Varuni for inviting me, and the research committee for selecting me as a keynote speaker. Thank you very much for your attention.
Thank you, Professor Nalin De Silva, for that very inspiring speech and talking your heart out on technologies and improvements in health sciences. You really gave us a lot of points to think about as scientists, educators, administrators, and also human beings. Thank you very much. And now I invite Senior Professor Aloka Patirana, our Dean, to give you a token of appreciation.
Once again, I thank you, sir, for that memorable address. As Madam said, I think we all found it very inspiring and insightful.
Ladies and gentlemen, we will now be taking a small break for tea. Refreshments will be served at the back of the hall behind the screen, and we will be reconvening by 10:20 for the next symposium. Thank you very much.
Welcome back, ladies and gentlemen. We now move on to our first symposium, Building Resilience and Adapting in Crisis. This symposium will focus on how we, as medical professionals, can utilize our limited resources rationally in the current economic crisis while maintaining the quality of our healthcare system, which has stood the test of time.
We would like to invite the chairpersons, Senior Professor Surangi Asawardana, Dean of the Faculty of Dental Sciences, and Senior Professor J. Indra Kumar, Chair Professor of the Department of Medicine, on stage to conduct the symposium. I now also invite the speakers of the symposium, Dr. Ananda Vijay Vikrama, Dr. Mahen Kotalavala, and Dr. Susie Pereira on stage.
Good morning, ladies and gentlemen and distinguished colleagues. I welcome you to this post-tea session of our annual conference. And may I thank the organizers of this conference for inviting me and Dr. Surangi to chair this very interesting symposium. So we have three speakers today. All three of them are very distinguished speakers who are here to address on this symposium. And each speaker will talk for 20 minutes. And at the end of, please keep your questions. At the end of all three sessions, we'll be giving 10 minutes for any questions and answers. So without any further delay, may I invite the first speaker, Dr. Ananda Vijay Vikrama, who will be talking to us on building resilience and adapt to crisis in physician's perspective. And Dr. Ananda is no stranger to us and who has been very closely working with our university in many research collaborations. He was an excellent clinician and a specialist in infectious disease, who has main research interest including COVID, dengue, and HIV. And he has been a past president of the College of Physicians for the year 2020. So he needs no further introduction. So a man who is very capable for the given topic, because we all know how he has managed the dengue crisis. So let's listen to what he has got to say about building resilience and adapting to crisis, a physician's perspective. Dr. Ananda, please.
Thank you very much. Good morning, everybody. First, I would like to thank the organizers of the conference for giving me this opportunity to share some of my thoughts on this important topic. The topic I was given is the physician's perspective in adapting and building resilience in the current context, which I thought was more sort of too complicated. So I thought of simplifying it as the physician's role in the current crisis. Here again, what I thought was when I say physicians, I thought of using the old definition of physician, so it's a more generalized thing rather than the specialist in internal medicine, because I thought as medical people, as physicians in the medical field, we have an important and quite a large role, big role in the current crisis. We know we have been facing this dual crisis, the COVID and the economic crisis, and we know there are a lot of effects on health of people. This has led to increasing poverty, increasing malnutrition, increasing prices of medicines and all modes of treatment, lack of adequate funds for pharmaceuticals, lack of funds for development of state health sector, and then this is being further worsened with increased migration of health professionals. These are some of the effects. And some results of these effects are these. We have started to see wasting and stunting of children, increasing number of school dropouts will be, if we haven't seen yet, I'm sure we are going to see this in the near future. And then we are seeing people are not continuing on their medication who should be taking regular medication for chronic illnesses such as diabetes, hypertension, and then that will lead to complication of these illnesses. And due to the increased cost in the private sector, we have started to see overcrowding of state hospitals, clinics, and wards, increasing out-of-pocket expenditure for patients due to non-availability of drugs and certain investigation at times. And of course, this has led to increasing stress and other psychological conditions among public. These are, of course, some of the things. And then, as I said, we see increased migration of doctors and other healthcare workers. And of course, in other categories too, we see this. But of course, isn't there a silver line in this dark cloud? I believe there is. So what can we do in this situation? A professional, I believe, has many roles, of which some of the roles I have indicated here. They are the leaders of their respective teams. They give directives for innovation, inventions. They conduct and direct research. They should be examples to the public and encouragement to the public. And we should provide advocacy to the public and also to the government, which I believe are some of the roles of a professional. And we know during COVID crisis, the health professionals played a unique role, which was very, very important. A lot of fear, especially at the beginning, and the health professionals played an important role in alleviating this fear. And then we had to provide care for COVID-infected patients, and also during that period, providing care for COVID non-infected patients was also a challenge which we undertook as health professionals. And then we went on educating public, educating and training healthcare workers, then addressing and rejecting new drugs which are coming to the market for COVID, and then same for vaccines, and then of course advocating on policy related to COVID. In this economic crisis, what is the role we have as health professionals? I believe we have two main roles. One, as a responsible citizen. Every Sri Lankan, I believe, has a responsibility in this situation to help the country to overcome the crisis. In addition to the role of a common role which is common for all citizens, I am of the opinion that the health professionals have a bigger role than an ordinary citizen in the present crisis in their professional capacity and also due to their social status. So as a health professional, I believe we have a unique role in crisis of health-related activities, such as lack of essential medicines, increasing cost, etc. And then we have a unique role in advising the policymakers to use the situation as an opportunity to improve the health and well-being of the people. And many of us undertook many roles during the last 1 year or so in this aspect. Many clinicians, professional associations, individual and members of these associations did many things. For example, the Sri Lanka Medical Association started the relief fund to buy essential medicines which are lacking. The Ceylon College of Physicians, with the collaboration with other colleges like College of Pediatricians, Surgeons and Obstetricians, started another fund to purchase essential medicines. So other than this, now this is the first response of most of us when we face this crisis, face the economic crisis. Now, other than this, what other things can we do? Many organizations have voiced their concerns on purchasing unregistered medicines and non-essential medicines in this crisis period. Because we as health professionals understand the importance of having good quality, effective medicines which are of low cost, especially in this situation. So these are some of the publications or news items which led to these actions. Many professional organizations like the Sri Lanka Medical Association, Ceylon College of Physicians, College of Pediatricians objecting to these things. And as a result, Ministry of Health invited professional bodies to revise the essential medicines list. So many are involved in revising the list in view of the crisis. Therefore, the idea of the people who are involved and the professional bodies is to give a cost-effective care in our patient management. I believe we were not cost-conscious until recently. We were giving whatever the best we could give to our patients. That was the idea. But now it has to be different. So we have to be cost-conscious. And certain other things like adopting antibiotic stewardship programs, I'm sure Mahen will elaborate on this. And then we can have new guidelines to suit the situation, considering the cost and the cost effectiveness. For example, already Sri Lanka College of Cardiologists have made guidelines on using tenecteplase and streptokinase in thrombolysis. In the recent past, we have been using tenecteplase for most of our patients, but considering the present crisis, the College of Cardiologists have recommended that tenecteplase be used in high-risk patients, whereas for others to use streptokinase, considering the cost. The cost of tenecteplase is maybe around 100,000 or more rupees, whereas the cost of a streptokinase is less than 3,000 rupees. So you can see the difference, and that is where we have to consider the cost effectiveness. So similarly, Sri Lanka College of Oncologists have come up with an essential list of oncology medicines, and not only that, they have shown that if we adopt to this, the oncology drug budget, which consumes the highest proportion of drug budget in the country, can be reduced by half. So which will lead to a significant reduction of our expenditure, and we can use that money to improve the other sectors. And of course, I believe as health professionals, we have to be cautious in using new drugs. For example, we see increasing use of clinirapine for hypertension without a definite indication. We see increased use of levetiracetam for epilepsy without a definite indication. Now here, the cheapest clinirapine product is 48 rupees per capsule. That's the cheapest, whereas the amlodipine, I believe, must be around 3 rupees or 4 rupees. So you see the price difference. And there may be occasional conditions where clinirapine has an advantage, but definitely not for all people who need calcium channel blockers. And then the Medicines Regulatory Authority should consider whether they should accommodate all applications for the registration of new drugs or new products. Of course, they should consider the cost effectiveness and benefit to the country rather than loading our health sector with so-called new drugs. So what else can we do in this situation other than in getting involved in the pharmaceuticals, giving medicines and so on? Do we have a role beyond treating patients? And I believe so. I believe we have to use this opportunity to promote healthy living, which we can do in many aspects. Now, I'm sure most of the old people and older people in their childhood have made kites. And that was an experience and also something which will, I believe, will increase the skills, and also generally a couple of people get together and do that. But now, is that opportunity is there for our children? Because we are flying, our children are flying ready-made kites imported from China. What is the necessity? Now, there is a health aspect in this. So as health professionals, I'm sure we can elaborate on these things. Let's look at another example. This photograph may not be very clear. Is the lower down part you can see, it says a ක්‍රියාකාරකම මිශ්‍ර කිරීම සහ කලවම් කිරීම ශිල්පීය ක්‍රම අත්හදා බැලීම සඳහා පහත දැක්වෙන ආකාරයට ආහාරය සකස් කරන්න. And the ආහාරය is a puff pastry. This is from the page from textbook for O-level students for their home science. I saw this because we conducted O-level examination in our hospitals for children who had dengue. So I just look at some of their books and this is what I found. And how many of these children are going to make puff pastry in their life? Is it necessary? And also look at the contents. Tirangupiti 400 grams, lily margarine 350 grams, beehive margarine 50 grams. So are they healthy? Now this is where we have a much bigger role in advocating. We have to use this opportunity to give correct advice in these aspects too. And this is another example from the same book. And the makings are for short crust pastry. I don't know what it is. But again, how many of them are going to make it? And it is not healthy. That's the other thing. And we have a lot of local things which can be made, teach people to make, and which can be healthy. Then I would like to talk a little bit on the much discussed topic on tax. There's no argument on the fact that higher earners should pay tax. Right? So there's no argument on that. However, I believe as health professionals, we have to see how taxation can be used for more benefits other than filling coffers of treasury. So that is how taxation can be used for the health and other benefits of people. For example, the higher taxation we know can discourage importation of non-essential or hazardous things. Higher taxation will reduce the consumption of hazardous things. These are proven facts which have been used in some countries, for example, for cigarettes. Let's look at some examples. For the year 2022, we have imported more than 1.3 million kilograms of monosodium glutamate. Is it necessary? And is it healthy? We have imported 5.8 million kilograms of palm oil for Sri Lanka during the course of last year. So increasing tax they have to pay tax. But there's no problem in increasing the tax further, which will lead to some reduction of consumption, whereas at the same time, the treasury will get more money. So increasing tax in such items is important. Let's look at this example we all of us know. The global statistics shows that tobacco is responsible for more than 15% of deaths among men and 17% of deaths among women. So it's such a hazardous thing. 19.4% overall use tobacco, and 4.9% of women currently use tobacco. These are from government statistics. These are blog from policy studies of Sri Lanka. According to National Authority of Tobacco, NATA, currently 1.5 million Sri Lankans smokes as much as 11 million cigarettes daily. The high number of current male smokers who are 15 years and above, amounting to 28.4%, is concerning. Even the high health, social environment, and so on. And in 2015, Sri Lanka incurred a cost of 89 billion owing to both direct and indirect cost of tobacco. And a major part of that was health expenditure for these people with health problems. This is a study done, published in Tobacco Control, which says the result, in this study, in the conclusion, they say the results suggest that there is ample room to increase tobacco prices through taxation. In too many countries, cigarette prices have failed to keep up with increases in the general price level of goods and services, rendering them more affordable in 2000 than they were at the beginning of the decade. This is the situation, same situation is there in our country too. Just imagine increasing the price by tax by 10 rupees for a cigarette. The treasury will get 4 billion. This is a crude calculation, and this may be wrong because this was done by me. However, this is a document from Verity Research, where they say in 2019, the government introduced a policy where taxes and prices of cigarettes would be based on an indexation formula. Forgetting to implement the policy is costly. It has resulted in a foregone revenue of 85 billion from 2022 and will cost a further 45 billion in 2023. So if this price formula for which the government agreed to adopt was adopted, for this year alone, we would have another 45 billion rupees. So this is what the research says. So we need policymakers with a vision to make these attempts work. Otherwise, our suggestions will not work. For example, we didn't have amlodipine, but we had clinidipine. So we had to have some policy decisions on these. And also we need to, especially as health professionals, we need to be beware of abuses of the situation. There are many. For example, as consultants in various fields, you may be asked to authorize an unregistered drug, claiming an emergency and saying registered ones are not available. This has become quite a common situation at present. So then there's another suggestion, establishing private wards. Of course, it could be arguable, but when available facilities, we know the available facilities are reducing, decreasing in state health sector. So why further compromise this, whatever the funds we have for the state health sector? More than a year ago, the National Medicines Regulatory Authority, understanding the crisis, proposed, that was in last March, that the Minister of Health to curtail the importation of supplements, cosmetics, etc. to save dollars, which can be used to buy essential medicines, and also to limit purchases to really essential medicines. Up to now, nothing has happened. Well, it's not really so, because the minister sacked the board. The reason was the annual report was not submitted. So our role of advocacy, questionable. Thank you.
Thank you, Dr. Ananda Vijayavikrama, for presenting that very analytic and very kind of informative presentation, which went into details of very practical problems and solutions. So I hope this will materialize. Thanks.
Yes, so in our symposium, Building Resilience and Adapting in Crisis, today the next speaker will speak on laboratory perspective. And to speak on laboratory perspective, we have Dr. Mahen Kothalawala. Dr. Mahen Kothalawala is a clinical microbiologist, and he's currently working at the National Hospital of Sri Lanka. He's a board-certified medical microbiologist with over 16 years of service. And his special interests include rational use of antibiotics. Over to you, Dr. Mahen.
Thank you, Madam. So thank you very much for inviting me for this important symposium. So this is how I'm going to discuss my presentation. First, I would like to give you organization of diagnostic services in Sri Lanka, basically in the curative sector. So it is organized as such based on 4 broader subspecialties: histopathology, chemical pathology, hematology, microbiology. So I'm going to discuss what has happened in the diagnostic field during the pandemic, as well as aftermath of pandemic, using medical microbiology and medical virology as an example. So the impact, generally I have thought of discussing under 4 headings. So I'll be taking you through the pre-pandemic phase, during pandemic, and then the economic crisis, and I have divided economic crisis into 2. That is early part of the economic crisis and late or the current phase. So what has happened in the diagnostic field during pre-pandemic era? So we were functioning normally. So the functioning normally in the sense, our normal is, when you compare it in the Western laboratory or Western diagnostic services, it's very poor. But still, we were managing to cater for the demand from the clinicians. So what has happened during the pandemic? So basically, during the pandemic, our main concern was to carry out diagnostic tests to diagnose COVID-19, SARS-CoV-2 infection. So we have done it very neatly and spearheaded by the clinical virologist in the government sector. So the government sector and some private sector laboratories catered for the entire request made from the country. In fact, so this has been one of the pillars for successful control of COVID in Sri Lanka. So at the peak of the pandemic, many laboratories touched more than 1,000 tests per day level. So that's a huge achievement when you consider the diagnostic services in Sri Lanka. So at that time, I was working in the Kandy National Hospital. So Kandy virology alone accounted for 450,000 tests during that period. And with the sub-lab system, so the other labs which is supervised by Kandy, so we have done around 800,000 tests. And that is accounting to 3,300 tests per 10,000 population. So if you have a value for the national figures at that time, so during the pandemic, all these laboratories accounted for 6 million tests. So if you compare it with other countries, you can see in USA during the pandemic, so they have done 2,388 tests per 10,000 population, and our test is around 274 tests per 10,000 population. Indeed, it's a great achievement when we compare our resources. So something interesting happened during the pandemic period. So the request, our need for other requests have sharply declined during that time because of there were less patients, and also more concern is spent on COVID diagnosis. As a result of that, all other tests, the request for other tests have sharply declined. So as a consequence of this sharp decline, so we were all right during the early phase of the economic crisis. So we had all the reagents which were ordered to cover the COVID pandemic period, and we used that to cover the next 6 months, that is the first part of the economic crisis. But during the latter part of the economic crisis, that is the current stage, we were not so lucky. So the laboratory sector is one of the worst hit sectors in the health segment. So because, when all funds are shunted to purchase essential items, and there is not much of money to spend on laboratories. So work of the laboratories almost stalled some laboratories. So local agents, they stopped supplies. So we were 100% depending on the supplies from overseas. But because of the financial issue, the economic issue, the laboratories, we didn't get the reagents necessary. And also MSD, the Medical Supplies Department, which is the main supplier of items to our laboratories. So they even didn't supply the antimicrobial disk, which is a bare necessity to provide a good susceptibility testing. So we were facing with that crisis right now. Some of the laboratories like District General Hospital or Base Hospital was most affected. So they had to make drastic changes in their laboratory portfolios to face the crisis. Larger laboratories, they managed to continue the work, but suboptimally. So what current status? So now our diagnostic sector as well as the curative sector is hit by triple crisis. So Dr. Vijay Vikrama said double crisis. So now we are facing another crisis, that is the increasing antimicrobial resistance, pandemic and aftermath, the economic crisis, and increasing antimicrobial resistance. All these triple crises now we are suffering from. So it is similar to this situation that we have described in folklore. So it's Marana Tunak Atiminiak Panikaya. So we are suffering from the triple crisis. So laboratories were functioning under very low test profiles. So number of tests, so we have drastically reduced the number of tests that we can do. And there is no infusion of new tests or no infrastructure, no equipment purchases. As a result, the output from our laboratories have slowed, and also the quality of output has gone down. Antimicrobial susceptibility test done with limited number of tests, limited number of discs. And even the most critical tests like blood cultures has to stop or modify. Most laboratories reverted back to less sensitive, high contamination prone, conventional culture systems, which is a big issue when it comes to managing patients with sepsis. Reagents for these automated kits, automated machines that we are using, it was out of stock. As there is no guidance for selecting antibiotics to treat infections, so the haphazard use of empiric antimicrobials increased. So this has led to increase in end-of-spectrum antibiotics like colistin or other things. Most importantly, something very bad happened during that time. So that is the infection prevention and control efforts, they're not followed, simply because non-availability of alcohol hand rub. So this has led to increased number of difficult to treating organisms. If you see this cumulative antibiogram, you can see. So the susceptibilities that given in the last quarter of our hospital, you will see a lot of reds, less greens and less yellows. So that means we are encountering more and more difficult to treat organisms. If you compare it with the National Hospital Kandy in 2018, you will see more greens, less reds and more yellows compared to the one that we are experiencing now. So are we seeing something else? Are we seeing the ill effects of infection, poor infection control practices? Are we seeing ill effects of not using alcohol hand rub when you're managing patients? So on top of that, we are experiencing acute surge in brain drain. So that means more than 10,000 docs have migrated in 2022. So 10 of my SRs went abroad for overseas training, and 8 opted to stay at their respective countries. And worsening the situation, we were plagued with health sector, plagued with the strikes, especially when it comes to laboratory sector. There are medical laboratory technicians and also the minor staff. So they have launched several strikes during this time. So the greatest achievement of modern medicine, that is the chemotherapy, cancer therapy, transplant, organ replacement, all these things will depend on our ability to fight infection. So the fight infection depends on our ability to detect infection correctly. So unfortunately, with the current crisis, now it is going away. So what are the challenges? We know that the supply chains will not be restored within foreseeable future. So we are still in the crisis. So therefore, very unlikely that we might, this whole scenario might change within foreseeable future. Antibiotic stewardship, something that we have initiated from the laboratory sector. Lab-based surveillances, antibiotic guidance are in jeopardy. So it's no longer a viable option because we don't have facility to do certain things. Patient safety. So this is one of the important things, patient safety. So if a patient comes to hospital and getting an infection as a result of hospital admission, so that will be a big problem for the patient safety. So it is being breached heavily. So how are we going to adapt to this change? So now it is happening mainly in the laboratory sector. So it can spill over to the curative sector. So that is how this all structure works. Because of the financial crisis, the economic crisis, the government is not spending on the laboratory to improvement of laboratory. But I'm sure if this goes on like this, it will spill over to the clinical setting as well. So we have to do something to prevent this. So what can we do? So we have to select. We have to select certain things and we have to work on that. So number one that I suggest is to time critical, identify the time critical conditions like sepsis and put more emphasis on that to improve diagnosis. So for that, we suggest something called diagnostic stewardship. So the diagnostic stewardship is selection of right test, right time on right patient. So basically we are trying to streamline the request of laboratory tests on patients. So diagnostic stewardship is not just cost reduction. If somebody is thinking that we want to cut down cost, so that is not the aim of diagnostic stewardship. So diagnostic stewardship involves multidisciplinary involvement. So that is not only just isolated, partitioned care. So we all get together to provide the care. And then rational test selection. So, you know, our house officers were taught when they come to do their internship, get a full list of tests. Rather than that, we approach in the way that we select rational test selection rather than this predetermined list of tests. Then point of care testing. So this is another important thing. So when the patient comes, when the critical patient who is suffering from a time critical condition, when the patient present to the ETU, we can do certain tests. So that will reduce upstream further more advanced investigations. So if we can infuse that, we can reduce this thing. And then we have to take action based on the test that we request. So what happens here is, at the end of the day, when I go to the place where we usually keep the reports, we will see 100 or 200 tests which was not taken to the wards. So that means the cost, which incurs cost. And it also involves avoidance of errors, you know. So we make a lot of errors, but unfortunately we don't admit that. So there has to be effort to prevent these avoidable errors. So what are the things that we can do? First, we need to have cheap and easy to operate, rapid and sensitive enough tests to identify pathogens, especially targeting the critical illnesses like sepsis. Few things in the line. Lateral flow test. So now this is standalone test. It doesn't require high-end equipments, just lateral flow test and just a ICT like the pregnancy test that we use. And there are many highly sensitive diagnostic tests. Still, we have to use it rationally. And then pathogen identification with multiplex PCR. So you know when it comes to molecular test, so that is costly. But we have to know that we have an infrastructure, very good infrastructure that we have developed during COVID days. The facility is there, but we are not using it. At the moment, NHSL does around 3 or 4 COVID tests per day, but we have a very good molecular biology laboratory. We can modify it with addition of reagents only. More sensitive strains. Now we are using the classical gram stain. So we can use more sensitive strain like acridine orange, which gives results very easy to interpret and see. So that can be done. Rapid antimicrobial susceptibility. So this is the whole thing that we have. This is the best test that we provide from the microbiology laboratory, antimicrobial susceptibility testing. So there are new technologies where you can do the susceptibilities within 4 hours. So in addition to that, identification of organisms which causing disease, and also identification of the resistant patterns. So we can easily undertake it with chromegas. So rather than having these high-end MALDI-TOFs or high-end automated platforms, we can use chromega to detect organisms very easily, like MRSA chromega. You can diagnose MRSA, methicillin-resistant Staph aureus, and we can use chromega to detect the resistance patterns, ESBLs, the common resistant organisms which haunts us, and also carbapenem-resistant enterobacteriaceae. So that can be detected with chromega, and there are a whole lot of other colorful agars where you can detect pathogens. So that can be used rationally to prevent the time and also to identify the resistant organisms. And that with that we can make a change in the current system, and we will be able to provide the demand for these critical conditions. In addition to that, we need to have a multidisciplinary action. So something that we lacked. So we need to come closer. It is not just closing doors, but we're opening doors to other specialties to get the knowledge, get their insight in patient management. Ultimately, what we are doing is we are trying to achieve one single target, that is the benefit of the patient and the patient management. So we have to open up and get the others' fields help. Screening samples before processing. So this is another important thing that we have not done earlier, but we are doing it. So that is finding out whether this processing or analyzing the sample is really necessary. So we'll see a lot of samples which has to be rejected, unnecessary samples that we are doing. So if we can do that, we'll be able to rationalize and also save a lot of cost. Tracheal secretions, a test that we are doing in tons, but that is useless. Most of the time what we tend to do is we tend to get the contaminants. Wound swabs, worst scenario. So we always get this multi-resistant organism, and that will put us into additional problems. So therefore, we want to find out whether we really need to do this or not. Sputum. So the sputum is another culture that you will see a lot of false positives. So we have to have some sort of compromise session for this. Urine cultures, which are sent for culture, more than 4 hours delay. So that is useless. All that grows does not require further processing and treatment. So that's one important message that I would like to give. In addition to that, improving infection prevention. So that is something that we have not followed in the recent past. So that will have a big impact on patient care and patient safety. Then the improvement at ward interface. So this is something that we have ignored. Communication. clinical tools to identify critically ill patients and focus on them for the diagnostic take. Senior inputs. So this is very important in the crisis situation like this. Seniors has to come forward and supervise the juniors so that it will have a big thing in this. Improvement of the community interface, as Dr. Ananda said. So we have to have a early identification on septic patient, accident prevention. So there are many people coming with accidents and a whole lot of infections are getting it from the hospital. So if we can prevent, if it cut down by 50%, we can. Improvement of road safety, road rage, all these things will reduce number of patients coming into the hospitals. So for blood culture, there is no alternative. You have to do blood culture. Improve surveillance. So that is another thing that we have missed. Audits. We are not using it, that tool properly for basic summary. So the all efforts we had to put to break this vicious cycle created by the pandemic and the economic crisis. So what I suggest is to bring the laboratory to the bedside, as suggested by Professor William Osler in 1800. So that means you have to communicate with the laboratory consultants and early results and frequent communication with wards. And thank you very much.
Thank you, Dr. Mahen, for this eye-opening presentation and making us aware about the triple crisis and your suggestions for the how to face this challenge.
We will come to the third speaker on the same topic of building resilience and adapting to crisis. This time we're going to look into the primary health care perspectives. To talk on this, we have got a distinguished speaker, Dr. Susie Pereira. She is a Deputy Director General Public Health Services of Ministry of Health, Sri Lanka. And she will talk to us on the primary health care perspectives. Please take.
Thank you very much for giving me this opportunity. And I think it's quite an important area that we're discussing resilience. If you, this would be roughly the outline of my presentation, which I think we need to highlight the relevance and scope of the primary health care in building resilience, but relating it to the overall health system. So health systems resilience, which is actually the overarching theme of this symposium, is defined as the ability for health systems to absorb, adapt, or transform to maintain essential functions when we are shocked or stressed. Now, we know that we went through a long, drawn phase of the COVID-19 pandemic, but it's continuing to the economic downturn. If we reflect, long time ago, maybe some of you would recall, the Alma-Ata Declaration, 1978. Also, it was popularly referred as the Health for All. And since then, the primary health care has gone through several waves of different global understanding. And it has been re-emphasized through universal health coverage and SDGs, and actually came out as another global declaration as the Astana Declaration in 2018. In fact, now we all know that we talk about universal health coverage, and primary health care is now considered as the key and important strategy for universal health coverage. Now, global agendas, if we sort of look at what's happening, have largely been on retooling, reorganizing, adopting person-centered care, looking at sustainable financing for PHC, redefining what comprehensive care is, and the need for essential service packages that include NCD. It's very relevant for us. And now we are also thinking of these digital transformations and how it can suitably improve PHC. Again, we are emphasizing the multi-sector engagement and community empowerment. I think some of these were also mentioned by Dr. Ananda Vijayvikrama in different ways, right? Which were actually part of the original PHC approach in 1978. Some of these words came up as community empowerment, multi-sectoral action, but they were forgotten down the line, and we actually saw more selective PHC being implemented for some time. So the more recent directions are on now, if you say, the very recent introduction was last year, on the actual measurements of how PHC contributes to universal health coverage. And of course now, resilience, which we can see after the pandemic and maybe several other crisis situations. Now I'm showing the next two slides for where we have taken, I'm not going to read all of this, but it shows that for revitalizing primary health care in Sri Lanka and leading up to the policy on healthcare delivery for UHC in 2018, there was a considerable amount of work that was done, that we undertook. I'm just giving you this background. So, what is primary health care? There are many definitions, and I would like to think that from a definition of saying it is the first level of contact with the health system to promote health, prevent illness, care for common illness, and manage ongoing health problems. With this comes comprehensiveness and holistic approach. Actually, 95% of patient contact with the health service would take place in primary care. It can therefore be argued that primary care is the backbone of any effective health system. Now, in settings where primary health care has been effectively deployed and supported with adequate training and resources, family physicians often refer around about less than 10% of patients from consultations onto the secondary care. So patient satisfaction is known to be high and at a decidedly low cost to the health system. This evidence is clear, and a health system that is not primary care led is a weak and expensive one. In Sri Lanka, the primary healthcare services is organized in as two main streams, and you can see that we have primary level curative care, the community health services, and also the private sector coming in largely for the curative side. Right? Now, what makes the health system? I would like to, before coming to discussing on what makes it more resilient, I would also like to mention that there were two major projects that came to support the primary care strengthening, both World Bank and the ADB. But there are, I think these were mentioned by the previous speakers also, and I will not read out, but there are these challenges that also apply to how we are going to retool primary care. Financial, human resource in a huge way, governance, believe it or not, that's a huge thing. And I think a lot of it was hinted by both the speakers. Medicines and supplies, we all know about it. Information and medicines and supplies includes laboratory, information systems, and community empowerment. There is a huge potential there. Now, what features actually make the system more resilient? So these are some points. Comprehensive person-centered primary care. And when we say primary health care, primary prevention, secondary prevention, and tertiary prevention, all are important in primary health care. This is now considered the most important composition to go into primary health care, right? Reflection for Sri Lanka. Now, actually, if you look at it, in Sri Lanka, were we able to maintain all the essential healthcare services during this time? To what extent did the primary curative care services support and maintain health services? Were they optimally utilized to manage the COVID-19 patients? If we did not, we also need to find out why. Now, there is also the recent thinking about staffing. Do our facilities actually have adequate staff? Are they trained? Are they motivated? Especially to manage under stress. Do they have the necessary supplies? Did the administration plan to utilize the primary care systems adequately? Did public health and social measures that we adopted actually create a negative health-seeking behavior and add barriers to patient care in the hospital settings? And what emphasis do we make on well-being and self-care and community empowerment, and including education and other multi-sector engagement for health? I think this is where we have to now reflect, and we are seeing that if overall we are to have a health system that is resilient, then these aspects of primary health care are important just as much as the care delivery, but the overall aspect. So I think previous speakers also mentioned about the education systems and all of that. And I'm aware that there is a curriculum reform going on in the education. Already they have done it, but they're not implementing it. So these are things that we have to see why these things are not implemented when a reform has been done and we are seriously needing these changes. So these all have an effect on the kind of graduates we have also, because they are the result of the education system, primary education system, right? So we are seeing a whole cycle of changes that are coming because of the primary health care is therefore not only what the health sector is providing. When I say health sector, government and the private sector. So I would like to conclude by saying that this public health model becomes important when we compare the biomedical models that are purely disease focused, and when we are combining it with the public health. So this integration is what is now being spoken of. So resilience comes with a health system that has a well-considered curative plus the preventive. And that is why primary, secondary, tertiary prevention, all these things are important. And actually, Sri Lanka has a very good foundation for that. It is just that during the COVID, we actually didn't make best use of it. To some extent, there was ignorance of this, apart from the community health services. We kind of ignored it in the first phase of the response, where we try to get all the patients to the higher level institutions, ignoring the 960 odd facilities that we have at the ground level. So the factors that contribute to resilience, we know that changes don't happen in a jiffy. It takes time. So preparedness and investment is needed, and the returns are definitely going to be high. And one important aspect that we are seeing is, and I think both speakers mentioned it, is the focus on human resource strengthening. And I think even in the morning, the keynote speaker also showed the caliber of thinking, the entrepreneurship that comes with it. All of these things will make a change. So I just leave with you some references which I took to sort of triangulate this, because this is a kind of a newer thinking, because earlier we were just focusing on from the policy. I'm telling that the policy is important, but from the policy, the implementation now has to restore, retool our available infrastructure. It's possible, but financing has to be secured. Thank you.
Thank you, Dr. Susi Pereira, for that very thought-provoking talk on the primary care perspectives. And with this third talk, we come to the end of the symposium, and very exciting symposium. We all enjoyed it. And to go in, before we go into the next 10-minute question, let me thank all three speakers who are very distinguished speakers. They have all done a very thorough analysis of the recent crisis and proposed various solutions and drawbacks and all. So I think we all have gone. Sri Lanka has been stretched to the max during the crisis, and our resilience has been tested, and we have proven that we are a resilient nation, and we have come out quite well despite a lot of drawbacks which were beyond the primary care physicians, the healthcare providers' control. The healthcare providers have done a marvelous job, I should say, in during the crisis in building resilience. So let's open this symposium for questions for the next 10 minutes.
This is to Dr. Mahen Kotarawala. Thank you, Mahen, for this very informative talk. Now, I like your concept on diagnostic stewardship. So why now in our other developed countries we have seen them having multidisciplinary clinical meetings, and I think by doing that we will be able to reduce the cost for this diagnostic test we do a lot. So what are the difficulties of having such meetings in our country? I think we can, if we do it routinely, we will be able to do cut the cost to a great extent.
Actually, the multidisciplinary meetings is a very good concept, but we are using it wrongly. So what we are doing here in my country, Sri Lanka, when you are falling into trouble only, that you go for a multidisciplinary meeting. So that is to come out of the problem. So most of the time when the patient is pretty bad, we'll go for the multidisciplinary meeting. Actually, it has happened to be right at the beginning, not right at the end of the care pathway. So that is what I see. So most of the time, all these patients we are discussing on multidisciplinary meetings will end up in a very bad outcome. So that is because we are not using it at the right end. We have to do it right at the upstream, not right at the end. I think Dr. Ananda would be able to answer better for that.
Yeah, I agree with Mahen. As you mentioned, the concept of diagnostic approach of multidisciplinary work is important. Unfortunately, we have not been used to that setup. That is one issue. And also sometimes the workload also probably is preventing having such approach. However, I think as Mahen suggested, at least in selected cases, if we can make it as a practice. And also to have it has to be not only about the discussing, it has to be some auditing process also. Say what diagnostic tests were done, whether they were necessary, and what antibiotics are used, whether they were necessary. So that sort of auditing process also has to be incorporated into that. And I think that will be quite useful.
I think this audit system is very important. It's not just when something wrong has happened, but it should be a ongoing thing on a day-to-day basis, randomly. A patient, you just pick up from the ward and just find out, has this patient received the kind of care that we recommended? You know, so it just today, patient comes to the ward, you just find out from that point whether this has happened. So every week, if at least one patient is being audited, this automatically the whole system gets ticking, So that's, and multidisciplinary, I think, a lot of countries, they have the conducive arrangement where the disciplines can meet. But I think, this is a bit not conducive sometimes. But nevertheless, I think when we start doing the audits, the little audits, then, automatically the necessity and the value of multidisciplinary discussions would come in.
I think, as you told, house officers generally tend to have the whole list of investigations, I think, not to miss anything. And again, it's a part of their training. So if we have this type of meetings, I think we will be able to educate them also about the essential things to do. And as you told, would be a very good audit also. Thank you.
I have a question. I think I'll let to ask from Ananda. Now, you very nicely compared the cost of medications, very usefully compared. So I have these reflections going on in my mind. Now, why did we fail to obtain these antigen kits to be available freely in the primary care providers as well as pharmacies, where when you go to any country in the world during that time, just pick it up from the pharmacy or supermarket. And why did we, what is the cost did you analyze the cost of antigen if it was to be available at a pharmacy and where we had to pay in a private sector? So do you analyze that costing? COVID.
Yeah, I think that time that was probably a new experience for all of us. So that is why sometimes people were reluctant to, I would say, liberalize things, even when it is done in some other countries. We know it can lead to abuse also. So there were many aspects to that. Now, the example I took in other instance, use of clinidipine, it has become very general, which is absurd. It is being abused, and people have to pay. So similarly, the other things can also be, when you elaborate on that, sometimes we have to pay a bigger cost. So probably I think that is why it was not generalized. Maybe Mahin can add.
Yeah. So now this antigen test, there are actually two types of antigen test. One which is available in the outdoor for the individuals to buy is not the same that we have purchased for the diagnostic purposes. So this is two things. One is where you use the anterior arrays for people to see whether they are infected already, having that sort of thing. The one that we have got down is not that one. So that is a different one. So that may be the reason. We use the same term ICT, antigen kit, but two different purposes. It serves two different purposes. That may be the reason. In other countries, they had this access, the anterior arrays one more freely. But ours, we just use antigen test kits per particular this thing. Other thing, now at the initial period of pandemic, our disease burden is not high to use an antigen test. So at that time, antigen test if you are using a low sensitive thing for diagnose, so you will be end up with lots and lots of false positives and false negatives, which will have a repercussion in the controlling. So that may be the one reason for not introducing antigen test kit right at the beginning. But I think in the latter part, we were using it correctly.
But I think in this deciding on tests for primary care, and especially when the pandemic was going on, we should have taken a decision what is the most appropriate to give at the right time to the primary care level. Could have made things very much easy for the people.
So I have a question. I think I will direct to all three speakers. Like now we were talking about adapting in crisis, and you all had very good suggestions. But certain things are happening in a very, I think it reflected in your talks. So how can we make this, push your good suggestions, make things happen to come over this crisis?
If I may answer first, because I have the mic. I think that is again a role of the professionals. I think we have to get together, put pressure, speak to not only the policymakers, but speak to the public also. I think this is important, and I'm glad that we have selected this topic. That's why we are discussing this. So likewise, not only we have to discuss these things here, I think as professional organizations, the academic bodies, universities, we have to take this to a different level. Then only certain things will be implemented, because some of the policymakers, unfortunately, have different agendas. That is the plain truth, unfortunate truth. So some of the things which can be done easily even are not done. So that's the problem. And also, even if I may talk about the health workers or rather doctors, now certain things which are even not controversial are not implemented because some people don't want to get this extra trouble. So they would just keep on doing whatever they have been doing, rather than doing something a little new to have a better benefit, because they have to do little extra work. I think that is another reason.
Yeah, to answer in a different way, I would say that it's important to measure things and measure and objectively take decisions. I think that culture is a bit lacking. And recently, I'm seeing from the very high level government, there is a pressure put on to give a results framework for the Ministry of Health. Now, programs coming under me, all of them have results frameworks. But, this is something that we advocated a long time ago, right? But it didn't happen in all. Now, for example, laboratory program should have had, they should be having a proper results framework. So, these are good practices in governance to be results oriented, to monitor. And that is why, if you take for primary health care last year, WHO put out a special guideline on monitoring primary health care, contributing to the UHC. So we have to use these. We are trying to use these things to report to somewhere else. But no, this use has to be to make the changes downstream.
So I will give you one example for this thing. During COVID pandemic, we were supposed to make guidelines. So College of Physicians did one, pediatrician did one, microbiologist did one. So we were just closing. So we are very happy with when we are dealing with ourselves, our unit. But we have to open up, and that will create a necessary background for having this.
I think
Certain things are, people do certain things, maybe at individual levels, which should be done as policies. Now, if I may tell an example, we may have seen in the media that during the last 2 weeks, for dengue infected children, we were conducting an exam center in our hospital. Now, that was not our job, but we did that because to help these kids. And the important thing was the reception we got from the exam, which this we have been doing for the last 6 years or so. And the reception we got from the Department of Examination was superb. They were very receptive to the idea. And initially, couple of years ago, even 2 years ago, we had to, the parents have to take the admission card to the examination department to get things done. And still they were attending 24 hours a day. But this year, just sending it through WhatsApp was accepted by them. So there were some positive things happening in certain sectors. So I think we have to do this in other sectors too.
I think we are running short of time, so maybe that we can discuss for hours and hours. Let us thank all three speakers for very superb presentations and on a very timely topic. So with that, I think we all have a duty, maybe the professional bodies, the universities and the hospital staff, ministry, so let us push and get things happening. So with that, let us end this session. Once again, let us thank the three speakers.
I thank the chairpersons, Senior Professor J. Indakumar and Senior Professor Surangi Asavardhana, and the speakers of this symposium. And I also invite the chairpersons to hand over tokens of appreciation to the speakers. Can we please have Dr. Ananda Vijay Vikrama? Dr. Mahen Kotalawala. And Dr. Susie Pereira.
Thank you very much, ladies and gentlemen. Next up, we have an exciting new addition to the sessions this year, the Rapid Pitch Thesis Challenge. This will be an event where the postgraduate trainees will showcase their communication skills, quick thinking, and where each presenter will be given just 3 minutes to present the essence of their thesis, followed by a rapid fire question and answer session of another 2 minutes. I now invite Dr. Shehan Silva, consultant pediatric physician, to chair this session.
Good morning, ladies and gentlemen. We are a little bit running short of time, but we will have this session going on. It's a pleasure to be chairing this session, which is a new addition in this academic session. I would like to stress out to the presenters that you ought to be very strict to the time, which we will provide 3 minutes for you to present your work. And at the end of the bell, there will be an additional 2 minutes where the judges will pose questions. And we have delighted to have Professor Rasika Pereira as well as Professor Inoka Korea to be the judges of this session. So the first presentation is investigation of dengue NS1 specific antibody and memory B cell responses in individuals with varying severity of past infection by Ramu, Disanayaka, Jeevandara, Barry, Harvey, Gomez, Vijay Singh, Og, and Malavige. And we invite Ramu ST to present.
Thank you. Hello everyone, I'm Shaira and I'm a PhD student in this university. So to begin with, I would like to just tell you all that my research is on dengue and I will not give an introduction on dengue since we all know what it is. But although we know that dengue is a pressing issue in the country, we do not know why there are a set of people who go into severe disease. So we also know that there are 4 types of dengue in Sri Lanka, around the world. And also we know that we acquire dengue through a mosquito bite. And once the mosquito infects the person, there is a particular protein called the NS1 that is released into the blood. So in my research, I am looking at this NS1 protein. And why is that? It's because NS1 has been known to cause a lot of issues in severe disease. It contributes vastly to severe disease. And it leads to a lot of the complications such as fluid accumulation, which we call as hemorrhage and bleeding in most of the severe cases. So there is a vaccine that has been produced previously called the Dengvaxia. And although this vaccine was introduced, it did not induce any antibodies against this NS1 protein. So we want to see, in my PhD, I wanted to see if these antibodies to this NS1 are actually protective or not. So as you know, so these NS1 antibodies, so I studied these NS1 antibody levels and also memory responses to these NS1 antibodies in patients who had past severe dengue and past non-severe dengue. So according to my study, what I found was that most of the people who had severe dengue had very high levels of these antibodies. So what does this say? Does this say that NS1 antibodies are pathogenic and can serve as a biomarker to predict severe disease? So in order to know this thing, I need to further study this and see if the functionality of these antibodies will tell us whether it is protective or not. So I have almost finished all my work on my PhD so far, but apart from that, when I will be doing my postdoctoral research, I will be continuing to study the functionality of these antibodies. Thank you.
Questions?
You did not give us your findings. What were the findings that you had so far?
So the thing is, when I studied the NS1 levels in the severe and non-severe dengue individuals with past severe and non-severe, what I found was there was high levels of the NS1 antibodies in people who had past severe dengue. And also the memory responses were similar in both the levels. So it can be because the functionality of the antibodies are different.
Did you do any functionality?
No, I had not studied the functionality except for the types of antibodies. So that is what I am going to pursue, to study what type of antibodies are involved in the memory when compared to the antibodies that are circulating freely in the blood.
But you said there was no difference in the memory.
Yes.
Between the two groups, severe and non-severe.
Severe and non-severe, yes.
What was the difference? Just the quantity?
Yeah, the quantitative levels, yes.
And how about for the different serotypes? Any difference?
Throughout the serotypes, there is actually cross-reactivity that is seen. That means, like even we know in some cases there was a particular type of serotype that the person was infected with, but they did have responses to them, to the other serotypes as well.
No, I mean between the severe and non-severe, did you see any difference in the cocktail of antibodies?
No, there was no difference in the serotypes.
Because you have said so in the
antibody
abstract.
levels, yes, but not in the memory levels.
No, I'm talking about the 4 different serotypes.
When we measured the antibodies, the circulating antibodies, there was a difference mainly in DEN2. DEN2 and 3 serotypes showed differences in the DHF, whereas in the DF, that is a non-severe dengue cohort, there was just for 2.
So do you think that has any relevance? Or?
No, that is important because that means these antibodies can, like if you have a previous infection with another serotype, that can definitely maybe cause severity when you get a subsequent infection.
Yeah, I mean, we know that. The particular serotypes?
Sorry?
You said that there were a difference in the type of serotype antibodies between the severe type and the non-severe. Yes. Non-severe, there was no difference in the 4. DS1,
yes.
D1 to D4, but in the severe there was a difference in the number. How would that, are you going to study that?
Yes, I'm actually going to study the exact type. Like I'm going to isolate the antibodies from the serum itself, and that is my next research that I'm working on right currently. I am actually developing an assay to isolate the antibodies and study that.
Okay, right. Thank you.
Thank you. We move on to the second presentation. It's on parasitological, serological, and molecular-based diagnosis of strongyloidiasis among immunocompromised patients in Sri Lanka and associated risk factors for disease occurrence. The study is by Virasekara, Manike, Vimalasiri, Anpahalan, Vijayaratna Pilapitiya, Pereira, Gunathilaka, De Silva, and Vikramasinghe. Over to you, Dr. Virasekara.
What comes to your mind when you hear the term elusive parasite? No, I'm not talking about the usual two-legged ones we all know about. I'm in fact referring to a parasitic worm called Strongyloides stercoralis. Strongy what, you may ask? Well, Strongyloides stercoralis, or strongy for short, is a tiny parasitic worm that lives within the walls of the human small intestine. Humans get infected by this parasite when they set foot on fecally contaminated soil through skin penetration. Strongy has the unique ability to reinfect its host, hence called autoinfection. Strongy causes diarrhea. However, it does not cause severe disease if your immunity is good. But when its host gets low in its immunity, as in cancer chemotherapy, organ transplantation, or advanced kidney disease, strongy can auto-infect and multiply by leaps and bounds and cause even death. Luckily, there are simple drugs that can cure this infection. Unlike the other parasitic worms, strongy eggs cannot be detected by simple microscopy, simply because they are not excreted in the human stool. Only larvae are, and that too in minute quantities in patients with mild infection. Therefore, this disease is largely undetected and we do not know its true burden. As the proportion of infection of the other soil-transmitted helminths are low in Sri Lanka, we assume that the strongy burden is also low. But is it really? For my MD, I looked for the prevalence of strongyloidiasis among patients with impaired immunity by several methods: simple microscopy, culture, and PCR. I also looked for the parasite-specific antibodies in the serum, as it is an indirect marker of infection. Then I looked at the risk factors for infection, like age, gender, level of education, then exposure to soil, and the availability of sanitary facilities. Out of 260 patients I recruited, 122 provided serum samples, out of which 20 were positive for strongy antibodies. The presence of antibodies, however, does not confirm the presence of infection. For that, we need the parasite. Out of 160 fecal samples, none were positive by simple microscopy. Only one was positive by culture. But out of 123 PCRs performed, 14 were positive for strongy DNA. Thank you very much.
Q&A session.
This strongyloides PCR test, is it a validated one? How did you validate, and what are the controls you used?
Madam, this test has been established at the Faculty of Medicine at Ragama, and it has been used there. So I went there and did my test. So the positives that we got, we sent a certain amount with the availability of resources. We sent for sequencing, and they became positive for strongyloides stercoralis. And also we took a certain amount of the positives, and we ran the PCR here at the Japura laboratory also, and they also became positive.
Right. And you didn't do a PCR on all. Why was that?
In the sense, all 160 samples, madam?
Yes, of stools.
Because of the limitations of the reagents, madam.
How did you select the ones you would do PCR?
Based on the risk factors. So I sort of in descending order, those who had the most risk factors selected first, and that's how I got it.
And how many patients did you diagnose as having strongyloides based on all the 4 tests you did? 14,
madam.
Just the PCR ones. How about the serology ones?
Serology we did, but the problem is with Sri Lanka is actually considered as a non-endemic country for strongyloidiasis based on the recent WHO classification. So the problem is with the lower prevalence, there can be a high number of false positives. So we mainly took the molecular prevalence into context.
Okay, thank you.
Thank you very much.
Thank you. We move on to the third presentation, microbiological profile of pediatric community-acquired pneumonia and analysis of pneumococcal colonization among healthy children in the Colombo district. Authors Gonapala Deniya, Disanayaka, Veerasekara, Kaviratna, and Liyanage. It will be presented by Dr. Gonapala Deniya.
Despite novel approaches, pneumonia is the leading infectious cause of death in children globally. According to WHO, in 2019, more than 700,000 children died due to pneumonia. Hospitalization due to community-acquired pneumonia in children is a substantial burden on healthcare expenditure, especially in countries like ours, developing countries. Streptococcus pneumoniae is a leading pathogen for community-acquired pneumonia and other infections like other diseases like sepsis and meningitis. Colonization of Streptococcus pneumoniae is a non-prerequisite for invasive diseases. Having that in mind, we aim to investigate the microbiological profile of pediatric community-acquired pneumonia and analyze the pneumococcal colonization and the biofilm-forming ability of pneumococcus in healthy children. So, to detect the microbiological profile of community-acquired pneumonia,
we took 159 CAP children, and for the other objectives, 350 healthy children were recruited. Blood, nasopharyngeal swabs, and chest x-rays were taken from CAP children, whereas only a nasopharyngeal swab was taken from the healthy children. A panel of tests, namely culture, serology, PCR, and sequencing was performed to obtain our objectives. So moving on to the results, what is the microbiological profile revealed in CAP children? At least one potential pathogen was detected in about 80% of CAP children, and there was an obvious viral predominance over bacteria was observed. And almost half of the CAP children were nasally colonized with pneumococci. Contrastingly, the healthy children had only low pneumococcal colonization rate. And also, the serotypes we observed from the healthy children could be covered with the available pneumococcal conjugate vaccines. So why this study is important? Because it is the first study done in Sri Lanka to investigate the biofilm formation ability with their corresponding serotypes. Also, we have given data on the serotypes and the vaccine coverage of healthy children in the Colombo district. So this knowledge could be used for future studies in national and in international level. Thank you.
Q&A session.
Can you explain the discrepancy between the colonization you saw in the CAP children and the colonization you saw in healthy children?
Madam, actually, it is hard to compare the CAP children and the healthy children in our contest because the samples were taken in two different time frames. The healthy children sample was taken during the pandemic, so the colonization rate was very low. But the other even in our country, the studies reveal that colonization in healthy children is comparatively high.
You had 50% colonization in the CAP children.
Yes.
Can you explain that?
That is because the colonization rate was investigated using a real-time PCR from nasopharyngeal swab. So as it is an upper respiratory sample test, we cannot come to a conclusion it as a pathogen or the causative agent. So it was considered as a colonizer in CAP children.
And did you culture anything from the CAP children pneumococci?
Actually, because in the first phase of our study, we didn't culture any of the upper respiratory tract samples, but looking at the results from the CAP children in the second phase, we cultured the nasopharyngeal swabs of healthy children.
Okay. Thank you.
Thank you.
Thank you. Move on to the fourth presentation. Prevalence of carbapenem-resistant Enterobacteriaceae among two patient populations and evaluation of selected phenotypic carbapenemase detection methods. Chaturanga Disanayaka, Fernando, and Vanigatunga, presented by Chaturanga BAG.
Imagine you have an army of soldiers who are fighting against enemy invaders. The soldiers have powerful weapons called antibiotics that can easily destroy the enemy invaders. But over time, the invaders start getting smarter and tougher. They develop techniques to resist the weapons used against them. Similarly, antibiotic resistance occurs when bacteria develop the ability to fight off the antibiotics designed to kill them. Carbapenem antibiotics like imipenem and meropenem are highly effective against a wide range of bacteria. Carbapenems are often considered as last resort antibiotics when other antibiotics have failed. Unfortunately, some bacteria have developed resistance to carbapenems as well. Bacteria can develop carbapenem resistance in several mechanisms. The most common and most important mechanism is producing enzymes called carbapenemases. Cancer patients are more prone to acquiring infections when compared to a person without cancer. We studied bacteria isolated from cancer patients and patients without cancer who were diagnosed to have lower respiratory tract, urinary tract, and skin and soft tissue infections. Samples collected from these two patient groups were processed to find out which bacteria were causing infections and how these bacteria responded to different antibiotics. We were particularly interested in carbapenem resistant enterobacteria. We looked for specific genes that would make these enterobacteria to produce carbapenemase enzymes. We also evaluated 4 different tests to see if they could detect carbapenemase production in enterobacteria. According to our findings, nearly 50% of the enterobacteria isolated from cancer patients were carbapenem resistant. This is significantly higher than the rates we observed in patients without cancer. Almost all carbapenem resistant enterobacteriae were carbapenemase producers. Modified carbapenem inactivation test was the best test out of the 4 tests we evaluated. The observed high rate of carbapenem resistance in cancer patients is concerning because it limits the available treatment options. Our findings will help healthcare providers to make better therapeutic decisions regarding carbapenem resistant enterobacteria. Thank you.
Q&A session.
Did you start with the patients themselves, recruit the patients and then collect patient specimens and do cultures? Or did you start with the culture isolates from the lab?
Madam, we started with the positive cultures.
All right, but that was not clear in your presentation. So how did you had 3 sets of infections and 2 patient populations.
Yes, ma'am.
How many samples did you have from each of those 6?
We included 55 positive cultures from each patient group, so that accumulated to 165 from each patient group.
And how many for each of the, there was low respiratory, skin and urinary?
55 from each infection category, we included 55. 55 from lower respiratory, 55 from urinary tract.
Yes.
So that accounts to 165 total in one patient population.
And then another 165
65 from other patients.
So altogether 300.
300.
Right, that's not clear in your abstract at all. Okay, that's a good number of specimens. Right. And so your main aim was to check for carbapenem resistance.
We check the entire spectrum of bacteria, madam, and then we focused on carbapenem resistant enterobacteria.
So of those, 165 and plus 165, how many enterobacteriaceae did you actually get?
Nearly, madam, the proportion of enterobacteria was similar in each patient group. So
But,
out of 165, 94 in cancer patients and nearly 98 in non-cancer patients.
So about half of each were due to, in each group was half of the cultures were enterobacteriaceae, and of them a significant proportion had the
carbapenem resistant population.
Okay, right. Okay, so what is the final conclusion?
The observed rate was very high, so therefore proper infection control measures should be implied in, especially for cancer patients, because their rates are extremely high.
Did you do any genotyping to check whether it was the same? When you say infection control, we usually mean that there's a single, genotype that is spreading due to horizontally due to poor infection control. Did you all manage to do any genotyping?
We just identified the type of gene, madam, not the typing actually.
Okay, right. Thank you.
Thank you.
Thank you. We move on. Next is a study of group B streptococcus, their characteristics and vaginal microbiome in pregnant women from tertiary care hospitals in Colombo. Authors are Dilrukshi, Kotachi, Disanayaka, and Fernando. Over to you, Dilrukshi GN.
Imagine you are about to have your baby at labor and you are ready to bring your baby to home. At this point, realizing that your baby is not well and not to gain proper weight and suffering from severe disorders, and not to let the baby to see the world. I started from this because this is a global burden and leading cause of neonatal morbidity and mortality. Not only that, adults and immunocompromised patients. Actually, it looks like a crime caused by a small tiny bacteria named as Streptococcus agalactiae, group B streptococci, or the GBS. About 10 to 40% of pregnant women all around the world colonized by GBS and cause GBS and in their rectum or vagina and affect the neonatal or neonates and the fetus, and also gives adverse pregnancy outcomes. Therefore, my project focused on detection of characteristic of group B streptococcus, and it will help to predict the severity of the disease, establish the preventive measures and formation of vaccine against GBS. Therefore, I investigated vaginal and rectal swabs from pregnant women in western province of Sri Lanka. I used culture, qPCR and PCR and more biochemical tests to detect GBS. As a result, colonization of GBS was 25% by culture method and 55% by qPCR method. And also, all the tested organisms, GBS organisms, were sensitive to penicillin. And erythromycin and clindamycin resistant isolates were detected, and when considering the microbiome, lactobacillus species were reduced. These findings could be used to establish the national policies of to prevent the GBS infection. And thank you.
Q&A session.
Thank you. Did you use, what was the culture medium, or did you use any kind of, because vaginal swabs can be sometimes contaminated, to get the group B, did you use any selective?
Yes, madam, I use Todd Hewitt broth to transport and enrich the bacteria, and use blood agar and Mekong agar.
And I mean, any kind of selective medium containing nalidixic or anything to sort of suppress the other flora?
No, madam. I use Todd Hewitt broth to suppress the gram-negative bacilli.
Nothing added to that?
Gentamicin and...
you did add?
Yes, ma'am.
That's right. That's what I was asking. You use some selective media, right? Okay. And what was the virulence? You had also studied virulence?
Yes, madam. C5a peptidase and rib and back genes.
And what did you find?
C5, I got with all the isolate C5a peptidase and others, few percentages.
And did you follow up these patients to see whether any baby developed?
Yes, madam. I got the phone calls to the parents.
Yes.
But not all the parents did not answer the
But did you
phone.
detect any
I got,
infections?
madam, 4 mothers told that their babies were suffering from sepsis.
So of the...
but did not confirm the group B streptococcus, madam. But they suffering from sepsis and fever like that.
Okay, then thank you.
Thank you, ma'am.
So we come to the final presentation. Selected treatment adherence behaviors and dialysis adequacy among patients undergoing hemodialysis in selected government hospitals in Sri Lanka. Lasantika, Vanigasuriya, Hettiarachchi, Amarasekara and Gunawardena. Over to you, Lasantika.
While we are talking more and more about global burden of disease, chronic kidney disease, and especially the diabetic and kidney disease, has become amongst the top 10 diseases that causing global burden of disease worldwide. CKD is the third fastest growing cause of death and fifth commonest cause of premature mortality by 2040. In South Asia, where we live, the increase in prevalence of chronic kidney disease caused by increased prevalence of diabetes mellitus as well as chronic kidney disease of unknown origin can be seen. Usually, when it comes to end stage of kidney disease, the patients need to undergo kidney transplantation or hemodialysis. So, because of lack of kidney donors, many of the patients prefer to undergo hemodialysis as their renal replacement therapy. So, with that, anyway, for having successful hemodialysis therapy, patients need to complete adherence to hemodialysis attendance, prescribed medications, diet control, and also for adherence to fluid restrictions. So, with that, usually the patients need to adhere all these different treatment modalities as well as they need to receive adequate dialysis dose to have successful hemodialysis therapy. So, looking with that evidence, I aimed to assess selected treatment adherence behaviors and dialysis adequacy among patients undergoing hemodialysis in 3 major government hospital dialysis units in Colombo district, Sri Lanka. So, with that, the study was conducted in 2 phases, phase 1 and phase 2, validation study and descriptive cross-sectional study with using validated Sinhalese version end-stage renal disease adherence questionnaire. I found many patients adhere to hemodialysis attendance and prescribed medications, but their adherence to prescribed diet and fluid restrictions are very low. Surprisingly, the patients had increased perception towards adherence to their treatment regime. Regarding dialysis adequacy, more than 50% patients received adequate dialysis dose. Anyway, when the frequency of the dialysis per week was considered, many patients received 1 to 2 dialysis per week had largely inadequate dialysis. Therefore, frequent monitoring of dialysis adequacy and adherence behaviors is needed to provide quality care for the patients. Thank you.
Q&A session.
Okay, thank you. Yeah, now you have looked at the perceptions. How was perceptions assessed in the study?
Actually, sir, we validated end-stage renal disease adherence questionnaire. In this end-stage renal disease adherence questionnaire, there are 2 scales. One scale is to assess direct adherence behavior. The other one is to assess attitude and perceptions of the people towards their treatment regime.
Yeah. Okay, now in your findings, you find that the dietary and the fluid restrictions were the ones with the lowest numbers.
Yes, sir.
Did you check whether the correct information has been given to the patients beforehand? How did you check that?
Yes, sir. Actually, in the end-stage renal disease adherence questionnaire, there are specific questions to assess. That means in relation to fluid adherence, we ask during last week, how many times...
No, not that. Whether the patients have been advised properly in what to do regarding the diet and the fluid.
Yes, actually, I mean, sir, asking about the health education sessions for the patients. Yes, we also assess that part in our study. Many patients told that they have not advice regarding their diet, and but they have advice for regarding their fluid restrictions. But they told that they are unable to control fluid intake because of this temperature, and also they are it is actually it is a habit of them to have a lot of fluid during the day.
Okay. Okay. Thank you.
Thank you, sir.
Come to the end of this session. Thank you so much for all the presenters, and also we extend our thanks to the 2 judges as well.
I thank the chairperson, Dr. Shihan Silva, for a wonderful session, and our esteemed judges and all the presenters of this energetic and exciting session. Ladies and gentlemen, before moving on, a gentle reminder to keep your phones on silent.
Ladies and gentlemen, next up, we will move on to an insightful and spirited debate by our very own students here at the Faculty of Medical Sciences on a very pertinent issue of our time. The topic today will be, this House believes that healthcare professionals leaving the country in the current context is justifiable. Now, I invite our moderator of the day, Professor Bhavanta Gamage, consultant surgeon, who was the captain of the very first debating team of the Faculty of Medical Sciences, University of Sri Jayawardenepura, and an accomplished debater at D.S. Senanayaka College.
I now invite our debaters, Senara Vidhanapathirana and Mirshan Sivakumar of the 29th batch for the proposing team, and Amira Izzadeen and Chaitanan Mokan of the 30th batch for the opposing team.
Good afternoon, everybody. So after fruitful academic discussions, and now we are coming to an interesting program in this academic session. So when we hear the word debate, we get a different mental picture. We have been seeing debates on TV. Some people are taking policy decisions after debates. So of course, in university, among students, we used to debate a lot. I think the current situation is same. And as academics, we debate much more, I suppose. But at the end, we come to very intellectually guided decisions. So here we have today to debate on the topic is, this House believes that the healthcare professionals leaving the country in the current context is justifiable. So the proposing team is on my right side. The team leader is Ms. Senara Vidhanapathirana from 29th batch. And the other member of the team is Mr. Mirshan Sivakumar, also from 29th batch. And on my left-hand side, the opposition team is led by Ms. Amira Izzadeen from 30th batch and Ms. Chaitanan Mokan, also from 30th batch. So let me invite the backseaters to come to forward. Don't worry, there won't be any chairs going here and there. So please come forward without wasting much time, because we are running out of time. Let me invite Senara to start the proposal.
I hope I'm seen and heard. Yeah. Starting my speech in 3, 2, 1. Ladies and gentlemen, esteemed guests, debaters of the House, as team proposition, we'll be proving to you that this House believes that healthcare professionals leaving the country in the current crisis is justifiable. So firstly, what is this current context that we speak of? That is the current socioeconomic crisis which has led to inflation, the fuel crisis, and obviously the scarcity of resources in terms of the health sector, in terms of medical equipment, in terms of supplies, in terms of infrastructure. So as to justifiable is reasonable in terms of three stakeholders. The three stakeholders being, firstly, in an individual basis, secondly, for your families, and thirdly, for the country as a whole. So moving on to the case division of team proposition. As team proposition, we have three main arguments. Firstly, individual freedom and safety comes first. And secondly, that government reforms should be made first to retain professionals within the country. Otherwise, you can't expect us to be the only people sacrificing here. And thirdly, we gain foreign remittances out of our professionals who leave the country. Moving on to the case of team proposition. So firstly, individual freedom and safety. Every human has a right to migrate and they have the liberty to live wherever they want in accordance with the Sri Lanka national policy on labor migration, right? So you should think from the perspective of a healthcare professional. It is human nature to want a better life, right? So what are these reasons that we have to leave the country? It has two aspects. Firstly, we have many benefits abroad. Secondly, there are many disadvantages within the country. As for benefits abroad, firstly, obviously, there's a very high pay. But in Sri Lanka, we have invested so much time and effort to this degree. It's not just free education. What we get here is we've put in so much effort to get into the faculties, right? And here we sacrifice so much of our social time on this degree, right? And after you get your degree, you end up getting a very low salary with very little benefits. But then if you take countries like Australia, for example, a consultant gets paid 11,400 USD, which is equivalent to 34 lakhs in Sri Lankan rupees. Whereas a Sri Lankan consultant gets paid only 3.5 lakhs, and if your salary is above 3 lakhs, you have a tax cut of about 1 lakh. Right? So this is the pay gap that we have in the country. Moving on, second argument, that is the quality of life abroad, right? So you have very feasible working hours and work-life balance is so much better than here. You have better living conditions, more safety, more stability. And in terms of your families, you have better schools and quality education, ladies and gentlemen. So moving on to the disadvantages in Sri Lanka. So this has four aspects. Firstly, we have the political and social instability that we have, right? So it's not just us, our children are also suffering. So look at your families, ladies and gentlemen. Even though you're a doctor, your children are suffering right now. For example, paper marking is late. Our A-level students haven't got their results yet. They don't know when they'll start university again. They don't know if they'll have a future here. Moving on, if we take our healthcare sector, our intern postings, they say will be delayed even beyond November this year. So they've got the degree, they can't start a job. So do you see a future within the country, ladies and gentlemen? So if you can't aspire, if you can't have big dreams, what is the point of staying in a country? So you should think as an individual, what is good for you? Moving on to the second argument as to why it's disadvantages in the country. Financial responsibility. Because here, there's high inflation. There's a very high cost of living. But because of the tax cut, your pay is very low. Apparently, some SHOs have a negative cash balance in their salary with their loans. So how can you survive? What is the point if you're suffering as a human being? What is the point of living in a country which doesn't give two hoots about you? Moving on, if you take interns, for example, they only pay 57,000 for an intern, whereas the hospital security guard gets paid 60,000. Moving on to the next argument, that is reduced job satisfaction, ladies and gentlemen. So because of the lack of resources, our healthcare professionals are overwhelmed. So they are unable to provide the level of care that they want to. So where is the job satisfaction with the limited resources that we have? And besides, when you go abroad, you'll get a peace of mind. So what we require as healthcare professionals is firstly, we have to make sure that we have our own health and our own mental well-being in place. Otherwise, how can we heal others if we aren't feeling good ourselves? Moving on. Finally, we have a safety concern right now. With the socio-political situation that we have a social unrest in society. There's a very high crime rate. And so along with that, you might want to protect your families. You might want to protect your children. So that is why you might want to go abroad. So you have to think as a human being first. Because we have to save ourselves if we have to save the country, right? So moving on. What if a country someday becomes a country like Afghanistan? Might as well go to another country and safeguard our identity somewhere else. Because if there's no country in the first place, what is the point of us sacrificing? So I believe we've proved to you as to why it's justifiable at an individual level and at a family level. And my second speaker will be proving to you as to why it's justifiable as a country as a whole as well. Thank you.
Thank you very much, Tanara. So the argument against the proposal will be presented to you by Ms. Amira Izzadeen from 30th batch. Over to you, Amira.
Good afternoon, ladies and gentlemen, moderator sir, and the debaters of the House. You all heard a lot of values. So I will take you all away from that into something a lot more meaningful. Now, an excerpt from the article in the Journal of Ceylon branch of the British Medical Association states that medicine aims at preserving the lives of human beings as long as possible, at curing diseases and preventing suffering. As this devotion to the cause of human life conditions the traditions, methods, and regulations of medical practice, it is ranked amongst the noblest of professions. Hence, service to humanity and not personal gain is an ideal to the profession, and one who chooses the profession must assume the obligation to conduct himself in accordance with that ideal. Now, this practice of medicine brings one in contact with three units of society: the patient, the public, and the fellow practitioners. So to serve humanity, the practitioner must ever be conscious of the interest of these three units. Now, ladies and gentlemen, standing here are medical professionals and medical students. We are here to service our country. Now, if you consider Sri Lanka, we are one of the only countries that have a much admired, publicly financed and delivered free education system. We are not like the other countries that have to pay for our education. We are being paid to study. So if you consider how this situation works, we learn from the money of the general public, and our skills are what have been given to us by the people of our country, Sri Lanka. They do so with the hope and belief that they will be taken care of. And so when the very people chosen to do the taking care of, that is us, when we leave to foreign nations, we lose the opportunity to pay that debt back, to pay the debt to the public back. So while there is obviously no legal tether binding you to servicing the public, Team Opposition strongly believes that it is our duty to do so. Regardless of whatever value comes forward, it is our duty to do so. A profession that stands above most in service, in terms of service, care, and hope to a country, we would like to emphasize the fact that healthcare workers, when they migrate, the moral obligation to the public that provided for them will not be fulfilled. Thus, migration is a sign of misery to our country. Now, taking into consideration what Team Proposition kept talking about, individuality and care for the family. This is not like, once again I would like to emphasize, this is not like any other profession. You all chose to do this, and you all were chosen to do this. So you all have to understand that it's not a simple case of, okay, I want to take care of myself and my family only. You are taking care of a whole nation. You're taking care of millions of peoples. And you all chose to do this, ladies and gentlemen. So you'll have to do it to your utmost capabilities, regardless of the situation. And if you take our current crisis now, leaving or migration usually occurs from developing to developed countries. We are a developing country. And who do you think needs more help? The developing or the developed countries? Individuals from the developed countries do not come to our country. We just keep losing. So we are always going to be at the back end of the situation. We are always going to be the ones failing no matter how much we try. Now, if you consider this situation of migration of the healthcare professionals who are considered to be one of the most skilled workforce in a country, now data suggests that one of the greatest challenges that a country faces to maintain and advance their competitiveness levels is to ensure a flowing and substantial or sustainable human capital accumulation. As I mentioned before, we lack that. And that is because of this migration. That is because we choose to choose ourselves and our families over our duty, over our job. Once again, it's a matter of choice. You all weren't forced to do this, you all chose to do this. And I would like for that to hit you all in the hearts, in the minds, in the souls. And now if you consider our current economic crisis, our drug shortage, and all other issues that are affecting our country, I want you all to think, and I want you all to ask yourself, who do you think deserves help more? Us or them? Ask yourselves that, and I hope you find the answer to that question. With all the negatives that is affecting our country right now, we are needed in this country. It's the cream of the crop that leaves, and it is the cream of the crop that is needed to further our country and to make it a better place for everyone. So Team Opposition strongly believes that it is not justifiable for healthcare professionals to leave the country and migrate. Thank you.
Thank you, Amira. So let me invite Mishran Sivakumar from the proposition team to present his argument.
Ladies and gentlemen, debaters of the House and esteemed guests. My first speaker clearly mentioned why is it justifiable for the healthcare professionals to leave the country in the current context, depending on the benefits they'll get when they go to a new country and the disadvantages they have in this country on an individual basis and depending on the family. So, as the opposition team said, the doctor profession is one of the noblest professions, and this deserves a special place in the society. But doesn't the country need to take better care of them in the first place? For the country, like for professionals to stay in the country, they need an incentive in the first place. If the country doesn't take care of the healthcare professionals in the first place, why would they want to stay in this country? This brings us to our second argument. So our second argument is based on the government reforms. So first of all, let's take a look at the country's budget allocation for the health sector over the years. Okay? So in 2021, the budget allocation for the health as a percentage of GDP was just 1.7%, while that of defense was 2.3%. And Sri Lanka's defense expenditure has been on the rise since the war ended, where it should decrease. And with the economic crisis, Sri Lanka had to reduce the state expenditures. But where did they make the biggest cut? They made one of the biggest cuts in the health sector. They reduced it like nearly 0.5% cuts in this health sector, while they didn't reduce that much in the defense sector. And if all this money has been reallocated towards the health sector, most of the issues could have been solved. So one issue that can be solved is the medicine shortage issues that we have these days. And we could have increased the salaries in the first place. And the people, healthcare profession could have had more job benefits. This would have had at least some incentive for them to stay. And there's an extra distress that the doctors go through each and every day because they couldn't treat the patients, because there is no medicines. They don't have enough surgical equipments to do the surgeries. Even the government postponed some of the surgeries. They closed surgical units because they didn't have enough money to provide them with medicines or surgical equipments. So the country should make or do something towards this. Unless that, they don't have any point in staying in this country. Moving on to my next argument, before moving on to my next argument, I'd like to address some of the points the team opposition said. So they talked about free education we received. So just because we received free education doesn't mean we have to stay here and live in a prison and suffer. And the free education money that the country spends on us can be actually paid back. And they've been talking about more obligation, it actually can be paid back. So if you take the amount of money spent by the government on a single medical degree, it's around 62,500 USD. Why? Okay, if you take, so I'll give you some stats here. So take Australia for an example. So in Australia, they pay just an MO like 3,500 USD after the tax cuts. So if they bring on a bond system, just like they do with the PG trainees, okay, if that system could get money from them, they could actually pay back all the money that the country spent on their education in just like 3 years. But the country isn't doing anything to increase the salaries. And talking about the gaps left by the professionals leaving the country has to bring a change in the education system first. So they had to increase the intake and produce more healthcare professionals to compensate for those who leave the country. And they had to promote PG training. So in this country, because of the lack of money, they pay a less amount of money to them. So they can't manage families while studying. So most people don't want to do PGs these days. And the pass rate is also really low in this country. But compared to UK, US, they have nearly 40% pass rate. And Sri Lanka tries to limit the amount of consultants the country has. With that, I'll move on to my last argument. So they've been talking about the country isn't benefiting from it. They are having a loss. So actually the country will benefit from the healthcare professionals leaving this country. First thing they'll get is the foreign remittances. Our country is in a dollar crisis. They don't have enough foreign exchange money. So if the healthcare professionals go to another country and if they could send back dollars, that issue could be solved. Another good thing that will happen is the network or diaspora effects. So now that the trade links are, so they could go there and build new trade links. And it could bring on new mutually beneficial opportunities. So these connections usually open doors to new research opportunities, knowledge exchange, and collaboration. And also, you could actually get external funding to the country, which could solve the medicine short supply issues. And also, there's the human capital formation. So they could actually acquire new skills, and they could come back to the country as talented professionals. So with that way, they could actually serve this country, and it's actually like an investment for this country. So there are so many advantages on why, if they leave the country, even if they leave the country, there are so many advantages that is coming back to the country. With that, I'll clearly state that it's justifiable for the healthcare professionals to leave the country in this current context. And I rest my case. Thank you.
Thank you, Mirshan. Let me invite Chitran Mohan to give his arguments opposing the topic.
I would like to address the adjudicator, my fellow debaters, and the jury. So before addressing the proposition team's points, I would like to bring up a story into this debate to entertain y'all. So this story is orientated around a mother who has 3 sons in a community. And she had poured her blood and sweat into raising these 3 childs to become a better self of themselves. So eventually, the eldest son becomes the best in the community at a point where the community needs him for his consult. But what happened is, he looked into the outside world and thought, the outside world is more better than the community itself. So what he thought of is to leave the community and go and live in the outside world to better himself in the career and also live a better lifestyle. So, what will happen right now to the community and all to his family, which is dependent on him? Ladies and gentlemen, this is what this topic is all about, whether it's justifiable or not. Just like that, putting a lot of people's health in risk just because a single doctor thought that a fancy food and fancy school is better for his children is not justifiable. It's really absurd to think of. So coming to this, let's go back to the story. So there's the other 2 brothers of the eldest son who are still following his pathway, and now he's went outside that there is no one for those 2 brothers to follow up. So this brings us to the opposition team's 3rd point, which is a vicious cycle where when a certain number of doctors leave the country, the following doctors who are following their pathway, learning from them, decides to move out of the country. Why? Because what happened is that they are losing their learning source, and in the same time they are getting an idea that this country is done for, that they don't have a future in this country and they just want to leave. Given the chance, this country can be developed if we all have the motive. That is our job actually in here. Now, speaking of which, let's address the proposition team's argument's 3rd point. So in an article from the Human Resource Department, which is presented in the Sunday Times in 2011, has stated in 1970s, the government actually motivated doctors to go abroad just because they wanted the dollars to pour in. But what actually happened is something else. The doctors went there, and initially they worked and came back with the money, but what happened after that is they just took the families and they went and permanently lived there. So what happened is there is a major investment loss for the entire country, even though that didn't work. Well, other than that, what we have to say is this is not only regarding the patient, just like my first speaker said, it also includes the entire medical education system as well. As we can see, the shortage of doctors. So in a current population index study shows that for 1,000 people in this country, there's only 1.04% of doctors. So that means it has been reduced by a huge amount from the 2000 beginnings. So what does this result is in that the education system, the medical education system, which is special to this country because of its free and also better system than the other regions in the Southeast Asia, has been in a major instability position where medical students have a problem on lack of learning because there's no one to teach. This, ladies and gentlemen, is a rising problem in this country right now because in another article from a local studies around the Western province, which includes 3 universities, have showed more than 76% of medical students are thinking of now leaving the country right after they get the degree. So you can see how massively this is impacting our country right now. It is not only the present, but it is also the future is being in a really bad state in our country. So as doctors who have went through like 5 years of medical training and postgraduate training and a lot, which is a hard way path, we must not feel sorry for our actions. We must be better. We must learn that the solution for this is not to give up, but to be better and follow the country's crisis and work. Thank you.
Thank you, Chintan. Now we are coming to the counter arguments. Let me invite the opposition leader, Ms. Amira Izzadeen, to present the counter arguments.
Ladies and gentlemen, if we focus on the three main arguments that team proposition brought up, individuality along with family and children, government reforms and foreign remittances. My co-speaker of team opposition clearly stated that foreign remittances is something that is very far-fetched. Now, if you consider foreign remittances, and our current crisis, with the dollar crisis, how much do you think foreign remittances would be worth to our country right now? And once again, the point that he mentioned, I would like to reiterate. These doctors, they will take their families and leaves. Foreign remittances will not be coming to our country because they choose to take their family and leave. Therefore, foreign remittances is of no use to our country if healthcare professionals choose to migrate. Then if we take government reforms, for government reforms to even be of any use, there has to be high-skilled professionals in the beginning. Now, if you consider how this brain drain or migration of individuals occurs, when they occur, there is a decreased quality of care, reduced healthcare investment, economic consequences, and an inequitable access to healthcare. There are so many negatives that occur when the highly trained professionals leave the country. And therefore, government reforms would be of no use if there are no highly trained, skilled professionals to start it up and to take it forward. They are needed in this country because of the disadvantages that would occur if they are not there anymore. And once again, if we take individuality, if we take family, and if we take children, ladies and gentlemen, one thing team proposition refused to focus upon is why we are choosing this profession. We are choosing it for the people. It is not only for us. It is not only for the individuals. We are choosing to be doctors. We are choosing to be healthcare professionals for the country. Please, let's think of the people that we have to service. And our country, Sri Lanka, has poured money from the people, from the taxpayers' money for us. And if we do not pay it back, which is our duty as team opposition thinks, it will be of no use. So we say that healthcare professionals leaving the country is not justifiable, especially in the current crisis, especially from our country, Sri Lanka. Thank you.
Thank you. So the last speaker of the debate, it's Senara, the captain of the proposing team, to present her counter arguments.
Ladies and gentlemen, so let me tell you a story for a story, right? So they kept on harping on and on about free education and how you have a moral obligation to serve the country, right? But let's say that you were drowning in a flood and a person rescued you, right? That is free education, saving you when you were in poverty, right? But then this same person sexually abuses you. Are you going to hang on to this person forever? This is exactly what you want us to do. Free education doesn't mean that it can imprison us forever. It can't hold us back in terms of our passions, our dreams, our future. That is what you expect us to do. We can't. That is not justifiable, ladies and gentlemen. Moving on. You kept on saying that we chose to do this, right? But we actually had a PPD session once with our entire batch. And out of our entire batch, this particular lecturer came and asked us as to who exactly wanted to do medicine purely because of their passion for it. Out of 160 students in our batch, only 3 students raised their hand. Whatever said and done, in reality, all of you did medicine because deep inside you had passions. You wanted to buy that car. You wanted to make that house. You wanted to get that new phone. Whatever said and done. And you might have wanted to serve the country, yes? But deep inside, would you want to sacrifice your entire life, your lives of your children, purely for a country that does not care about you? I don't think that is true, ladies and gentlemen. Moving on, you came and said that it's a holy profession. It is a holy profession. Yes, we should serve the people. But if it is a holy profession, might as well treat us well. You should treat us well if it's a holy profession. But our healthcare budget keeps on reducing. They don't increase our medical supplies. They don't give us resources. So the government doesn't give us the incentive to stay. So if the government gives us the resources, the budget, at least a certain incentive for us to stay, then we would stay. We are actually good human beings. Doctors really want to serve the people, yes, but you have to give us an incentive to stay back. Moving on, We came up with three main arguments under which individual freedom and safety, you just completely disregarded the fact that we are human beings too. So I hope we proved our point. And we proved to you that it's justifiable in terms of an individual, in terms of the family, in terms of the country, as to why it is justifiable to leave the country in the current context, ladies and gentlemen. Thank you very much.
Thank you very much for interesting facts, for giving us a lot of things to thought about. And so who's going to judge? So as debaters, we know what is coming out of our mouth is not, sometimes may not be real sentiments in our hearts. So, for both teams, that's true, I think. So everybody has their difficult times and good times and bad times, same for the country as well. So it's, but the point is some people and countries have bad times all the time. So, so we make to have some changes to improve ourselves as well as our country situation. So I'm not going to give the judgment. So once again, thank you very much for both teams. And I think we had good things. We learned a lot of things, facts from your talks. So I'm not going to give you any judgment on that. Let the House judge us what we should do. Thank you so much. Thanks.
Big round of applause for our debaters, and a big thank you to Professor Bhavanta Gamage for being an excellent moderator. I invite Professor Bhavanta Gamage to hand over the certificates of appreciation to the students now. Senara Vidana Patiran and Mirshan Sivakumar of the proposing team, ladies and gentlemen. And we have Chetanan Mokan and Amira Izzadeen of the opposing team.
Ladies and gentlemen, on that scintillating note, we will be breaking for lunch, and we will be reconvening at 1:45 p.m. During the break, you are more than welcome to go through our poster presentations, which are displayed outside in the corridor on the LED screens as a rotation. The poster numbers will be displayed beside the screen, and each poster will be displayed for 3 minutes before rotating to the subsequent one. And also, feel free to visit our sponsorship stalls during the lunch break. Thank you.
Thank you.
Welcome back, ladies and gentlemen. We will now be having our next symposium. We are happy to have the newly established Faculty of Dental Sciences of the University of Sri Jayawardhanapura collaborating with us for this session, which will be on integration and harmonization of oral health, which is an essential but underrated area, and we look forward to having the speakers share their insights with us.
We now invite the moderators, Dr. Amirtha Varshini Rajaganesh and Dr. Rasika Ekanayaka on stage to start the session. Can we please have the speakers also on stage? Dr. Lakmal Kulasekara, Dr. Hemantha Amarasinghe, Dr. Ananda Ratnayaka, Dr. Priyaka Palipana.
Good afternoon, everyone. We would like to welcome you all to our symposium on integration and harmonization of oral health. To give a brief introduction to the symposium, I would like to invite Dr. Lakmal Kulasekara. Dr. Lakmal Kulasekara is a senior lecturer and the head, Department of Basic Sciences, Faculty of Dental Sciences, University of Sri Jayawardhanapura. Over to you, Dr. Lakmal.
Thank you, Rasika, for the kind introduction. Good afternoon, you all. And the topic for today's symposium from our end is integration and harmonization of oral health. All right. Sometimes we tend to miss little things in life. One such little thing is that oral health is an integral part of general health. Oral cavity has been described as the window to general health. And also, one cannot simply have good general health without good oral health. And also, the mouth is considered to be the critical point of contact with the external environment in some physiological processes such as speech, mastication, swallowing, and digestion of food. And not to forget the sound integration and the individual appearance as well. So, according to the World Health Organization, oral health is defined as the state of the mouth, teeth, and orofacial structures that enables individuals to perform essential functions such as eating, breathing, and speaking. And this encompasses psychosocial dimensions such as self-confidence, well-being, and the ability to socialize and work without pain, discomfort, and embarrassment. So, anyone can identify this is not mere absence of oral disease, but we should know what oral diseases are as well. Dental caries, periodontal disease, tooth loss, oral cancer, orodontal trauma, noma, and birth defects such as cleft lip and palate are the common oral diseases. And according to the WHO, the most common non-communicable disease worldwide is oral diseases. And it affects like 3.5 billion people worldwide. So these infographics came straight away from WHO website. You can see almost half of the world's population are affected by oral diseases. And out of them, 3 out of 4 people affected with these oral diseases are living in either middle or low income category countries, countries like us, countries like Sri Lanka. Few facts from Global Oral Health Report 2023. Untreated dental caries in permanent teeth is the most common health condition according to the Global Burden of Disease 2019. So, the unfortunate thing is treatment of oral health conditions is expensive, and it is usually not a part of universal health coverage too. So you can clearly understand the vulnerable groups, the vulnerable countries, less disadvantaged people from low socioeconomic status. Now these people tend to undergo without proper dental treatments simply because of lack of adequate facilities. And one major point I would like to stress here, the oral diseases are caused by a range of modifiable risk factors, and these risk factors are common to many non-communicable diseases, including sugar consumption, tobacco use, alcohol use, and poor hygiene. So, now one can sense there's a case for integration. To make the case stronger, few more facts. Now, poor oral health has been linked to increased risk for cardiovascular disease, diabetes, and other chronic conditions as well. And also from the dental point of view, among adults who have lost their natural teeth, studies have shown there's a significant impact on nutritional intake. So it's kind of a bidirectional association. And not only that, poor oral health exacerbates some underlying chronic diseases. For example, diabetic patients with diabetic patients with periodontitis, they are at 6 times greater risk for worsening glycemic control. So not only the medical reasons, there are some social reasons as well. 51 million school hours are lost each year due to dental problems. So to make whatever the facilities that are there and utilize them more productively, integration is the only way. But what's the reality? Even though there were several attempts made to integrate oral health to the general health concepts were made, still the reality is not that great. In 1978, essential oral health was introduced to the context of primary oral health care. And also notable collaborative efforts were initiated between medical and dental practitioners in their areas of education and practice. But this statement straight away came from the WHO website. Still, in the process of integrating oral health into primary care, even the primary care has remained slow and unsteady. So in the fields of education, in the fields of curative sector, in the fields of preventive sector, the situation is further gloomy, I would say. So there's a strong case for better integration. How can we do this? We can do this by sharing information, providing basic diagnostic services together, and also doing consultation in more systematic and sustained manner. And also if the dental and medical professionals can involve in integrated practice where there's a far better chance of identifying disease precursors and underlying conditions in keeping with the patient-centered model of care. Finally, this kind of approach, the integrated, harmonized approach, will provide significant cost savings to the healthcare system. Now, that is very important in countries like Sri Lanka. Now, in a country where compartmentalization is the norm, in the University of Sri Jayawardhanapura, there's a new model. The dental faculty, newly established dental faculty, teachers from the Faculty of Medical Sciences are teaching our students. And we are utilizing the facilitates in a better way. So this is the kind of integrated, harmonious approach that we should inculcate in our practices. So I strongly believe we have set a nice example for the future generations to follow. I hope, sincerely hope, may this be a great example, and even not only in the academic fields, but in the other fields as well. Thank you so much. Have a good day.
Thank you, Dr. Lakmal, for the introduction. You have set the stage and made it very clear that we cannot have good general health without good oral health. Next, I would like to invite Dr. Hemantha Amarasinghe to bring in his presentation. Dr. Hemantha Amarasinghe is a senior lecturer, Department of Community Dental Health, Faculty of Dental Sciences at University of Sri Jayawardhanapura. He has served the Ministry of Health as a dental surgeon and as a consultant in community dentistry for a period of 30 years. He has been the past president of the College of Dentistry and Stomatology of Sri Lanka and the past president of the College of Community Dentistry of Sri Lanka. He is a former national coordinator, Voice of Blue P victim group of oral cancer in Sri Lanka.
Thank you very much, Parshi. Happy to be part of this worthy symposium. I think first Dr. Lakmal has given a brief introduction. So what I would want to say is more than 90% of the oral diseases are preventable. So in this level of prevention, we can work out all the oral diseases. 95 prevention mean anything, what is the only 5% left. But even that, I think he also has shown the global burden. I will show you the dental oral burden in Sri Lanka. Then we are proposed, even being in the Ministry of Health, we propose some restructuring of the services that I will discuss with you. Right, this is again, as I said, I can put any of the oral disease into this model. The primordial prevention, primary prevention, secondary prevention, and tertiary prevention. Especially the dental caries, the healthy primordial prevention, what we can do. What we can do, the diet and brushing. Those are the two main things. If the children are brushing very well and diet control is there, I think no dental caries at all. That is dentistry. That is dentistry. And the other one, primary prevention, the fluoride gel application, we can prevent caries. And then secondary, we can screen. I can put this model into any of the dental disease or even to the oral cancer. Screening can do a lot. So 95% can be prevented. Then global burden, Dr. Lakmal also touched. I touched a little bit more detail, especially the oral disease as affecting half of the world population, even though it is 95% preventable disease in the world. That is the story. 2 billion caries of permanent teeth. Severe periodontal disease estimated to affect 19% of the adult population in the world. Edentivism, the total tooth loss. In Sri Lanka, I will show you the figures. About 60 years, 23% of the elderly, not having a single tooth to eat. Oral trauma, again 1 billion people. Oral cancer, 377,000 cases per year, 2020. 177 people dying in this world. And also cleft palate, again prevalence 1 in 1,000 to 1,500 birth. So then the global burden, this was in the Lancet 2009 to show the global case numbers with comparing with the NCD oral diseases, 3,474 million. Whereas the cancer is 86, but we know that mortality is very high even with the other NCDs. So this is the case in the 95% preventable diseases. So then I will get on a little bit on our burden, and I will show you our restructuring process that we have proposed to the Ministry of Health. So this is the again the case. Among 5 years, we have conducted 4 times we have conducted national oral health surveys in this country, 83 and 94 and 2002 and recently 2015 and 16. Every 10 yearly we are conducting this survey in Sri Lanka. 5 years and 12 years. Can see now, even now, in the recent survey, more than 63% of the children, 5 years mean the children who are coming to the school, grade 1, having dental caries, having at least a 1 carious cavity in the mouth. And 12 years, 30%. Again, the prevalence of healthy gum in 12 years. 12 years, 55%. Half of the children only having the healthy gum. And the other one, this is again to highlight 5-year-olds, 63.1% of them having caries. And this is again another thing. In the survey, it has been shown that in Sri Lanka, 12 years, the everyday eating of biscuits, buns and cakes, even we had now today. 12 years, every day, 38% of the children at least every day they eat biscuit, buns and cakes. Those are the cariogenic substances throughout their eating. Even the biscuit is the case nowadays. Children are eating from morning to evening by watching the TV. And 15 years, you can see 45. So this is the pattern. And the other one, main thing, brushing. Brushing twice a day. The children, only 50% of the children brushing twice a day. So then how can we do this job? How can we prevent? Then again, with the fluoride toothpaste. So those are the messages now. Brush twice a day, use fluoridated toothpaste. See the figures. 20% of the people in this country not brushing with fluoridated toothpaste. The Ministry of Health message is very clear. All the people in this country should use fluoridated toothpaste irrespective of where they are living, even in Anuradhapura, Polonnaruwa, where they are living. That is the message. But see, 20% of the people are not choosing. This is again oral health visit to the dental clinic. See, even these figures given here, those are problem-oriented visit, not for screening. They are going for if there's a pain, if there's any problem, only they go to the dental clinic. But you see this distance to the nearest dental clinic. 65% of the population in this country having at least 5 kilometer radius access to the dental clinic. At least one dental, even private to government, one dental clinic in a 5 kilometer radius. They are not visiting. They are not visiting. That is the problem that we have. And this is our aim 20 functional teeth at the age of 80. However, as I said earlier, the attentiveness among 65 to 74 in Sri Lanka is 11.3%. So this is again oral cancer, again the same story, 6 cases diagnosed every day, and among them 70% at stage 3 and 4, and 3 people dying every day due to oral cancer. So this is another scenario. Again, from the 2009 Lancet, it says economic impact of oral diseases, total expenditure on dental health care in millions, can see $40 USD. And per capita expenditure on dental health care, US dollars 1.8 per capita divided by population. Total productivity lost due to 5 oral diseases in million, 197. The huge economic impact by oral diseases. And I think, as Dr. Lakmal said, integration, it's a case. We really want to work it out. And this is the new development in the WHO in the 2020, 23rd December, had a big conference and decided achieving better oral health as part of the universal health coverage and non-communicable disease agenda towards 2030. I think the oral health as considered in the NCD agenda from year 2020. And as we discussed, the evidence for integration is three things, especially common risk factor approach. I think we know Sham and Watson 2005 introduced, as we always discussing bidirectional relationship, some oral diseases with the NCD. And the other one is treatment of oral disease takes a lot of family time and the money. These are the two other things for even for integration. So we can have common clinic and do everything together. That's what we always proposing. And I think we all know common risk factors. And this is again Chairman Watt common risk factor model. We share all risk factors: smoking, alcohol, exercise, injury, diet, everything, NCD plus all oral diseases we share. So why not we together control these diseases? We have WHO based bias as well. Then this is the one I really want to come into, the proposed restructuring of the oral health services with integration. This is the one I really want to discuss with you. This is, I think, the first part here is the MOH setting. MOH, primary healthcare workers, midwife, PHIs working in this area. Whereas this is our school dental services. Manned by school dental SDT, means school dental therapists. They screen year 1, year 4 and year 7. And we have adolescent dental ADC, mean adolescent dental clinic dental surgeons. They screen year 10 and also they look after the rest of the children, as well as they see little bit on preschool as well. So now the case, as I said earlier, when the children entering here in the year 1, 63% of them having cavities. So being here by treating, doing everything, I think will not work. What we have to do is, we have to jump into this area. What is this area? This is where the MOH and their staff is working. So we better start from here, eligible couple register, or pregnant mother. I think we have a very good program under the Family Health Bureau. We were able to cover for year, as you all know, at least 3 lakhs, 53 lakhs pregnant mothers are registering. Out of them, we were able to screen, not to complete the treatment. At least we were able to complete 80% of the pregnant mothers even last year. 80%, 20% only left. That is a good thing. But anyway, we want to strengthen it by doing treatment completion, to do everything, not just screening. So what we propose is, our whole team should come here. Come here and attend here, rather than being in the school dental clinic or a hospital dental clinic or adolescent dental clinic. We have to come here. And then we can do something in the infancy at 9 months, when the mother bringing an infant for the measles vaccination. That is the time where the teeth also getting erupting, maybe another month or just erupting at this time. We can give some input to the mother at this stage, if we have people here. So always we are pushing PHM to do this job. I think that need to be continued. But thing is, we should need more inputs here. Then only when we can give the message, the mother should brush the teeth at the time of eruption. Once the teeth are erupted, sometimes they wait to erupt all the teeth, or 3 teeth, 4 teeth. No, now our message is, once the teeth erupt, you have to brush your teeth. You have to brush your child teeth. So those messages can be given here. Other thing is the preschool. Preschool, if we can treat all the preschool children, definitely we can make here free dental care is free, calculus here, if you do better this one. So that's why we really want to give the school dental therapists as well as the dental surgeons in this country, please come into this place. So then we have to work with the medical team. So medical team is working there. So I think it is better we can work in the community and cover all the preschool. Nowadays the preschool coverage is very low. One school dental therapist is seeing only 500 preschool children. That is not enough. Rather than they can stop here and come here, even better. That's what we were always proposing. With this proposal, I think we want to go ahead. So whole this MOH stream, we have to work in the future. So this is our proposal already given to the Ministry of Health to go ahead with the integration. With that, I will conclude my presentation. Thank you very much.
Thank you, Dr. Hemant Amarasinghe, for putting the burden of oral health diseases into perspective and giving clarification on the necessity of integration of oral health and general health care. Our next presenter is Dr. Ananda Ratnayaka. Dr. Ananda Ratnayaka is a senior lecturer, Department of Oral Surgery, Faculty of Dental Sciences, University of Sri Jayawardhanapura. He had been the past president, Sri Lanka Association of Oral and Maxillofacial Surgeons, and the past president, Government Dental Surgeons Association as well. Over to you, sir.
Thank you very much. And good afternoon, everybody. And Dr. Lakmal well said that there is no general health without oral health. But of course, for generations, we practiced in isolation. We dental surgeons, we practice in and around oral cavity or the diseases of the oral cavity or the perioral tissues, while our medical colleagues, they practice or look after the patient's other part of the body. Well, but ultimately, we are actually going for one common goal, that is the general health of the patient and the quality of life. So let us bring the mouth back into the body. We know oral health is vital to the general health, well-being, and the quality of life. Well, how does it affect what are the systemic diseases? How does the systemic diseases affect in the oral health or the oral manifestation? We know if we take almost all the type of systemic diseases, they in one way or the other way, they also affect into the oral health as well. It could be either direct pathways via the disease, or it might be due to the influence of the treatment modalities. Well, if you take from the birth and development, we know very well, we know that patients with cleft lip and palate and Treacher-Collins syndrome or the Pierre-Robin syndromes, if you take most of these syndromes, they have oral manifestations as well. Well, infections, nutritional conditions, hematological conditions, gastroenterological conditions, endocrine, whatever it is, they all have a kind of oral manifestation in oral cavity or the perioral region. These are some of the examples. Infective causes. We know this is a patient from herpetic gingival stomatitis. Other than the herpetic, this is actually the type 1 type of herpes, but you know the type 2 herpetic infections are mostly below the belt or the genitourinary areas, but they have counterparts as well. And other than this, the herpetic infections, we know the hand, foot, and mouth disease and things like that. There are various other diseases, viral diseases that affect oral cavity as well. Well, another example, this is bacterial infection. We know a lot of extrapulmonary tuberculosis. We see, as you can see in the picture over there, this is a tuberculous ulcer appearing in the tongue, and we see a lot of patients with submandibular and cervical lymphadenopathy due to the tuberculosis. Well, syphilis, fortunately, we don't see much of patients nowadays. The classic oral lesion and the syphilitic leukoplakia, those are the other bacterial infections. And if you go to the deficiency status, so the nutritional status, you can see in the first picture, the classic picture of iron deficiency anemia, smooth tongue with the depapillated and the tongue. And the second picture, you can see Mollius-Hunter glossitis, which is basically due to the vitamin B deficiencies. The good thing or the significant thing is actually these features, most of the time, these features appear in the oral cavity even before the hematological indicators in our blood picture or the blood counts doesn't appear, give the indications to these deficiencies. Well, this is again the angular cheilitis is a common feature in hematological deficiencies. The other one, the leukemic deficits of the oral cavity. On the oral cavity, leukemic deficits, we can see other hematological conditions. Well, if you take into the dermatological conditions, we know that almost all the dermatological conditions, they have a oral manifestation in the oral cavity. The commonest one is the oral lichen planus, which gives actually the huge burden to the patients. We can see different types of, in these pictures, we can see different types of oral lichen planus. And other dermatological conditions, this is a classic feature of erythema multiforme appearing in the oral cavity. And again, you can see the oral lesions are preceded to the systemic lesions or the dermatological lesions in the erythema multiforme conditions. And this is, of course, again, the reasons behind if you take the infections and the drug reactions. So basically attached with the medical problems. Other conditions are like Behçet syndrome. Again, the oral lesions are preceding the other lesions. If you take the gastrointestinal conditions, the celiac disease or the Crohn's disease, almost all these conditions, ulcerative colitis, they give oral manifestation. In this upper picture, this is actually the classic feature in the oral cavity of the Crohn's disease, and this is the other one is one from the ulcerative colitis. Well, if you take other syndromic patients, you can see in there are a lot of syndromic conditions where oral and perioral tissues are affecting. This is one of the patients with Peutz-Jeghers syndrome. You can see cafe olate pigmentation in and around the oral cavity, and the similar conditions you can see conditions like McCain-Albright syndrome as well. And if you take endocrine diseases, there are various endocrine diseases that has oral manifestation. This, of course, the Addison's disease patient with Addison disease. Immunological conditions, immune deficiencies, of course, the Kaposi sarcoma and the hairy leukoplakia, all these are very common in immunocompromised patients with HIV as well as the organ transplanted patients. And those are the manifestations of systemic diseases in oral cavity. But what about the treatment relation? Of course, most of the treatment actually on the other hand, there are various manifestations in the oral cavity as well. If you take this is one of the examples, the anticoagulants. Obviously, in the oral cavity, if you are dealing with the operative procedure, the anticoagulants definitely affect in our treatment procedures. Not only that, actually, most of the other drugs, the first picture you can see here, the gingival hyperplasia, especially associated with the patients who are taking penetoin sodium, and in the pregnancy and the oral contraceptives, the patients will get gingival hyperplasia. These are actually a few examples. And the next one you can see oral ulcerations. Of course, there are a lot of medications that can give rise to oral ulceration. NSAID, especially the nicorandil, is the commonest culprit coming up with the oral ulcerations. And the third picture is a newly emerging conditions because of the treatment of bisphosphonate, and this is the medication-related osteonecrosis of patient with the. And the last picture is showing a patient with xerostomia, the consequences of xerostomia, and xerostomia again actually associated with most of the medical treatments, right? Well, from there, those are actually the systemic manifestations of the oral conditions. Well, on the other hand, are there any oral conditions that can give rise to the systemic disease, systemic conditions, or systemic issues? Well, there are, of course, there are a lot of evidences to show that oral conditions that also can give rise to the systemic conditions as well. The mechanism may be multifactorial or the multifaceted, and of course, this is the historically, this the link between the oral diseases and the general diseases are historically actually reported by the father of medicine, the Hippocrates, and it is evident and it is written in the history that he has treated the patient with rheumatism by extracting infected tooth. Well, out of these lot of various, actually the Hemant and the Lakmal mentioned about various oral conditions, out of these actually the periodontal diseases are the most vulnerable or the most biggest culprit for the systemic conditions, right? So the basic pathophysiology behind this is actually the alteration of the biofilm in and around the tooth tissues, which give rise to the acute and the chronic inflammatory conditions, producing a lot of cytotoxins and other inflammatory mediators and destructing the oral and the peridental tissues, as well as they have other systemic manifestations as well. These the chronic periodontal diseases, they actually produce a lot of prostaglandins, interleukins, and the tumor necrosis factors, and also they have actually they shed exotoxins like lipopolysaccharides, which in turn trigger various levels of elevated CRP and the fibrinogen, which cause a lot of cardiovascular disease as well. The pathophysiology may be the common risk factors, and the other thing actually the common genetic susceptibility in the both this thing. And the other thing, as I mentioned, the bacteremia, endotoxemias, and the things like that, and the inflammatory mechanisms. Well, this is again to show how it's happening. This inflammatory mediators and the cytokines and direct bacteria as well. They act directly as well as they induce liver enzyme, liver CRP and the fibrinogen formation, which indirect in other ways they affect in the atherosclerotic lesions as well. Right. This is again the mechanism. Well, this is the spectrum of diseases actually. This was taken from the WHO and the Federation, World Dental Federation, the presentation. You can see the how much it affects in the systemic conditions. Right, out of these conditions, the diabetic mellitus is the most significantly studied one. They have a bidirectional influences as well. We know the uncontrolled diabetic has a major effect on periodontal diseases, and on the other hand, periodontal diseases have acute inflammation, which lead to poor glycemic conditions due to the factors over there. And systemic reviews have concluded that mechanical periodontal therapy approximately reduces 0.4 reduction in HbA1c. This is a clinical impact equivalent to adding a second drug in diabetes. The other evidences regarding diabetics, it is evident that subgingival inflammation is associated with the diabetic and the periodontal conditions. Severe periodontal condition has inflammation implications in the cardiovascular, other microvascular and macrovascular complications, and things like that. So these are some of the evidence to show these conditions. And when it takes to the cardiovascular diseases, again, the periodontal conditions or the acute inflammatory conditions in the periodontal disease have various effects in the cardiovascular diseases as well. I'm not going to talk about the infective endocarditis and the rheumatic heart disease, which are obvious to everybody, but the others, you can see the mechanisms and the evidences to show that how the periodontal diseases are affecting the cardiovascular diseases. And there are various other evidences as well. Mostly they direct cytokines as well as they described about the production of the C-reactive proteins as a surrogative parameter in cardiovascular diseases. Well, these are some of the evidences again to show that influence of the periodontal diseases into the cardiovascular diseases. Is that the all? No. There are various other systems that has influences in oral diseases. Especially in chronic kidney diseases, it has been shown that in patients who are on end-stage kidney diseases, their survival rate is higher in the patients with good oral hygiene. And of course, we don't have to tell about the recurrent pneumonias and especially hospital-acquired pneumonias and the chronic obstructive pulmonary diseases, gastric diseases, and rheumatoid disease. And of course, the low birth weight and the pregnancy-induced conditions are very much prominent. Right. In finalizing, it is, I think it's very much important to integration of the general health and the oral health. Now it is becoming a fashion in the world level as well, especially in the health economics and the primary health care as well as in the academic field as well, especially the, in certain universities like yes, in certain universities, they are thinking about incorporation of medical and dental education in together. Thank you very much.
Thank you, Dr. Ananda Ratnayakar. You have established the link between oral diseases and the general health. Our next speaker is Dr. Priyaka Palipana. Dr. Priyaka Palipana is a senior lecturer and head Department of Restorative Dentistry, Faculty of Dental Sciences. He is a Surgeon Commodore, Consultant in Restorative Dentistry, Sri Lanka Navy, and past President of the College of Dentistry and Stomatology, Sri Lanka, and past President of the Association of Restorative Specialists in Sri Lanka. Over to you, sir.
Thank you very much, Dr. Varshini, for your kind introduction. And I am to talk about the challenges and remedies in integration. We have witnessed with the previous lectures that integration is not working at all. And we should find out the challenges for not happening of this integration. So there are so many reasons for this. Medical and dental professionals are being educated separately. You have separate medical schools and dental schools. They are getting licensed separately. Their work, whatever they practice is regulated separately. It is completely different. Although in Sri Lanka we have a common medical council controlling and regulating it, in most of the countries we have separate dental councils which is completely divorced from the medical fraternity. Then they practice independently. That is another problem, as being highlighted by the previous speakers. And most of the insurance schemes, they don't recognize dentistry or dental treatment as something required, something compulsory. They say it is for fancy. So they don't look after the benefits for the patients when it comes to dentistry. Talking about further challenges, medical officers and medical professionals believe that mouth is a property of dental surgeons. It belongs to everyone. Rarely, the information is shared between the medical and dental professionals. We just write letters in extreme cases, not commonly. Furthermore, public recognizes these two as completely different specialties, different doctors, which have no relevance between each other. So, there is a problem. There is no existence of oral health training program for the health professionals who are already in the service. Nothing is happening. If there are, that is very minimal. So talking about the medical and dental education, medical undergraduates, they have very minimal exposure to dentistry. Fortunately, thanks to our present Dean of the Faculty of Medical Sciences, the medical final years are having a short appointment in oral and maxillofacial surgery in Colombo South Teaching Hospital, which was started last year. Talking about medical postgraduates, we see green lights in these specialties, that is community and preventive medicine and dentistry. They have a common MSc program. Geriatric dentists, of course, yes, we do get geriatric dentist medicine trainees, again for a short period, ENT to a certain extent. Plastic surgeons, we work together during their training and even after getting qualified. That is to a certain extent, I wouldn't say that is adequate. Nursing staff, there's nothing. None of the nursing schools are having anything about dentistry. If at all, if they get, that is just a single or two lectures. Paramedicals, when you get a radiographer to our hospitals or to the general hospital, they have very least understanding of taking dental radiographs and the importance of it. Right throughout the corona period, they did not take radiographs of the oral cavity, being so scared of dentistry and oral cavity with regard to the spread of corona infection. That was a problem in managing our patients. Even other medical staff, the minor staff, they have very little understanding of dental diseases. Talking about the dental education, of course, the dental surgeons, they get graduated from dental schools or medical schools. Commonly, you have dental, common dental and medical schools, whatever. Either it is separate or together. They are being taught by medical professionals, especially during the first year, and in the paraclinical years, they have a program in general medicine, general surgery, microbiology, and all this. What about postgraduates? When it comes to dentistry, the postgraduates, they have a dental surgery program, oral surgery, restorative, orthodontics. More or less, everyone is going through a brief or extensive period of medical training. Dental surgery assistants, they don't have. We have dental surgery assistants, they don't have any sort of training. Dental nurses, nothing they do. Auxiliary staff, we have dental therapists who are looking after the small children's teeth. Of course, they are not getting any sort of training with regard to medical problems and medical practice. Dental technicians, again, is similar to the technical staff in the medical specialties. So I will be going through some photographs which will show you the importance of integration of dentistry into the medical practice, and also will show where at certain instances it was not considered and coming up with deleterious effects for the patients. So the first one is this, a developmental disorder, you know, the hereditary disorder, ectodermal dysplasia. The child is having so many problems together with dental problems. So you have to manage the child together. This is tetracycline staining. I would say it is iatrogenic. The child has got tetracycline staining in the milk teeth, and simply because either tetracycline or doxycycline was given to the pregnant mother. So this is dentinogenesis imperfecta in the primary teeth, a very rare picture. You don't usually see it these days, but these patients are treated with bisphosphonates. Once bisphosphonates are given to the patients, child patients, especially osteogenesis imperfecta, they are ending up with a lot of dental problems. What I show here are dental enamel defects, enamel hypoplasia and hypomineralization, and also they can end up with delayed eruption. This is the evidence for those. So talking about dental caries, that is the commonest disease, and it was highlighted by the previous speakers, the incidence of that, and it is still happening at a very higher rate in Sri Lanka. The top teeth are being affected over there, and once it is very extensive, you end up with life-threatening conditions, infection spreading through the different tissue spaces in the head and neck region, endangering the life. So, we look at a model which controls the causation. For the causation of caries, you have to have microbes. You have to have a tooth. You have to have exposure to sugar and the time factor. So, If we want to prevent it, we have to control these 4 factors at different levels and at different means. So, as Dr. Hemantha showed, the common risk factor and health factor approach is the best approach in controlling diseases. And controlling through these common risk factors, it will control most of the NCDs and dental problems together, as shown in this photograph. Simply, if we can control the diet, stress, smoking and alcohol will minimize the incidence of most of these diseases. Periodontal disease, it was discussed to a very great extent by Dr. Ananda Ratnayaka, where it is highlighted the bidirectional relationship between periodontal disease and diabetes, how the advanced periodontal disease will lead to poor glycemic control and the other way around. So this is another case where the medical practitioners and the laymen do not concentrate, do not give an adequate attention. This is a child with trauma to the milk teeth. You can see some scars on the face, but this is very alarming. One can see that the front incisors are being intruded into the jawbone. What are the problems associated with that? Once the tooth is pushed in, that can damage the developing tooth bed underneath. And it will lead to malformation of the permanent tooth, as you see on the right hand side. In worst scenario, the damage from the deciduous or the milk tooth would lead to bending of the tooth, leading to a tooth like that you see in the right corner. Sometimes these teeth don't erupt, and you will have so many problems throughout life. This is the very front tooth in the mouth. Similarly, trauma to the permanent teeth is very alarming. One has to refer these patients. If you come across a patient or a child who has got traumatized, it is our duty to refer and get the treatment as early as possible. So this is one of the worst scenarios where the root being resolved and replaced by the bone tissue. You call it replacement resorption. So aging is common to us, and it is going to be a big burden in the future to come. And we are having the fastest aging population in Southeast Asia. So we have so many problems associated with that. As you see in this picture, number of teeth are being reduced, and there, together with that problem, you have tooth wear. You have attrition that is associated with tooth-to-tooth contact. You have bending of teeth, and so that you get V-shaped lesions over there near the gum margin, you can see. And so many other problems are associated with that. This is reflux disease. Acids coming and hitting right on the palatal surfaces of teeth. And you get the hardest tissue of the body being eroded off. You can see the central incisors, the lateral incisors are being eroded. So all these patients who are having gastritis and GERD will have to be treated well, and these dental complications have to be addressed accordingly. This is iatrogenic. This is a patient, young girl, who has presented with neoplasm and ultimately treated with irradiation. One medical practitioner has prescribed vitamin C as a sialogogue. So vitamin C, in the absence of saliva, has led to erosion of teeth. So edentulism, I told you, it is coming up. Not coming up, the geriatric populations are coming up, so that ultimately the numbers are going up. So consequences of tooth loss, you know, it has to be highlighted. If you see a patient without teeth, they will have so many problems, as being highlighted over here. And we assess that by oral health related quality of life. We look at the functions being affected, pain and discomfort, psychological problems associated with appearance and self-esteem, and social problems. They have problems in intimacy, communication, and social interaction. This is a patient with dentures. Giving dentures would not be the ultimate solution. The top photographs show that the patient with dentures having problems after being wearing it for a long time. We have to remedy it. So as much as possible, try and preserve your natural dentition. Neoplasms, they come up with various problems, but we have to rehabilitate them for them to have a nice social life. So this is pre and post prosthetic photographs of the same patient I showed you before. And aesthetics is very important. We have to maintain aesthetics for the purpose of maintaining good psychosocial behavior. These are very simple treatment protocols. This is called microabrasion. In dental fluorosis, we can very easily do it. Finish up the treatment in half an hour's time with least invasion. This is another case, an elderly person has broken part of the teeth and got spaces in between two front teeth. We have built up with composite restorations. Things are quite possible. Just motivate your patients. That will be very useful for the society and for their individual health. So this is one of the cases that we have treated with implants. You have a titanium abutment and ultimately the tooth is being restored. You cannot see any difference between the rest of the dentition. So getting integration, get the dentistry integrated into the medical system is rewarding. And it will be helpful in identification of disease precursors and underlying conditions so that worsening of disease is prevented. It raises patients' awareness and it will help in obtaining dental services sooner if everyone knows about it. Effectiveness and efficiency of both dental and medical professionals in prevention is, of course, will be much better. And it will be very much easy to manage chronic diseases together as we have common reasons for them to get these diseases. Access to the dental care systems is sometimes difficult, but in previous lectures it was highlighted that it is not that far for them. It is in easy access, but this will facilitate that. Patient-specific barriers like anxiety and all these things can be addressed at the level of the medical practitioner, and we can overcome these issues. And it is cost savings to the system and for the families. So this is one of the cases that we have treated at the Lady Ridgeway Hospital. Former orthodontist Dr. Shriyani Basnayaka shared these photographs with me, whom we have managed together. You can see the very first photograph where the child is born with bilateral cleft lip and palate. Secondly, we have been treating the child with a feeding appliance, pre-surgical orthopedics, ultimately to end up in an adolescent like this. Thank you very much. These are my references, our references rather. Thank you.
Thank you, Dr. Palipana, for your very illustrative presentations. Now we have had the privilege of listening to all three of our distinguished speakers. To summarize, the integration and harmonization of oral health with overall healthcare systems is a continuous process that requires collaboration, education, policy support, and community engagement. By working together, healthcare professionals and policymakers can strive for a comprehensive approach to health that addresses the oral health needs of individuals and populations, leading to improved overall health outcomes and enhanced quality of life. Now, the forum is open for questions from the audience.
My question is now in child health records. I hope community medicine department is also some members may be there, because I think in that health record the public health nurse is supposed to note the dental caries and the status of the oral health. But I don't know after that what are the measures taken in correcting those
Yeah, actually, the Family Health Bureau has done a very good child health record. Even it has been revised several times. It has been included. First, mother need to note that the teeth are erupting. When if there's caries, the midwife should note and report to the MOH as well. Thing is, this is not taken as an extract to the Family Health Bureau because there's no record coming out of this case. So therefore, it is the rest of the things are recorded, but this is not coming the number of teeth decay or anything like that. But they give advice. We have given booklet everything for the midwife, how to give advice if there are caries, what to do, and everything is given. Thing is, the midwife is working in a very difficult workload. So therefore, the 100% getting out of from midwife is the issue. So we have to go behind and get it done. Some of them are not doing well.
But generally, like in Sri Lanka, our public health, say this program and the system is working, I would say, quite well compared to the other, maybe even Asian countries. But what I can't understand is, like they make a note of it, but does it get just diluted and not sort of more preventive, or I don't know, even the midwife, the advice is not very much emphasized, or is that what is happening?
Yeah. Actually, the thing is due to overburden of midwives' work, they note it, but it is not coming as any referral data to the center. The number of teeth decay or noted by midwife, but they give advice. They sometime ask mother to get the child to the clinic, and that will do. But there's no coordination. So that is the thing we have to. I think referral. If the midwife has sent that we have to strengthen in the future.
Thank you very much for that very interesting and very important question, I would say. And again, integration, when it comes to the integration of the oral health, it has to be at the level of primary care. And we are talking in terms of primary care, it is where actually we have to introduce and where it is not happening. As Professor Surangi very clearly mentioned, all other areas are being nicely covered, but oral health, prevention and integration has not been incorporated into primary health care level. So that is a problem. The other way around, we have to think why it is. Simply as we mentioned, they are not getting an adequate training. Are they capable of identifying dental issues? That is the other problem. So as a remedy, we will have to come up with strategies in educating them at the primary health care level.
So maybe something more need to happen at Family Health Bureau at that end, and maybe the
And the other thing, madam, the problem is there is in medical, in the other normal system, there is a referral system from the midwife. They send to the MOH. The MOH level, they are doing some kind of another review. But unfortunately, in Sri Lanka, dental preventive setup is not really established. It is actually proposed and identified the need of appointing dental surgeons into the MOH levels, but it is not materialized yet. Only a very few MOH areas, they have dental surgeons looking after the preventive aspect of the dentistry. That's another lack.
Because whatever the vaccination, so those things are well taken, looked after, and we have very high results. So maybe at the, as Dr. Ananda said very correctly, maybe that at the MOH level, there should be at least weekly or some dental clinics or something happening where these identified cases could be directed like.
That is well identified, but unfortunately, still we couldn't implement it into the grassroots level, especially the preventive aspects.
So from where should we start? Is it from the community dentistry I think it's the duty of the.
Yeah, actually, we don't have at least district community dental consultants at the moment. We have only 5-6 people in the ministry these days. So that with that manpower, we can't run because no district in this country having the medical dental community consultant. Only one outside the Colombo. So with that, very difficult to run the community.
So maybe
programs.
at least we can get the support from our, say, the medical faculty community medicine department and together at least make some proposals to the Ministry of Health.
Proposals, madam, already given.
No action is.
Implementing part is actually there are few dental surgeons appointed to certain MOH areas. The rest actually the majority of the MOH areas are not manpowered with the dental surgeons. And the other significant thing is that if you take the consultants in public health dentistry, almost all the public health dental consultants are within the Western province. To my knowledge, there is only one public health dental surgeon, consultant dental surgeons, working outside the Western province for the whole country.
So is that,
That's the
I mean,
situation.
is it that the number of dental graduates being produced not adequate, or is it that at the PGIM level nobody is taking into community dentistry, or like what is the root cause? I mean, from where should this be? Because what I feel is if this is properly addressed according to the figures, the statistics that you all have given, it's will be like the economically also like huge cost reduction could be done on this.
Yes, madam. I can share personal experience because my wife was one of the first 3 or 4 dental surgeons attached to MOH offices. So she went to Rabukkana, and in that period she worked there for like 1.5 years, and there was a big scope because she was going to all these tea estates. They were there. They never had exposure to dentist, but they went to the site and treated. So, I mean, she was the first person to introduce a toothbrush. So that was the situation, actual ground situation in that period. So I really think that is a very good area. If we can really promote, I mean, get the ministerial support to get dental surgeons to MOH officers and have a proper system, I think that is one area which will be very helpful in promoting oral health.
So maybe the location, then this dental faculty is quite closely located to the Ministry of Health. Maybe we can have some hope in future.
Actually, as you have correctly said, we have the preventive manpower is not counted because our economics are calculating thinking the hospital numbers. What we really want, as I said, at least we should have 365 dental surgeons to the MOH level. So that is the capacity that we have to give out, to give 300 odds
But
dental surgeons
comparatively,
in the
the
future.
medical, the MOH with regard to the medicine, I mean, that system is quite well established. So what is lacking is in the dental, like say the community dental health level is the...
Very true. We should have.
Any more questions from the audience? In the absence of any more questions, we have come to the end of our symposium. I would like to thank our exceptional lineup of speakers and a special thank to the Faculty of Medicine and the organizers of the ICM 2023 for giving us this opportunity. Thank you very much.
A very big thank you goes out to our esteemed speakers for their wonderful insights. I think we can all agree that the integration of medical and dental sciences is beneficial not only to our healthcare professionals but also to the general public. It will improve our healthcare outcomes as well as furthering scientific knowledge and progress in learning. So we look forward to future collaborations of this nature between the two faculties. I now invite the moderators, Dr. Amitavashini Rajaganesh and Dr. Rasika Ekanayaka, to hand over the tokens of appreciation to our speakers.
Can we please have Dr. Lakmal Kulasekara? Dr. Hemant Amarasinghe? Dr. Ananda Ratnayaka? And Dr. Priyaka Palipana. Thank you, sirs, and thank you, madams, for your dedication and this excellent symposium, which focuses on the integration of between Faculty of Medical Sciences and the Faculty of Dental Sciences. Thank you very much. Ladies and gentlemen, so far our sessions had been focused amazingly on the resilience, remediation, and the reinvention of healthcare. So today's sessions had been focused on, we had started early morning with 7 oral communication sessions, focused mainly on the resilience and fighting through with remediation in healthcare. And then we moved on to a wonderful keynote address, which focused on the technology and how to overcome and adapt to crisis by using technology. We then went on to symposiums on building resilience and adapting in crisis. And then we had rapid pitch sessions, which brought out the communication skills as well as the thinking on their feet among the postgraduate trainees. And then a wonderful debate by our very own students. Ladies and gentlemen, this was the conclusion of a symposium between the Faculty of Dental Sciences and the Faculty of Medical Sciences. And again, it was a very wonderful symposium which brought out the importance of integration between the two fields. We will next be having a Zoom session, a symposium which holds a special significance. Before moving on, we will move on to a small video. and gentlemen, let us now turn our attention toward the next symposium, which holds a special significance. We are honored to have our distinguished faculty alumni with us today via Zoom, who have not only dedicated their time and knowledge during their undergraduate years, but continue to support us as valuable overseas resource persons, despite their demanding schedules. This unwavering commitment to our institution is truly commendable and serves as an inspiration to all.
I now invite our chairpersons, Senior Professor Sagarika Ekanayaka, the Chair Professor of the Department of Biochemistry, and Professor Manori Gamage, Consultant Pediatrician.
This symposium is by alumni who are joining us from overseas, and they are online joining. And first presentation or the first lecture will be done by Dr. Nimantadi Alvis, who is a consultant in diabetes and endocrinology, South Tyneside and Sutherland NHS Trust, UK. The topic is Facing the Challenges of Metabolic Syndrome, the Place for Multimorbidity Clinics. Nimantha is a consultant in diabetes and endocrinology in Sutherland NHS Trust, UK. He's graduated from second batch from our faculty in 1999. He joined the Department of Medicine soon after underwent MD training, and then went for a PhD in non-alcoholic fatty liver disease and metabolic syndrome and mitochondrial genetics at Newcastle University in the UK. After completing his training, he joined the Sutherland Royal Hospital. And now he is currently working in Dubai, UAE. His main interests include non-alcoholic fatty liver disease, facing the challenges of metabolic syndrome, the place of multimorbidity clinics. We'll join his presentation now.
Good afternoon, everyone. I'd like to thank the research committee of the University of Sri Javadhanapura Faculty of Medical Sciences for this opportunity, on allowing me to speak for the next 20 minutes on the metabolic syndrome, which is one of the areas that I practice in at this international medical conference. So I'm going to start straight away. I'm hoping that you are able to see my slides, which I will share now. So I've titled this Facing the Challenge of the Metabolic Syndrome and about multi-speciality clinics because of the way that diabetes clinics have evolved over the last few years. So by way of introduction, what I would say to you is that there has been some evolution from just concentrating on blood sugar to really looking into the cardiovascular aspects of most of the medical problems that our patients have. And so we are tending to move towards multimorbidity management, or conditions that are linked together. Sometimes we are able to have other specialists like cardiologists, renal doctors, lipidologists involved in our clinics. And now with post-COVID times and virtual clinics, we are able to do that around the table as well, sometimes, and discuss patient care. Two of the main agents in the diabetes world, which are the SGLT2 inhibitors and the GLP-1 agonists, have really made such a big impact in the management of all metabolic disease. And this has actually made people think a little more about joint care for our patients with these conditions. So let's just look at a patient profile. A 68-year-old male with diabetes for about 15 years, which is uncontrolled. He's also known to have coronary artery disease and be slightly obese. He has uncontrolled hypertension and a kidney function that is not ideal, with raised cholesterol and liver functions that may appear to be slightly raised. So as you can see there are several problems. And if you think about how should this patient be managed, it's quite evident that several specialties are going to be involved in the care of this patient. So individually, this patient could end up going to all of these clinics, but we try our best here not to get the patient too complicated with multiple clinics and by the one specialist or for all the specialists to be in the same place at the same time. So these are really a series of interwoven conditions which include obesity, diabetes, blood pressure, cholesterol, and these first four are generally termed parts of the metabolic syndrome, which was described many years ago, but we don't generally tend to think of it because we kind of understand that these things happen together. But kidney disease and heart failure are also conditions that we sort of try to group together in these, and we call these, and because these conditions are all linked together at a pathophysiological level, we will call them CRM clinics or cardio-renal metabolic care rather than isolated treatment of individual cases. And therefore, this can sort of improve patient care. So if you really ask, why would we want to address all of these conditions in one go? The answers are quite simple and straightforward, but just to list them for you, we can come up with a coordinated treatment plan with no duplication or unnecessary interactive medication. We can come up with fewer blood tests and maybe fewer scans and investigations. And of course, definitely the advantage of fewer clinic visits for the patient, thus reducing the burden on the hospitals as well as patients to come into hospital for several conditions. Now, even in diabetes, in my specialty, the leading cause of death is cardiovascular or ischemic heart disease. And so most of our management is geared towards reducing this. It is the world's large or the first most common cause of death anyway. So it makes sense for us to try and address ischemic heart disease as a leading cause of death. So if I were to look at the interaction of diabetes and obesity, specifically selecting from all of these conditions, just in the interest of time, and I will touch briefly on fatty liver disease, let's look at each of these in turn. So diabetes, the number one cause for diabetes-related deaths is ischemic heart disease. And we know that 1/3 of patients with diabetes have established cardiovascular or coronary vascular disease, and about 75% are diagnosed or well undiagnosed but have heart failure within 5 years of diagnosis of diabetes. But strangely enough, less than 8% will receive a cardiovascularly protective diabetes medication. And the reason I say that is because of the availability of SGLT2s and GLP-1 agonists, which I will deal with in a little bit of detail in the care of these patients. So in diabetes clinics, we do ask patients to, exercise regularly, reduce their calorie intake, to control their sugars very tightly, if possible, without complications. We ask them to monitor and control their blood pressure. We control their lipids to international guidelines, and we sometimes use statins and aspirin and antiplatelet agents, although we don't routinely start this off now in diabetes clinics. Anyone who has any interest in diabetes will be aware of the UK PDS trial, which was one of the pivotal trials in diabetes, showing that good glycemic control reduces side effects of mainly microvascular complications. But 10 years after the trial finished, around 2007, there was a reanalysis of those patients, and actually they showed that even macrovascular disease like ischemic heart disease are reduced. And therefore they call this the legacy effect, because these patients were still not getting the same sort of control as they would have been on the UK BDS trial the time. But still, for all 10 years later, the graph on the right side, if you look at it, you will see that the myocardial infarctions were less in the intensively treated group. So of the medications used in diabetes, I'd like to talk a little bit about the GLP-1 receptor agonists and the SGLT2s, which I believe are available in Sri Lanka. The GLP-1s are mainly injectables, and I think this is limitedly used because of the cost of these. I have been fortunate enough to be in the UAE and in the UK, been able to use some of these agents. And of course, we have the oral one, which is Rybelsus, and I'm not sure if it's still available in Sri Lanka or not. And we have several SGLT2s, with the first two, dapagliflozin and empagliflozin, being the most popular and having the most evidence for cardiovascular disease. So the GLP-1s, which I said are injections mainly, they will reduce blood pressure and they will reduce cholesterol. Plus, they will also reduce weight and reduce or improve sugar control. So these arrows are across the range of all the available GLP-1 agonists, bar from GLP-GIP agonists, which I will come to as well. So just picking out Ozempic or semaglutide weekly injections, you can see here that it significantly reduced the risk of cardiovascular events 2 years after start. So showing that actually patients on these will have reduction in cardiovascular events by several mechanisms, and therefore agents that we should be using in those who have diabetes. And across many of the trials that have been done for GLP-1 agonists, you will see that most of the cardiovascular risk factors fall on your left of the hazard ratio 1 mark, showing that there was improvement in the control of those during their use. Moving on to SGLT2 inhibitors, the EMPA-REG and the dapagliflozin studies were the most common, and again, clearly showing nearly 1/3 reduction in cardiovascular death, all-cause mortality, and hospitalization for heart failure. Now, the SGLT2s had more of a benefit on heart failure than did the GLP-1s, but even in the 3-point MACE at the left side for major adverse cardiovascular events, there was a 14% risk reduction. So excellent data again showing cardiovascular benefit. This is the DAPA heart failure study for dapagliflozin, and again showing that even as soon as within 28 days, the benefit started off and a 26% relative risk reduction. So generally, we are talking about the 30% mark when we are looking at reduction in cardiovascular. Now, the SGLT2s and the GLPs to an extent don't stop at cardiovascular benefit. They also cause renal benefit. And this is the DAPA-CKD trial where dapagliflozin showed a sustained reduction in end-stage kidney disease, renal or cardiovascular death, and reduction in eGFR. So these agents, the GLP-1s and the SGLT2s, actually are sort of long-term beneficial treatments for heart problems and renal problems, which we are using in diabetes medicine. Plus, all of them will also cause weight loss, as I will show you in the next few slides. Now, we have tended to move towards real-world evidence for some of these agents, and this is real-world evidence, again, showing clearly that they're falling on the left side of the line when it comes to all the SGLT2s compared. So, again, this is a class effect and not an individual medication effect. And so it has reached international guidelines that we should be using these agents, the GLP-1s and the SGLT2s, in people with diabetes, particularly those who are at higher risk of cardiovascular disease. So the summary points here is that improving glycemic control has an immediate and a legacy benefit on reducing cardiovascular disease, but these newer agents also reduce by about 30% the cardiovascular risks and will benefit renal, weight loss, and sugar control. So we move on now to the impact of obesity on cardiovascular disease, and it's not unknown to people that as you put on weight or as your body mass index increases, which is happening all the time, there are several comorbidities that are associated. So these we will classify them as metabolic, mechanical, like the arthritis, and mental or psychological issues that come up with increasing weight. Now, most of my life here in the UK is spent managing people with obesity because 65% of those in our general population, particularly in the northeast of England, are overweight or obese. And as the amount of overweight or obeseness or obesity or the BMI increases, all these metabolic and other conditions increase. You will see from the left to the right, as the obesity class increases, the prevalence of each of these conditions also increases. So it is very important that we catch these people early, and people who are overweight or obese will have a reduced life expectancy as well. So they will die earlier, and by losing weight, actually, you will live longer. So this, the association with weight and cardiovascular disease has been recognized, and the American Heart Association also has released statements a couple of years ago on how to reduce this and how important it is to lose weight. We also know that losing weight reduces diabetes problems and many other, at the moment, 80 different conditions can be addressed by losing weight. So actually, An obesity clinic is almost a multi-morbidity, multi-speciality clinic impacting on several benefits. Obesity and heart failure are now known to be very closely linked, and although this is a busy slide and I don't want you to look at all of these, it's just evidence that there can be ventricular filling pressure problems, increased heart rate, the metabolic profile can be changed, as we all know, because of weight, and therefore it can impact on heart failure. So what do we do about management? And here I'm going to spend a little bit of time on this. We know that just a 5 to 10% weight loss is extremely beneficial in a lot of conditions. And this was from the Look Ahead trial. And everybody and anybody who's in obesity will know about this trial. Just they showed that by reducing a slight amount of weight can impact positively on several conditions. Now, lifestyle, diet, and exercise are the cornerstones, and I'm not going to go into that because that's a whole lecture in itself. But I just would like to mention a few things we are doing here in the Northeast, and one is very low calorie diets, because as you might have known, some of the biggest trials in very low calorie diets came out from this part of the world. And so we use these when we want people to either reverse their diabetes, or we call that going into remission, or if we want a specific weight loss in a specific short amount of time, where we will restrict their calories to 800 a day, giving them shakes and probably a small vegetable salad for the day. And we generally do this for about 3 months. And it is a safe diet to be done for selected people. So we sometimes tend to do this from our clinics. And so in the first 8 to 12 weeks, we will give them 3 shakes. We used to give them vitamins and minerals, but these diets are very balanced. So they have all the essential vitamins and minerals. We ensure that they remain hydrated and that they are able to open their bowels with by giving them stool bulking agents. And sometimes they have a little bit of vegetables. Now, coming on to drug treatment, just because there are these medications available at a cost and probably will take some time to come into regular use, we want the ideal drug to be cost effective, which it is not at the moment. We want it to be able to lose significant weight and sustain it, and also have minimal side effects and reduce the complications of obesity. So where are we and what have we got? These are the agents that I have personally used and available and licensed in the 2 countries that I have worked in my obesity career. I'm not going to talk about Orlistat, which basically reduces about 1/3 of the fat absorption in your diet. That can be difficult to tolerate because patients will have a lot of diarrhea. Contrave is also not very commonly used, maybe used in a handful of patients, but they are excellent in patients who have cravings, so constantly thinking about food, constantly wanting to eat. These are antidepressants, and they will work in your brain to reduce your hunger cravings. And you might get about an 8% weight loss with Contrave. Again, has to be used carefully, particularly if they have depression, where there may be interaction with other antidepressants. All these medications will have side effects. Not too bad when it comes to side effects of Contrave, and actually the cravings will reduce. And it's difficult though to decide on who is actually having cravings, and there are certain scales to look for these. Now, Saxenda and Victoza. Victoza being a very commonly used medication, I'm sure it's available in Sri Lanka as well, for diabetes and weight loss, but the Saxenda is the pure obesity-related form of it, can be used in a higher dose, and it is a GLP-1 analog which reduces your appetite. It also reduces gastric emptying, so you feel fuller for longer, and that's one of the ways it works. So even in those without diabetes, it can be used in the form of Saxenda, or even indeed sometimes off license on Victoza if you do not have availability, and it reduces your appetite. But it will only work as long as you have the availability of the drug and you are taking it, and it is not cheap. So I'm going to move on. Saxenda has been shown to be about 5 to 15% weight loss. And then the next one, or the gold standard that we're using nowadays a lot, and in fact, it's got so popular in America that there is no production anymore, which is Ozempic or semaglutide. Wegovy is again the weight loss only preparation of it, and all the Hollywood stars are on this, and therefore they find that there is no availability. And even in the UK, we are struggling now to find Wegovy, which has not even been released here. and just because all of the stock is being taken over by the Americans. Again, 5 to 20% weight loss with semaglutide, and it is also available in an oral form. Now, the newest kid on the block, and I was fortunate enough to be prescribing this in the UAE, is Mounjaro or tirzepatide. This is a GLP-GIP dual agonist. So it works in two places, similar side effects, similar once-weekly injections. I would actually argue and say less side effects than semaglutide. But actually, when you look at it, even at the lowest dose, the weight loss was even more than semaglutide or Ozempic or Wegovy. So excellent benefit, and though I am listing the side effects here, less I would have said than semaglutide. So of the efficacy of existing weight loss interventions, you will see here, lifestyle 3 to 5% weight loss, a very low calorie diet 6 to 10%. Then when we come into the medications, tirzepatide probably is the most efficacious, going on to about 22 to 25% weight loss, which is in the range of gastric bands, to be honest. And then, of course, bariatric surgery, which can give you much more weight loss. So I'm going to speak a little bit about that. And of course, watch out for the triple agonists, as they call them, which is GLP-GIP, which is what Mounjaro is, plus glucagon as well. And these are also going to come, and hopefully the weight loss may even be higher than what we already have. So what is the impact of obesity on cardiovascular disease? It's a chronic condition. It can reduce a lot of comorbidities and can impact positively on over 80 conditions if used in the right way. We do have effective medications and up to 20% of weight loss. Now, I just want to mention a couple of slides about bariatric surgery, and I know it's widely available in Sri Lanka. Recent updates from 2022 from the Association of Metabolic and Bariatric Surgeons, or ASMBS in the US, have reduced the thresholds for this. So actually, what used to be about 40 is now 35 without comorbidities, and those who are between 30 and 35 with a metabolic disease can also be eligible for bariatric surgery. Asians anywhere above a BMI of 27 are eligible to have bariatric surgery, and of course children and adolescents as well, depending on what their selection criteria are. So it's becoming more and more widely used. The problems are that there aren't always the surgeons or the MDTs to support this. But we know that it's great for diabetes prevention and remission. It's great for complication reduction and for a range of other metabolic illnesses. But we cannot do bariatric surgery on everyone. So it still comes to us having a mixed approach with diet and exercise and medications as well. So sorry, I may be just about going over time, but a few slides on fatty liver disease, because I think this is often ignored. We do have excellent guidelines now for non-alcoholic fatty liver disease from the American Association for Liver Disease, as well as NICE coming up with some of these as well. And it's more and more recognized as a proper entity with significant risk of cardiovascular disease as well, more so than the liver-related deaths of this. And we know that those with diabetes, obesity are at a higher risk, and that there is quite a close relationship with cardiovascular disease as well as cirrhosis and liver cancer in these conditions. We also have guidelines on how to identify these patients, because it's very common. So we want to identify the high-risk patients, and it might be using the FIB4 scoring index and then moving on to a fibroscan, which again, I believe will be available and useful in detecting these patients. But what you have to realize is we're not only trying to prevent liver-related death, we are trying to prevent cardiovascular death, because we know that there is more and more evidence that it does increase, for example, carotid intima thickness, it increases ischemic heart disease and coronary cardiovascular diseases. So very important to manage that because of the risk of other metabolic disease. So that's with that, I come to the end of my talk. I'm sorry I've been talking quite fast because I've tried to get through a lot of things in the 20 minutes and give you an overview of the importance of multimodal, risk factor management for reducing cardiovascular disease. So we know that these cardiorenal metabolic diseases are linked pathophysiologically. They're not like one entity here, one entity there. And so we should either be managing them whole as a patient or getting multi-speciality, multi-morbidity clinics even set up to try and manage these patients. And this will also have other impacts on patient care because it helps the patient, it helps the hospital and the physician because it reduces the number of visits that are available. And we are living in a day where we are fortunate to have several medications to impact on some of these conditions, particularly the SGLT2s and the GLP1s, which should be considered for any patient who can afford it. And we must all consider these agents wherever possible and try and source these for our country as well where possible. So I hope this has been useful to you. And if there are any questions, I will hopefully be joining you in person, but this is a recorded talk. So let me leave you with the thought that obesity management is very, very important because it can impact on 80 or more different conditions. And this might be sort of the one pill that kills many, many problems and helps with many patients' management of all of their metabolic illnesses. Bearing in mind that we Asians need far less weight, excess weight, to cause a lot of these metabolic conditions. And most of this is central obesity, which is around our tummies. And so it is really important for us to manage obesity if we are going to manage most of these metabolic conditions. Thanks again, and thank you for the pleasure of giving me this opportunity of delivering this talk.
Dr. Nimanta, thank you very much. I'm Professor Sagarika here. It's wonderful to see you. And I see you have lost a lot of weight. When you were a student, I think you were a little bit more chubby, I should say. Right, Nimanta, I have one question. Wonderful to see you all doing so well. You did not touch upon diets, actually. Right, so when obese patients come to the clinic, what is the intervention, nutrition intervention in UK or UAE? Do you all direct them to nutritionists or dietitians?
Thank you, madam. Are you hearing me? I hope. Can you hear me?
Yeah, we can, yes.
All right, great. Firstly, I am actually back in the UK, sadly I left the UAE, just I have introduced as being the UAE, but I'm not. So I think diets are very important depending on which country, and I realize that being in the UAE, because different cultures have different diets. And in the UK, as well as the UAE, you always, the first step would always be meeting with the dietitian. And so they will do a full dietetic assessment of what they're doing wrong and try to identify binge eating habits and what the eating patterns are, whether they're night eating, stress time eating, etc. And then from there on, we are coming up with an individualized plan. In the UK, in our tier 3 weight management services, we put people through groups as well for that. So they go to 5 1-hour sessions of dietetic input, and then they go on to having a one-on-one dietitian assessment of what they learn from those diet groups and how they should be eating and what the preparation is for going on. Because they have to maintain this lifelong, otherwise it's not going to work, whatever medications or surgical options we go into. I hope that answers the question.
Yes, thank you. I hope in Sri Lanka we will be able to follow that soon. I think we forgot, we have to ask whether the audience have any questions from you. Please, if any one of you have any questions, you all can ask from Dr. Nimanta. Yes, I can see Dr. Nilanka.
Hello, hi, Dr. Nimanthan. This is Dr. Mauli Arambavara, endocrinologist, and it's very nice to hear from you after a long time. Yeah. So as you said, obesity is a huge problem here, and our drugs are very limited. So we don't have GLP-1 analogs. Only one which is available is liraglutide, which is extremely expensive, and it's a daily injection. And of course, bariatric, most of the patients are extremely scared to head towards that pathway. So lifestyle plays a huge role. as Madam said, so the diet and, it's, I just want to know, since you're multimodal clinic, even though you tell, you have this program, how effective is this? Because most of the time patients get really enthusiastic initially, but then again, I mean, it's sustenance, isn't it? That's the key challenge. So is it effective is it happening in the UK? How do you follow these patients? How long do you follow? Would like to get your insight on that.
I think the challenge of that is the biggest challenge we have talked about, and you're very correct. I think the most important thing is to tailor the diet to where your patient is coming from and what they're doing. So just as an example, for people in the UK are quite, most of them are regimental in what they eat for the day, so it's a bit easier. Whereas in the UAE, every meal is big, there's a lot of availability, and we used to struggle with getting people to engage with diets more than we would even in the UK. In Sri Lanka, if you're giving that, it's got to be a Sri Lankan diet change. Like you can't tell people stop eating rice or stop eating bread completely. So it's got to be sort of a diet that's first of all fitting to their culture. Yes, it's a challenge. We have to keep reminding these people. So sometimes you might give them the dietetic education, and you'll be surprised to hear how many people actually don't know how to eat healthily and how they kind of go on all sorts of fatty diets. They always regain the weight back. So we encourage moderate eating and like not to go on crazy diets. And there are thousands and thousands of diets on the internet. So I think it's a diet that's specific to you as a whole. Some people will do well on, say, for example, intermittent fasting. Some will do well on 5-2 diets. Others will do on low carb or Mediterranean. So it depends on which diet suits that person. And of course, we have to admit that most people will not continue with 100% the rest of their lives, but at least knowing that the weight is coming back, knowing that they are not doing their diet right, coming back, and we even don't like the word diet anymore. It's just got to be a lifestyle change, really. So things that they can maintain for the rest of their life. We tell somebody don't ever eat chocolate or ice cream, they'll probably not listen. But it's about eating it in moderation and sort of being sensible.
Thank you.
Any more questions? Okay, I think our time is up. So thank you, Dr. Nimantha. Wonderful to see you and wonderful to see the work you are doing. Maybe when you're in Sri Lanka one day, you can come and talk to us a little bit more about these things. We wanted to ask you something about fatty liver, but I don't think we have time. So let us move on to the next one. Thank you very much for taking your time and being with us. Haridapura. Okay, so it's time to introduce another one of our alumni, Dr. Anushka Kotalawalabaga. She actually graduated from our own university faculty in 2005, and after completing her internship at National Hospital in Sri Lanka, she worked in pediatric cardiothoracic anesthesia at LRH, and during that time volunteered also at the Army Hospital. And then in 2009, she moved to America and started postgraduate training, initially in internal medicine, and completing her residency in internal medicine at Boston at Cambridge Health Alliance, and stayed on as faculty at Harvard Medical School. Then Dr. Anushka moved to University of Buffalo to pursue surgical training, which she completed in 2021, and continued on to University of California, Irvine, to complete a fellowship in trauma, surgery, and critical care. She's currently an assistant professor in trauma, acute care surgery, and critical care at Loma Linda University in California. Her other interests include a little bit of time spending with her children, and I think she's very passionate about music, so she's still pursuing it. So she will be talking about how can we survive sepsis. Dr. Anushka, you can start your presentation. Wonderful to see all of you.
Hi, everyone. Thank you for this wonderful opportunity, for the privilege of being a part of this program. I'll be forever grateful for the stellar medical education I received from Japura and the inspiring, brilliant mentors who continue to inspire me. I'm excited to share some of the knowledge and information I have gathered over the years on a topic I feel is very important. Sepsis kills a third to a sixth of the people it affects. It doesn't discriminate and has no geographic boundaries. although the mortality and morbidity can be higher in lower economic and lower access settings due to the inability to implement timely and necessary interventions. In the next half an hour, we will briefly discuss the pathophysiology of sepsis and septic shock and delve a little deeper into the evolution of data which acted as a catalyst for the genesis of the Surviving Sepsis campaign, which started in 2002, and an attempt to understand the reasoning behind their most recent guidelines and recommendations. Last but not least, we will outline what we can try to do better. The word sepsis in Latin means putrefaction or decay. Initially, the sequelae of sepsis were attributed to the organism or infection itself. However, better understanding of the process has made us realize that the sequence of events that results is more due to a dysregulated immune response than the actual initial insult. We see that the pro-inflammatory response results in a cytokine storm, resulting in tissue injury and death, resulting in further release of cytokines which affects every organ system, resulting in multi-organ dysfunction, with pulmonary shunt resulting in hypoxia, which can progress to ARDS, altered mentation and delirium, vasodilation and myocardial suppression resulting in hypotension, acute tubular necrosis and prerenal kidney injury, and coagulopathy and liver dysfunction. Until 2001, there was limited understanding on how best to manage sepsis or septic shock. Until this guy, Emmanuel Rivers, which is who you see on the top left corner from the University of Michigan, gave up his research on cardiac arrest and started focusing on septic shock when a family member of his almost died of sepsis. This resulted in a landmark trial you see above, which first popularized the concept of early goal-directed therapy. The graph you see above is the result I got when I plugged in the word sepsis in a PubMed search, and as you can see, there has been a rapid rise in research interest since then. Therefore, I thought understanding this landmark paper and the protocol is important, as most of the current research seems to be derived from his initial protocol. Rivers and his team performed a randomized control trial which included 263 patients who were assigned to current standard therapy as it existed in 2001, and the above protocol, which they described as early goal-directed therapy. One of the key differences in early goal-directed therapy group was that resuscitation and management was initiated in a timely fashion, which started in the ED, unlike the usual therapy, where there was no urgency to implement intervention. In the intervention group, a central line and arterial line were placed, and 500 ml boluses were administered until the CVP was 12. Until CVP was 12 was achieved if patients were hypotensive. In addition to this, central venous oxygen saturations were measured with a goal of maintaining above 70% and were transfused to a goal hematocrit of 30%, and dobutamine was initiated if the SCVO2 was not above this. All this was accomplished within 6 hours of identification of sepsis, and the results were striking. There was a statistically significant reduction in hospital mortality by a third. In addition, it was shown that even though the intervention group received more volume initially, after 72 hours, they actually received less total volume, suggesting that early aggressive resuscitation improved results but reduced fluid creep. There was also improved Apache scores, reduced lactate and therefore higher pH and lower base deficit in the intervention group, and higher SCVO2s at the expense of increased blood transfusion. In 2014 and 15, additional control trials were designed in multiple countries in an attempt to challenge all the components of the Rivers protocol. The first of these was the process trial in May 2014, which was a multi-center trial that included over 1,300 patients. They were assigned to early goal-directed therapy, similar to the Rivers protocol, standard therapy, which was similar to the Rivers protocol, but did not include the early central line placement, and therefore no initiation of dobutamine or monitoring of venous gases, and did establish a transfusion goal of 7 instead of 10. The third group, which was managed as per physician discretion or usual care. The results of their studies showed no difference in 90-day or 1-year mortality in any of the groups. This was closely followed by the ARISE trial in October 2014, which is another multi-center trial based in Australia and New Zealand, and included 1,600 patients with a randomization into early goal-directed therapy, again identical to the RIVERS protocol, versus usual care. This was care based at the discretion of the managing physician and was not protocol based. Again, surprisingly, they noticed that there was no difference in mortality, length of stay, or duration of organ support, including ventilatory and renal replacement therapy. The third trial was the PROMISE trial in 2015, which was based in the UK. And again, this was very similar to the previous two, which it was a randomized control trial, including over 1,200 patients, randomized to early goal-directed therapy, identical to the RIVERS protocol versus usual care. And here too, they found no difference in mortality, although the early goal-directed, the goal-directed therapy group did receive more IV fluid, more dobutamine transfusion, and did have an increased ICU length of stay. So, since the RIVERS trial in 2001, given the increasing volume of trials and research interest in this topic, an international collaboration called the Surviving Sepsis Campaign was established to screen and scrutinize the multiple studies that have since been published in an attempt to formulate guidelines and recommendations for the management of sepsis. Their most recent guidelines were published in 2021. One of the key concepts and tools of management have been the establishment of care bundles. And as you can see above, in the current 1-hour bundle. This has 6 components: rapid identification and screening of sepsis, measurement of lactate, obtaining blood cultures, administering antibiotics, volume resuscitation if there's evidence of hypoperfusion, and initiation of pressors after volume resuscitation for persistent hypotension. In the next few slides, we'll delve again a little deeper into the reasoning behind more of their recommendations. So the first recommendation, which is the early identification of sepsis, involves establishing a criteria for diagnosis of sepsis, and the campaign recommends the use of 3 scoring systems, so one of 3 scoring systems: SIRS, NEWS, or MEWS. All of the above need a source of infection in addition to the different components. It's best to choose one of these at an institution and stick to it for sepsis screening and diagnosis. SIRS, or systemic inflammatory response syndrome, includes tachycardia, tachypnea, hypo or hyperthermia, leukocytosis or leukopenia, or bandemia. And for the diagnosis of sepsis, you need 2 of the 4 plus a source of sepsis. MEWS, or the Modified Early Warning Score, has 6 components, which include tachypnea, tachycardia, oliguria, altered mental status, and then hyper or hypothermia. And here you need a score of more than 5. The NEWS score, which is the National Early Warning Score, core components, again, kind of similar to the other 2: tachycardia, tachypnea, hyperpyrexia, oxygen saturation, which is low or increased oxygen requirement, altered mental status, and hypotension. We tend to use SIRS mainly because it's just easier and I think probably has fewer components to it. All right, so the first component of the guidelines addresses initial resuscitation. In accordance with all studies on sepsis, timely intervention is of paramount importance to the extent that it's considered a medical emergency and warrants emergent evaluation and intervention. In all the large trials of sepsis, including RIVERS, PROMISE, PROCESS, and ARISE, all these trials, the patients received 30 ml per kilogram as an initial bolus if there was any evidence of hypoperfusion. So this remains the recommendation. SMART trial in 2018 was a randomized control trial of over 7,000 patients, which showed mortality benefit and with regards to renal dysfunction with the use of balanced crystalloid instead of normal saline boluses. And therefore, balanced crystalloids where there's increased buffers in the solution, like Ringer's lactate or plasmolide, is preferred over saline, likely because it also produces this metabolic acidosis, but there's definitely evidence that favors the balanced crystalloids. Multiple studies, the largest of which was the 2012 Scandinavian trial, showed the deleterious effects of using heterstarch for volume resuscitation, and more recently, the classic trial, which is a multi-center trial from Europe, showed no difference with restrictive versus liberal fluid resuscitation, but the difference in volume between the two groups was almost 2 liters. However, since it wasn't published before these guidelines, it has not been included, and will probably be included in the follow-up guidelines. So although clearly hypotension needs to be treated, establishing the optimal MAP, or mean arterial pressure target, has been studied with a randomized trial that did not show a benefit of MAP goals of 80 to 85 versus 65 to 70, but did show a high risk of arrhythmias in the higher MAP goal group. A more recent trial on permissive hypotension with the goal of 60 to 65 instead of above 65 also did not show a difference in mortality and did show reduced adverse outcomes on pressors. At the moment, however, the current recommendations are still to maintain a minimum MAP of 65. There is some limited data to suggest that dynamic measurement is superior to static measurements to guide volume resuscitation, of which straight leg raise seems to be the most commonly used. The recommendation to trend lactate is based on multiple retrospective observational data, which showed a mortality benefit, although as an isolated test, it is not specific nor sensitive. Even though it seems like common sense to remove the source of sepsis, the optimal timing of source control has been studied, with the optimal benefit being early and ideally within 6 to 12 hours, with poor outcomes when source control was delayed for over 12 hours. Before discussing the recommendations of vasopressors, especially for the students in the room, it's important to understand the mechanisms of action. If you look at the pressors listed above, as you move from left to right, you notice increasing effects on the beta receptor. Given that the alpha receptors are on blood vessels and result in vasoconstriction, this results in increased blood pressure and increased MAP, but increase in afterload results actually in reduced cardiac output and peripheral perfusion, which could lead to worsening organ dysfunction and lactic acidosis. Hence, phenylephrine is never used in septic shock. Given that septic shock is due to cytokine-mediated vasodilation and myocardial suppression, norepinephrine is an ideal agent where the vasoplegia from sepsis is treated by the alpha agonist effect and the myocardial suppression supported by its beta agonist effect. Dobutamine, on the other hand, causes vasodilation with its effect on the beta receptors on vessels, and even though it increases cardiac output, it can worsen the vasoplegia and hypotension already present in septic shock, and is therefore never used as a first-line agent in septic shock. Vasopressin, which is a very potent vasoconstrictor, has been used in septic shock, but not in a titratable dose, but instead as a replacement of a studied physiologic deficiency, and is usually given as a fixed low dose. Dopamine, similar to Levophed, has vasoconstricting effects on the vessels at higher doses and an inotropic effect on the heart, and was thought to have potential as an initial pressor in sepsis. Now that we understand how the different pressors act, we can better understand the following recommendations and trials that justify these recommendations. Given the physiologic effects of dopamine and norepinephrine, these were studied as first-line pressors. However, meta-analyses of 32 trials showed decreased all-cause mortality and reduced incidence of cardiac arrhythmias with norepinephrine compared to dopamine, and therefore the first-line pressor is norepinephrine. Next, a few trials, most prominently the VAST trial, studied the use of escalating norepinephrine versus the addition of a static dose of vasopressin, and there was shown to be a survival benefit with the addition of vasopressin in those patients on a lower dose of norepinephrine. A systematic review of data showed improved mortality and reduced arrhythmias with the addition of vasopressin and is likely related to the reduction in adverse effects of higher concentrations of catecholamines. When escalating pressures are required, epinephrine has been suggested as the third agent and if there is evidence of myocardial suppression, using epinephrine as a single agent or norepinephrine with dobutamine has been suggested. As explained previously, dobutamine cannot be used as a single agent in septic shock due to worsening vasoplegia in sepsis. There is a recommendation to initiate invasive arterial monitoring when possible and initiating vasopressors via a peripheral line and not waiting for central access. With regards to antimicrobials, the sooner the better is the basic concept, but ideally within an hour in septic shock and within 3 hours for sepsis without shock. The choice of antibiotics needs to be broad spectrum and should cover any potential organism that might be involved. A local antibiogram would be useful to guide antibiotic therapy and understanding resistance patterns. Although, according to the recommendations, the prevalence of multi-drug resistant organisms, including MRSA and Pseudomonas, need to be considered, and the choice of antibiotics tailored to ensure coverage of these. Early de-escalation to prevent development of resistance is recommended, and early or timely discontinuation also reduces the development of antibiotic resistance. And the guidelines addressing ventilation strategies are similar to the ARDSNet protocol of ventilator management and prevent ventilator-induced lung injury and barotrauma by using low tidal volume ventilation, preventing high airway pressures, and do include the recommendations of prone ventilation and ECMO in severe ARDS. Other components of management include initiating stress dose steroids in refractory shock. Prior to 2021, there appeared to be insufficient evidence to recommend the use of stress dose steroids. However, a meta-analysis and systematic review in 2018 showed a benefit with regard to ICU length of stay, ventilator days, and reduction in duration of shock with the initiation of adjunctive steroids. While the famous strict trial from 1999 on all ICU patients transfused with a goal of 7 instead of 10 showed a mortality benefit in the restrictive transfusion group, a more recent meta-analysis in 2019 showed no difference in the two groups, and therefore the recommendation is to transfuse to a goal of 7 instead of 10. Septic shock does predispose patients to stress ulcers, and therefore ulcer prophylaxis is indicated. It also predisposes patients to DVTs or venous thromboembolism due to its effects on coagulopathy. And there is some evidence to suggest that low molecular weight heparin is superior to unfractionated heparin for DVT chemoprophylaxis. The NICE sugar trial from 2009 taught us that overzealous glycemic control might result in adverse outcomes instead of benefit, and the SCC guidelines to suggest goal blood sugars to not exceed 180, which is a pretty liberal target. In conclusion, attempting to implement a protocol which is time sensitive in the early management and identification of sepsis would improve outcomes, and creating a performance improvement program would help collect data and analyze data, which would in turn aid in the improvement of future management. Thank you so much. This is a picture of my class in medical school. You might see some familiar faces among the group there, and I'm open to any questions. Thank you.
Thank you, Dr. Anushka. I think we have 5 minutes if you have any questions, clarifications that you require to ask from Dr. Anushka. We do have some surgeons in the audience, so they may have some questions for you, Anushka.
Anushka, it's Professor Manori. You mentioned that you have to escalate the antibiotics and reduce the duration. What do you mean by that when background of a septic shock?
Right. So what we actually try to do here is we try to take all the culture results, like with pneumonia, you get like, Yale, lavages, all that stuff, like as early as you can. try to honestly, earlier they say you do it for like 7 days or 10 days, but here once you actually get control of the initial infection, you try to escalate or stop it as soon as you get culture data. And that there's some evolving evidence that early discontinuation or definitely early de-escalation reduces resistance or development of resistance. So it's always based on culture data, and that's kind of the problem. If you don't have enough culture data, then you can't really de-escalate it, you can't really stop it. But say you actually start something like broad spectrum antibiotics for pneumonia, and then your BL, your sputum, your deep trachea, your bronchial aspiration, all of that comes back negative or with a much less resistant organism, then you can either de-escalate or just actually stop it once the initial treatment, once the initial is. Obviously, this depends on how hemodynamic is able to there's some improvement. If the patient continues to get worse and they continue demonstrating sepsis, then you will continue. But if everything looks like it's getting better and all the culture data is negative, then actually we stop the antibiotics.
Actually, I don't have a question to ask from you, but I just am Alok. Yeah. So it's very nice to see you. It's very nice to see you. I don't know what time it is there for you. Maybe 3 o'clock in the morning, is it? Yeah.
Exactly.
But you're active as if you've been working. Thank you very much for that inspiring talk, and I'm very happy to have been here, Anushka. Thank you.
Anushka, I am Professor Janani Kotahachi. Now, do you have experience in treating septic patients with steroids?
Right, so that, until I think the 21 guidelines and the meta-analysis that came up, I think it was in 2018, there was very controversial data about it. There was no recommendation because the data kind of was not great. It's just that some people gave steroids, some people didn't. But I think there's definitely it's in refractory shock. So you do like the whole volume resuscitation, start off with your usual presses, and then say you come to 3 presses, and they're still not doing well, they're still requiring high doses of presses, then there is a recommendation to start the non-stress of steroids, presuming an adrenal insufficiency. So yeah, the most recent data does show it's a pooled meta-analysis that there is actually a benefit to
Okay, thank you. Yeah.
steroids.
Any more questions? Okay. Okay. It seems that that's all, Anushka, and I think our time is also up, and the next session has to start now. Wonderful to see you, and it's good to see you all flying the flag of Faculty of Medical Sciences, University of Sri Jawadanapura all over the world. Good luck with all your work, and thank you for being with us today.
Thank you so much.
Once again, a very special thanks to the speakers for joining us and spending their valuable time despite the time differences, and also for the chairpersons for their immense contribution to this event. Ladies and gentlemen, today we shed light on the critical role of clinical trials in advancing modern medicine. These trials serve as the cornerstone of medical research, allowing us to evaluate new treatments that have the potential to save lives and improve patient outcomes. Through immense dedication, clinical trials pave the way for groundbreaking discoveries, shaping the future of healthcare and bringing hope to countless individuals around the world.
To start the plenary, I invite our esteemed chairpersons, Professor Guani Liyanage, consultant pediatrician, and Professor Shamini Prathapan, chair professor of the Department of Community Medicine, on stage.
plenary. Let me introduce the speaker. She's Dr. Isabella Ribeiro, is a medical doctor with postgraduate training in infectious diseases and over 25 years of drug development management experience focused on infectious diseases, particularly drugs for neglected diseases. She's the current director for DNDI, that is Drugs for Neglected Disease Initiative, for viral disease cluster with responsibility for portfolio of HIV, HCV and dengue. Dr. Ribeiro had helped to establish DNDI dynamic portfolio with responsibility for scoping, exploratory evaluation, feasibility assessment, and support and integration of potential new R&D areas for DNDI. And she is working on drugs for neglected disease initiative project since 2005 in projects on malaria, visceral and cutaneous leishmaniasis, and Chaga disease, involved in the development of registration of 2 DNDI available products. So that shows her contributions to advancement in medicine. Let me invite Dr. Isabella Ribeiro to talk on advances in clinical trial methodology, implications for drug development for neglected populations. Over to you, Dr. Ribeiro.
Thank you. Thank you very much. Thank you.
Thank you, Dr. Isabel. And this is Shamini from this side of the world. Right. So thank you for that very interesting and I would say thought-provoking lecture. So the floor is open for discussion. I think because of the time limit, we can take one question. Anyone? Yeah, Dr. Isabel, now that pertaining to Sri Lanka, Sri Lanka, we don't allow phase 1 trials. Because we have to start from phase 2, what would be the advice for Sri Lankans who have to, start off at a phase 2 trial without any phase 1 evidence? And would the proof of concept studies be a good way out for them? Or do you have any other advice?
This is interesting question. I was not aware that you don't allow phase 1 clinical trials. And because this often happens in terms of, so I think the key one is the importance, just the importance of PD technologies, right? Of actually how we formulate actually physiologically based pharmacokinetic modeling can be in such situations, right? Particularly in informing the transition from preclinical clinical then to your phase to phase 2. It is more and more used, as I already indicated before, but actually in this case, it's absolutely critical. I would say, and I'd like to learn a little bit more about that, because it's which way we will learn in relation to but certainly, just to go back, the way you design phase 2 then, phase 2 trials will be very important because then here it's about the numbers, right? And how it's all the safety elements that you will need to embed in your phase 2 to progress the respective medicines.
Thank you, Dr. Isabel, and thank you very much for joining us today. And we hope to hear from you soon also. Thank you very much.
Thank you. It's been a pleasure. And sorry for going through over the time. And thank you for the opportunity and honor to present today.
Thank you, Dr. Isabella Ribeiro, and thank you, esteemed chairpersons, for that wonderful and interesting plenary. Ladies and gentlemen, after an eventful day of sessions focusing on resilience, remediation, and reinvention, we have now reached the award ceremony, which will recognize the brilliance and dedication of our young researchers who have made significant contributions to their respective fields. These awards not only recognize excellence, but also inspire and encourage future generations as well.
We would like to invite the Dean of the Faculty of Medical Sciences, Professor Aloka Patirana, on stage to distribute the awards. We would also like to invite Dr. Varuni Thendamhon and Dr. Aruni De Silva to call out the winners and facilitate the award ceremony.
A very good afternoon. Let me enjoy the privilege of announcing the winners of our free paper session. As the organizing committee, this year we are proud to announce that we received 160 abstracts. Of these, we have selected 82 as poster presentations, 6 as oral presentations, and 6 as rapid pitch thesis challenge. The poster presentation competition was held under 9 categories. And may I announce the winners for category 1, that is microbiology and infectious disease, section 1. The winner of this session was molecular detection of antibiotic resistance genes in farmed prawns collected from selected areas of Sri Lanka. The authors of the paper, Vijayakumaran R, Ratnayaka NS, Bandara RMVB, Karunadasa AKUI, Senaratna KMPH, Farukava T, Amarasiri M, CK, Ruan Patirana G NR, and Gamage CD. May I invite Kumaran R to receive the certificate. The winner of the microbiology and infectious disease category 2 is the paper titled Incidence and Characterization of Carbaminopeas Producing Enterobacteriaceae Isolated from Cancer Patients. First evidence of VIM harboring Enterobacteriaceae in Sri Lanka. The authors are Chaturanga BAG, Disanayaka T, Fernando N, and Vanigatunga CA. May I invite Chaturanga BAG to receive the certificate. The next category is NCD, Pharmacology and Toxicology. The winner of this session is the paper titled Effect of the Ethyl Acetate Soluble Anthocyanidins from the Immature Fluorescence of Coccus nocifera and LPS-induced inflammatory response in endometrial mesenchymal stem cell derived from women with endometriosis. The authors of this paper is Thanna P.C.K. Galhena PB, Disanayaka DMAB, Padmadasa S, Piris LDC, Abesekara A, and Padmadasa C. May I invite Thanna PCRK to receive the certificate. The next category is Health Policy and Medical Education, Pathology or Surgical Intervention. The winner of this category is the paper titled Anomalous Insertion of an Inferior Mesenteric Vein Varix, a Cadaveric Case Report. The authors are Jayaratna MJS, Udayakumara S, Danushkar R, Veerasinghe S, and Amaratunga HA. May I call upon Jayaratna MJS to receive the certificate. The next category is oral health. The winner of this poster category is Analysis of Chemicals Present in Slaked Lime Used with Beetle Quid in Jaffna District. Presence of Carcinogenic Chemical Rhadomine B. The authors include Priyanath H, Edirisinghe EAST, Veerasekara MM, and Jayavira PM. May I invite Priyanath H to receive the certificate. The winner of the category Preventive Medicine and Public Health is the paper titled Medication Related to Quality of Life Among Older Adults Attending Medical Clinics at Teaching Hospital, Kalathura. The paper was authored by Sulakshana UADS, Rodrigo WMD, Disanayaka DMTM, Rajapaksha RMTN, Vijaysurya WAIC, Nisansala MWN, and Senarath NSASN. May I invite Sulakshana UADS to receive the certificate. The winner of the category Clinical Medicine, Quality and Patient Safety goes to the paper titled The Associations of Left Ventricular Systolic Dysfunction with Clinico-Epidemiological Characteristics in a Sri Lankan elderly population. The authors are Ratnayaka BMC, Ile Perum RP, Jayasinghe S, Faushe TN, Jayalath WATA, Palam Panava U. May I invite Ratnayaka BMC to receive the certificate. The winner of the category Miscellaneous Section 1 goes to the poster presentation titled Carbon Dot Stabilization and Photostability as Potential Factors that Alter the Cytotoxicity of Bacterial Silver Nanoparticles. The authors are Karunatilaka DN, Ranuge CTL, Disanayaka SDHS, Miriyahallage MKKM, Jayasekara DMW, Samarakon DNAW, Piris MMK. May I invite Karunatilaka DN to receive the certificate. The winner of the miscellaneous category 2 goes to the poster presentation titled Caregiver Burden Among Family Caregivers of Advanced Cancer Patients Attending Palliative Care Clinic at National Cancer Institute, Maharagama, Sri Lanka. The authors are Dharmakan MD, Senaratna L, Vidana Patirana J. May I invite Dharmakan MD to receive the certificate. That brings to the winners of all 9 categories of poster presentations. And next comes the best poster presentation. This award goes to the paper titled Effect of the Ethyl Acetate Soluble Proacanthocyanides from the Immature Fluorescein of Coccus nucifera on LPS induced inflammatory response in endometrial mesenchymal stem cells derived from women with endometriosis. The authors are Thanna PCRK, Galhena PB, Disanayaka DMAB, Padumadasa S, Puris LDC, Abesekara A, and Padumadasa C. May I call upon Thanna PCRK to receive the certificate. The next award is the Best Oral Presentation. And the prize goes to Step D Research Group from Sri Lanka College of Endocrinologists for their paper titled Are We Giving Enough Attention to Young People with Diabetes? A preliminary analysis of the multi-center database for patients with young onset diabetes in Sri Lanka. And may I invite a representative from Step D Research Group to receive the certificate. So in the absence of a recipient, we will move to the next award. The Best Rapid Pitch Thesis Challenge award goes to the paper titled Microbiological Profile of Pediatric Community-Acquired Pneumonia and Analysis of Pneumococcal Colonization Among Healthy Children in the Colombo District, authored by Gonapola Deniya, GDMC, Disanayaka DMBT, Veerasekara MM, Kaviratna M, Liyanage GHS. May I invite Gonapola GDMC to receive the certificate. That brings to an end of the award ceremony, and may I thank Professor Aloka Patirana and Dr. Varuni Tennakon for their support.
We would like to invite Professor Aloka on stage to speak a few words.
Thank you. Don't worry, I'm not going to take long. We have all been waiting for the conclusion of this debate now. And I think it was yet another successful research conference that we had. And I know that many worked tirelessly to make this a success. And I'm very happy as the Dean that we somehow managed to go through with this despite all the difficulties we faced in the recent past, not having money and having to not having much research work going on. So despite all those things, we managed to have a successful conference, and I think we all gained a lot from it. I wish to thank the research committee led by Varuni and Ilanka and the team for a fantastic event that we witnessed. I think we learned a lot, not from the topics or the lectures. I don't know that everyone gained from every lecture, but some would have gained knowledge from some of the lectures. But for me, it was an experience which I thought was more important. Learning how people gain confidence or seeing how people gain confidence and looking at presentations. And those are the things, and how the organization went on. Everything was a learning experience for me. So I think looking back, I'm sure that students and the junior researchers would have gained a lot from this conference as in the past. Few things touched my mind, and one of them was the keynote speaker, Professor Nalin Disala. I think that was an excellent choice. And his talk, without any slides, was really good and inspired a lot, I think probably all of us. And the most important thing was a message he gave to people who are waiting to go abroad. I think that was interesting and needs to probably people would think twice before a decision is made to go overseas. Another thing that he showed us was that we also can have an endowment fund, because you're all always saying that we have no money, country has no money, there's no way of doing research. No, he showed us how they have done and created an endowment fund with the support of their alumni, which is a really a successful thing. I'm sure we can do that because we have a lot of alumni who are supportive, and if we really show that we can do quality research with the money they are willing to part with, that should be a reality I'm sure. The two new things which I saw in this conference was this rapid pitch thesis challenge, which I thought was very innovative. I was told it was not innovative, but some other universities have it. But I think it was innovative for us because it gave an opportunity for young researchers to present their work in a very short time. So they had to really summarize everything that they have done into, I think, 2 minutes, 3 minutes. And they had to face some tough questions from the judges. And I'm sure I was congratulating the winner of this contest. And I think I was there for her presentation. I saw how she handled the questions confidently. And I think that was one of the main things. And I was telling Varuni that we should introduce such things, maybe not only at a conference, but as a regular event so that all the researchers who are, PhD, postdoctoral PhD students can have an opportunity to present their work maybe on a regular basis, maybe once in 3 months or 6 months, because we have so many people doing research in our faculty. They will probably get an opportunity, and research committee probably could spearhead that as well. And I also enjoyed the debate and was impressed, surprised by the ability of our researchers to trying to convince the audience that going abroad was good. Well, this is a topic which we can debate, but I don't think there's a clear-cut answer to it. It is an individual choice or a personal choice. But it's interesting to see that there are always two sides to it, because everybody will say, go, go, go. It's good to go. But there's always another side. It might be good to stay also. Who knows? Only time will tell. And it's how we take things, whatever we do, if we can be happy, well, either of them should be all right. So it's important thing, as Professor Nalini says, to try to learn to be content. So that's the most important thing. Even if you go abroad, if you're not content, it's not going to help you. So, and what are the other innovative thing we had? I think that that one, and alumni. So that also brought some nice memories to me, because Anushka Kotalawala and Nimanta were two brilliant students who were produced by, brilliant students who went through us. I don't claim to take any credit for their performance, but they were two brilliant individuals who entered our faculty and have really reached the peak that is possible. Anushka, I don't know, you would have realized that she spent 6 years doing internal medicine, but her goal was to be a surgeon one day. She couldn't achieve it here. She was too impatient, so she went overseas. But in USA, she couldn't get into surgery. But she got into medicine, did 6 years, became a consultant, but still decided to do surgery. Spent another 6 years and became a surgeon. So that shows the goal-orientedness, and now she is very happy. Although she did medicine for 6 years and became a consultant, she was not happy with that. Her ultimate goal was to be a surgeon. So now she has achieved it, and I saw her in her face, 3 o'clock in the morning, but still active, bubbly, and the same Anushka we had, I think, about 15, 20 years ago. So that was really good. So that's all what I have to say. Thank you very much for being with us. And thank you for the fantastic comparing we had today. And once again, thanking all of you all and the staff, students, and those all who contributed to make this event a success. Thank you.
Thank you, sir, for those inspiring words. I would now like to invite Dr. Tushari Disanayaka on stage for her concluding remarks.
A very good evening to you all. Now that we have come to the end of the ICM 2023, I sincerely hope you all had a fruitful day and enjoyed this experience of sharing knowledge, experience, and views. As we all know, we are at a crossroads as a nation at the moment. So what is important at this juncture? What is the need of the hour? Resilience, remediation, reinvention, the theme of our conference. I believe the participants of this event had a great opportunity to reflect on our roles and responsibilities as professionals, scientists, and citizens. Starting from a fabulous inaugural ceremony last evening, we listened to an outstanding oration. Today we had an array of interesting, insightful, and thought-provoking discussions and presentations which shared experiences and outcomes of new research. I am sure you all agree that executing an event of this caliber is not an easy task, especially at present time. I would like to take this opportunity to thank everyone who made this possible. First, I extend my gratitude to Professor Uppul Subasinghe, Acting Vice Chancellor, for all the support given throughout. And Professor Aloka Patirana, the Dean of the Faculty of Medical Sciences, without whose guidance and continuous encouragement, this would not have been materialized. Thank you, sir. I am much grateful to all speakers, local and overseas, for their valuable contribution and all authors who shared their excellent work with us. Also the abstract reviewers, free paper judges, session chairpersons, and moderators for their valuable input and time spent. Most importantly, I would like to thank all the participants who made this event a successful one. The chairperson and the secretary of the FMS Research Committee, Varuni and Nilanka, thank you for endless hours spent attending to every detail, seeing it through to the end. Aruni, Shehan, Prasangika, Sitara, and all my colleagues of the research committee, thank you all for the team spirit. A special note of thanks to Dulanji and Asel for excellent comparing and Varuna for editing the book of proceedings. And I acknowledge all pre-intern demonstrators and undergraduate students who helped and contributed in numerous ways. I do not attempt to mention all by names, but each and every one of you are sincerely appreciated. Further, a big thank you to all academic and non-academic staff of the faculty and the university who contributed to the success of the conference. My profound thanks to all our sponsors for making this event possible by their generous and thoughtful contribution. I deeply appreciate our event organizers, Nalin and his team from Impress Events, for living up to their name and for being so accommodative. I would like to thank all our service providers and cleaning staff for their services. Ladies and gentlemen, I am certain that the takeaways from this conference will further nourish our professions and help navigate to the future through resilience, remediation, and reinvention. It's been a pleasure being with you today. On behalf of the Research Committee of the FMS, thank you.
Thank you, Dr. Tushari Disanaika. And with that, the proceedings of the day will be concluded. I will invite all participants on stage for a group photograph, after which we can have tea which will be served at the back.